being here. I'll call the Senate Committee on Education to order. First, we'll have the roll call.
Senator Olson?
Here.
Senator Darling?
Here.
Senator Vukmir? Senator Nass? Senator Larson? Senator Risser? Senator Bewley?
Okay, our agenda today is we were just having hearings. We're not doing any exec. And what we will be doing first is hearing Senate Bill 494 and then 412, and then hopefully we'll be done by 1 o'clock so that we can have a information hearing on mental health issues in the school system. If you'd like to testify on 494 or 412, please fill out a sheet here. I think they're over by the door, and give it to the pages. And this is a relatively busy week and month, and so you may, or you will see, because I'm going to have to leave for a minute, legislators going in and out today because there's a number of committees meetings going on at the same time, and some of us have bills, me included, that are being heard in other committees, and so they may have to step out for a minute to testify, which I will about 1 o'clock. So don't feel that that's because they weren't interested in what you had to say. It's just that a lot of things are happening right now. So if please turn your cell phones on vibrate or off so we don't have any disturbances that way. And the first bill up is 494, which happens to be mine, and I'll turn the gavel over to Senator Darling, and we will proceed.
Oh, excuse me, Senator Olson, I have to go testify in the bill right now.
You're good.
Okay, sorry.
It'll be 1 minute.
Yeah, no problem. Senator Olson, welcome to your committee and to your bill.
It's really great to be here. This is a really simple bill. It's something that expands what was passed in the budget dealing with Montessori teaching licenses. And currently, we allow an individual teaching license to be granted to a person who has successfully completed a teacher education program that is accredited by the Montessori Accreditation Council for Teacher Education. In order to be eligible for this initial license, you must, number 1, possess a bachelor's degree, 2, successfully completed a teacher education program certified by the Montessori Accreditation Council for Teacher Education, 3, successfully complete an introductory course in special ed for which the individual has earned at least 3 post-secondary credits, which is true for all teachers no matter where you come from, and then have earned a passing score on any standardized examinations required by the state superintendent, which is what all teachers have to do also. The goal for this law is to allow people who have a 4-year degree and attended a rigorous Montessori teacher education program to be licensed to teach at a school that uses Montessori method as its primary method of instruction. The thing that you have to realize is these licenses are only good in schools that use Montessori as the main thing. They're not good for other types of educational programming. Most programs that teach Montessori teacher education are accredited by MACT. However, a few programs are approved by the Association Montessori International rather than MACT. To use a Star Wars analogy, and hopefully that people testifying later will agree with me, that the Association Montessori International is sort of like the mothership. It's where it was developed, and then the ones that we approved were sort of like the satellite schools, and so we think we might as well, if you learn from the mothership, that should be equal or better than, and probably some people argue with that, than being taught the Montessori program in the other systems. It modifies the second requirement to allow, in current law, to allow for teachers who receive training at AMI to also be eligible for Montessori license. Modifying this law would help correct the shortage of Montessori trained educators that has impacted many schools, such as Isthmus Montessori Academy here in Madison. That's really all the bill does. We didn't include that in the original bill. It was an oversight, and we're just expanding it. So is there any questions?
Questions of the committee? Seeing none?
Okay.
Did a great job. Oh, okay. Senator Risser.
I don't know too much about it. So what is this international group? Where are they located?
I'll let you answer that question, or ask that question to the next person who's going to testify, because
Right.
they went there, but it's, I think
All right.
it's in Italy.
So you're allowing an Italian group to to certify our teachers?
No, we will certify them. It's just that their training was, well, I'm not going to go down that road, because I'll let them, because everything
right.
I say could be,
I'll withhold my
it's what I
questions.
understand, but it doesn't mean it's fact, so.
Okay. I'll withhold my questions till later.
Okay, thanks.
Thank you. Thank you, Senator Olson. The next speaker will be Phil Dousman and Melissa Dressler. Thank you. Thank you.
Welcome.
Hi, thank you for having us. My name is Melissa Dressler, and I'm here to talk a little bit about AMI, the Association Montessori International. First off, I'm a lifelong learner and an educator. I'm a teacher and an administrator. I have taught in public and private institutions, and I love my job. I made the choice to become a teacher after careful consideration and observation of different educational programs. And when I was presented with the opportunity to go through the AMI program for Montessori teacher training, I opted for that because it can provide a master's in education, along with the ability to teach in any Montessori school in the nation and internationally. Other programs do not provide this opportunity. It's incredibly rigorous. Very thorough, and as I said, it does provide employment opportunities, but the teacher preparation of this program stands alone, especially with regard to curriculum and instruction based on human development and child psychology. I was receiving this training. It was one of the most challenging programs of which I was a part, but also the most rewarding. Like I said, I'm an administrator, and so I interview people every year, multiple people every year, and it's clear to me that the people who go through the AMI training have gone through what we call a teacher transformation. So they are prepared to teach, they are ready to teach, and boy, do they have that fire to teach. And so that's why I'm supporting this part. Thank you.
Hi, I'm Phil Dousman.
I think you got to press the button.
Oh, sorry.
Well, somewhere's over there.
All right, very good. Hi, Phil Dousman from Milwaukee, Wisconsin. I also echo what Melissa said about the rigorous training of AMI, Association Montessori International. There is also a branch of AMI in America, AMI USA, which is main headquarters are in Washington, D.C., and then AMI International is located in Amsterdam, and they purvey over all the programs internationally across the world. We are representing Wisconsin Montessori Association. We're both on the board of the association, and we work with Montessori schools, charter and private, throughout the state. And we initially brought this legislation forward because we felt there was a great need for Montessori trained teachers. I myself was an administrator in Milwaukee Public Schools of 4 of the Montessori programs, of the 7 Montessori programs in Milwaukee Public Schools over my tenure of 30 years. During that time, I coordinated most of the hiring for the Montessori programs. And we were always in short supply of a talented pool of teachers for this program, for the programs. And as working with the WMA now, Wisconsin Montessori Association, we continue to see this problem outstate, not only in Milwaukee, but everywhere, that there's a shortage of these programs, or a shortage of teachers for these programs. So it is our hope, by expanding the legislation to include AMI, we will expand the talent pool that we can draw upon. And it is our hope that this will happen with the addition of this legislation. Thank you.
Senator Risser?
Yeah, I guess my question is, with this excellent training you're getting, why wouldn't you automatically be approved by the Montessori Accreditation Council for Teaching Education?
It is.
Well, if you're, I mean,
Oh,
you still require the current teacher association to approve in addition to, I mean, why is it an alternative? You say the bill says either one or the other. But you tell me that if you get the AMI training, that you're automatically part of the, approved by the Teaching Education Association?
Actually, to clarify.
Is there a conflict there? I don't understand.
No, there isn't a conflict. MACD, which is the Montessori Teacher Accreditation Council that the original bill was approved, has many of the AMI centers in America that are part under the MACD umbrella, but there are some that are not under that umbrella of the AMI centers in America, and many internationally. So we recruit all over the United States because there's such a shortage of teachers in this specialty area. So it is possible that more of the AMI centers in America will come on board under MACD's umbrella, but at this time they are not. And then we're also looking at international training. I was actually trained in Italy, in Bergamo, Italy, my training in 1980. And I found, the training was excellent. We have recruited people from there. We actually have one teacher on sabbatical from Milwaukee Public Schools taking training there this year. And then we also recruit from a center in London and a center in Ireland. And much of that is because of the language, the bridging the language, and those centers all teach the Montessori in English.
Well, I'm all for the Montessori Association and for the educational situation and the teachers and all, but it looks to me like the bill sets up a conflict between the Montessori Accreditation Council for Teacher Education and the AMI. It's because you say one or the other. I don't understand if the education is so good on the AMI, why it wouldn't automatically give you the accreditation you need under the teacher education group.
Senator Risser.
I mean, understand.
Senator Risser, thank you for your question. I think it's more a matter of answering the shortage of teachers. And so what's happening is that there are X number of AMI training centers, which are, they're all wonderful and they're all high quality. And so in order to put those AMI training centers just through the bureaucratic paperwork, it will take years before we get those teachers out of those training centers to be a part of this. So now if we're saying the AMI, which is already there, already qualified, we just haven't gone through the process with MACT, they will go through the process. We just need those teachers faster. So the teachers themselves are qualified. It doesn't, put to question the qualifications of the teachers. It's more about, can you get this institution through that process fast enough to get those teachers out to serve the schools. There are thousands of Montessori schools popping up all over the nation, and it's a wonderful thing, but we don't have enough teachers for them.
Really, if I can jump in, the reason for this bill is that if you went through one of those Montessori programs, either or, before this part became law in the budget, you had to go through our educational training program in our state, which was, they sort of called it the $10,000 license. So they went through all this training, and then our state says, well, that's well and good, but you've got to go through the training we have here to be a teacher to get your teaching license. What we did in the original bill said that if you're trained in the Montessori program at a certified thing, you can get your license in the state of Wisconsin to teach only in a Montessori school. This just adds another institution that trains teachers that is high quality to qualify, if you went there, qualify you to get a teaching license in our state. So it's sort of like saying that it would be sort of like saying, I think maybe, we will license people who come out of the School of Education at UW-Madison, or UW Whitewater and Platteville and all that, but not Madison. Now we're adding Madison to it. I don't know if that
Yeah, that makes sense.
is sort of an analogy. And at the original time we did the bill, we neglected to include AMI.
So in essence, if you're trained abroad, you don't have to, if you're trained abroad, you don't have to qualify, you don't have to meet any state standards at all. You don't even have to speak the English language, do you? There's any requirement you speak the English language? I mean, I don't know.
Yeah, you do. You have to pass you have to have a bachelor's degree.
Huh?
You have to completed one of these courses. You have to take a class in special ed, and you also have to pass a standardized test that the superintendent says is all new teachers have to do. So you have to do take the examination and things that regular teachers do. It's just that we are acknowledging the Montessori training as equivalent and good enough to teach in a Montessori school without having to go through the whole process again. And Senator Bewley.
Thank you. Thank you for your help in clarifying this. I want to make sure I understand fully. So of the 4 items that you have here, what we're doing is we're taking number 2 and we're saying Montessori Accreditation Council or. But the other 3, bachelor's degree, introductory course, passing score, all of those still hold. Okay. And you are saying that the AMI schools that are not currently accredited by MACD are in the process of doing so.
As far as I understand it.
Okay, okay. And are you able to say that the training at the MACD accredited schools are identical to the training curriculum coursework at AMI?
Well, I'll be honest with you, I can speak to AMI. And so, and I know the MACT process because I serve on a board of a training center that is MACT accredited.
Okay,
So, MACT is all-encompassing of the institution, meaning not just the curriculum that the students go through to become teachers, but also the operations of a training center, such as the budgeting and the, what you go through with your employees, everything that involves the institution. So, as I said, there are some training centers that have, for instance, right now, 2 employees because they're trying to answer the need of getting the teachers trained, but they don't have the big enough staff to require, and also cost quite a bit of money, so to require going through that process at this time. However, if it's an AMI accredited training program, it's the best kind of Montessori that you can get.
okay. So what you're saying now makes me conclude that AMI is teacher training to be a Montessori teacher. MACD now has a curriculum that would include teaching and administration on how to set up a Montessori school and run one?
No, it views the training center as an institution, so as the school. So they're looking at all the pieces of.
I see what you're saying. Okay. Okay, all right, I understand now. Thank you.
Any other questions? If not, thank you very much.
Thank you.
And I think that concludes the testimony on 494. The next bill is 412, and we have the author, Senator Jerry Petrowski, speaking in favor. Welcome, Jerry.
Is this mine or yours?
Good afternoon, Honorable Chairman, honorable members of the Education Committee. Thank you for the opportunity to speak on Senate Bill 412. This past March, a constituent of mine suffered a massive heart attack while riding his bicycle. Without the quick thinking and action of 3 CPR-trained teenagers who happened to be nearby, he would not have survived. This incident has prompted me to author Senate Bill 412 in the hopes that we can provide crucial hands-on CPR training and education to as many youths as possible. Under current law, each school board, charter school operator, and private school governing body that operates a high school grades is required to offer but not provide instruction in CPR and to provide instruction about automated external defibrillators to their students. The problem is, although schools are required to offer this instruction, it does not always translate into students partaking in the training. This bill makes a couple of changes that will help ensure that as many youths as possible are receiving this training. First, instead of requiring the instruction for high school age students, it requires that schools provide instruction in CPR and external defibrillators to students in grades 7 through 12. The second change to the bill is to specify that the instruction be included as part of any health education course offered to pupils in grades 7 through 12. It is my understanding that this training can be completed in roughly 30 minutes and that 20 states have already passed similar legislation. I think it is important to clarify that Senate Bill 412 does not require schools to implement any new health education courses that they are not already providing. Also, please note that the bill does not create any graduation requirement. If a student is absent or transfers to a school after the training has taken place, there is no penalty. We have worked very closely with the Heart Association on this measure and are confident that this life-saving legislation will help to make our community safer and improve survival rates. We have also tried to work with everyone, DPI, School Boards Association, the administrators, to come up with something that everybody, I think, either can support or can at least be supportive of. I think the main thing in realizing this is that many schools are already doing this, and the fact is this will save lives across our state. Thank you, Mr. Chairman.
Thank you, Jerry. Just a question. Right now, you have to offer it. They don't have to take it. This bill would say we'd expand it 7th and 8th grade, and it would be embedded in a health course that students have to take sometime during their career.
Right.
And if you wind up taking 3 health courses, I don't know if you would or not.
I think one is only mandated.
Okay, but let's say I took 2, it would be embedded in each class.
Well, I think that's true, Mr. Chairman. However, I think, a lot can be gained by repetition, by learning by repetition. The Army focuses on that, military focuses on it. I'm sure that the Heart Association, DPI, will probably address that issue. We didn't want to make it any more cumbersome than we had to about having a form that everybody would have to check that they already had it or didn't have it. So I think this is an opportunity for, maybe it's repetition, maybe it isn't, but I think the bottom line is, over a period of time, kids probably, their memories fail a little bit, and a refresher course sometimes is very good.
Any questions?
Just one question. By the way, I think it's a good bill. I'm a co-author of the bill. But is there any penalty for failure to do this?
Not that I know of, Senator, because it's not a mandate for graduation or anything. Our goal is really to educate as many young people as we can with this life-saving ability.
As I say, I think it's a good bill, and I'm a co-author of it, but I was just wondering if you had any power besides the act of persuasion.
Maybe somebody will address that. I don't think there's anything in the bill to force the issue, but I think it is something that will pay dividends, and I thank you for signing on, Senator.
Okay,
No question.
Senator Bewley.
So there seems to be a distinction between the terms provide and require, provide and offer. What's the difference between offer and provide?
You know, I think Luther summed it up real well, that when they're offering a course, there is no mandate to take it. By putting it in as part of the health course, they have to take the health course, at least one health course for graduation.
So it is required to graduate.
No, it's not a requirement for graduation, it's just a requirement that it's part of the health class.
But if the health class is required for graduation,
Yes. But that
so
segment
de
is-
facto, it would just follow, I just want to make sure I understand, I'm truly not arguing. If you are required to take the health class,
Right.
and this bill says the health class must include this new instruction,
Right.
doesn't it follow logically that this instruction is required to graduate?
No.
Why not?
If students were missing at that day that it was given, then they wouldn't be able to graduate until they took that course. I don't think that's what we'd want to do. If somebody transfers in from a different school and happens to miss that portion of the health class, by making it a requirement of graduation, I think you would make it a lot more cumbersome for the school districts to make sure that every student had that. And we didn't want to go.
So this is like the furthest you can go to see that as many students as possible get this training without going so far as to saying you can't walk across the stage and get your diploma because you don't know how to do this. Is that correct?
I'm not sure I would characterize it like that, but I think you're on the right focus.
Okay, thank you.
Yeah, Ledge Counsel, she has something to add here, I think, that can clarify this a little bit.
Well, I just wanted to say that there's nothing in the bill that makes taking this particular training a requirement for passing a health course.
Thank you.
Senator Doss.
I think it's good that you don't have a graduation requirement. Schools have enough to deal with now. One of the disappointing things, I'll quite frankly say, regarding the mandate aspect, and that's directed to my comments to the Superintendent's Association and the School Board Association, we get repeatedly banged up for not providing enough money for mandates. The Superintendent's Association is supporting the legislation. Admittedly, it is going to cost money. The School Board Association is neutral, and again, this is more so directed to them. Then they need to keep quiet about mandates if they're going to ask for more and be okay with this mandate. So, to the bill, and in the schools, and what the superintendents and school board members have said, when the legislature has additional mandates, their core responsibility is reading, writing, math, turning a kid out that it can survive in the real world. And when you take away from that, it's not good. Another item that has come forward is financial literacy. I would argue that probably financial literacy is going to affect way more people than the CPR training. Someone may use this and probably will along the way. There's numerous ways you can get training right now. So financial literacy is another one that perhaps will rear its head again. It has for several years here in the legislature, and we've turned it back because of the cost and the taking away from classroom time. I guess to the bill itself, since now the superintendents are okay with it and the School Board Association is not opposing it, is the cost aspect. Not huge. When I met in my office, I believe it was the American Heart Association, and I do see in testimony they're prepared to step forward with $75,000. What I would like to see in the bill to make sure it happens is that, and I guess I would like your feedback on this, is that because it is a mandate, a school district that does not receive the initial funding to pay for the various things that the Department of Public Instruction has pointed out, disposable plastic airways, lungs, cleansing wipes, and so forth, the mannequins, that they don't have to do it because of the mandate aspect. Heart Association says they're going to step forward. I would like to make sure that happens and say that if a school district doesn't have the Heart Association step forward, or some group, could be a fire department, hospital, funding them initially, that then they don't have to do it, if they don't want to.
You know, I I know that there are a number of school districts that already offer this.
Mhm.
And I know that the Heart Association is looking how they can be supportive of this, whether it would be making available these devices through the CISAs or to regions or through different high schools or however. And I think they will probably address that in their testimony. I believe that in schools, you go for training, and yes, the financial literacy is really an important thing in the world that we live in, because whether it be the amount of student debt that a person acquires or just being able to manage their affairs, there's probably more that needs to be done. But I think the way we have designed this bill, it's not intrusive near as much as we could have made it. Our goal was really to try to get as many people trained with CPR that we could, because we know, and you can, I know that there are people around the state that are living today because teenagers have gotten this training in schools. This guy in my district who had a heart attack, a massive heart attack, who was riding his bike, I'm sure if you talk to his children, his wife, on how they would feel and how important this was in school, they would put a high priority on this. Is it beyond writing and arithmetic and all of that? Yeah, of course it is. But I think it's an opportunity. And I think it's an opportunity that we should probably march forward with. We have worked with all the organizations that you have talked about to get them to a point where it was doable, where they felt that the cost would not be too excessive, that it would not be intrusive in the course that they're offering. And it is only probably a 30-minute course to learn CPR. Why wouldn't we want to do it, Senator?
Actually, it may be beyond that. Even the Department of Public Instruction says it may take several sessions. So the 30 minutes, maybe, but maybe not. And it's a laudable goal, and I think it's probably going to pass. The mandate aspect is concerning, that, and that's why the School Board Association and Superintendent Association, I think in the future, needs to remain quiet on mandates. They're inviting this. And are there good things that will come out of it? Sure. The bigger issue, let me put it this way. We've had bills come before the legislature that have not made it. And I have heard, if we can save one life, well, then we ought to outlaw bicycles. We can save a lot of lives. Outlaw cars. Make all houses one story so people aren't falling downstairs. I mean, that can go to a point, and it's a laudable goal, I admit, and it's good that somebody's life has been saved. So I'm just trying to get at the financial aspect of it, and making the point that on the mandate issue, that there's only so much classroom time. Is it going to save lives in the future? I'm sure it probably will. There is some point where the legislature has to, it's our obligation to look at the financial aspect, especially as we get hammered on mandates. Let me ask this question, and maybe better for the Heart Association or whatever, in case you want to pass it along. Not that you don't have it. How long is that certification good for? Because it's been mentioned a student may go through this training a couple times. So I guess once you go through it, how long is that certification good for? And can that student then, instead of spending that time, whether, even if as a DPI mentions it may be several class periods, spend that time working on homework or going to the library and working on homework or doing something else instead of going through repetition once again, if that certification?
I don't think that it's going to be the norm where they're going to be at this more than, so many times. I think that would not be the rule, but it could happen. And I don't think there's a time limit on the certification unless something changes dramatically, and sometimes in medicine that happens. But I think it's, Senator, the training by repetition, if it takes more than 30 minutes, if they go through it again 4 years after they initially took the course, is that a bad thing? I don't think so.
I'll ask the Heart Association. My question was, how long is a certification good for? I guess we don't know. One of the groups testifying may know. That's-
I would ask them, they probably do know.
Okay.
And I understand what you're saying about the fiscal problem with not having enough money or the complaints that we receive. I do understand that, Senator.
Well, I guess what's frustrating also, and maybe the Heart Association will say it's okay to put an amendment in. Our word is good. We are going to pay for it. Okay. I don't know that I'm going to hear that, because then we could put it in the bill and everybody would have that comfort level, including the Superintendent's Association and the School Board Association, that at least initially, the upfront costs are going to be covered. Thank you.
Okay. Senator Bewley.
Just one final question, Senator. I want to be able to vote for this. I really, truly do. I did not sign on to it because it's an unfunded mandate. And I heard from the school districts in the north, pretty rural, all rural, that it is a burden. It is a burden, and they would be hoping for some way to get financial relief for it. I understand that the Heart Association is coming forward with money to help. I don't know if 100 kits would be enough. And without, I'm not asking you to say yes or no, but I want to agree with Senator Nass, although I want to suggest perhaps if they do not get the money that they need to get the kit or use the kit in a given year, would you be agreeable to some sort of language that would say you can ask for a waiver for that year, just so that we know, or for the next school year, until they know they can get the kit? Because if they can't, if they're not in line, there's not enough kits and they don't get it, what are they going to do?
If DPI would ask for that, or, one of the groups that we talked about, I don't have a problem with that. Our goal is to try to get as many people as we can trained.
Okay, thank you. Thank you very much.
Okay. Thank you very much, Senator Petrowski. Thanks, Jenna.
Thank you, Mr. Chairman.
Up next, we have a group testifying together from the American Heart Association. We have John Raymond, Nicole Hosdinsky, and Jay Carter Ralph.
I assume you wanted to be together, but if you didn't, we're still putting you together.
Am I on? Okay. Can you hear?
Tap it and see what.
Okay. Good afternoon, Chairman Olson, members of the committee. My name is Nicole Odzinski. I'm the Government Relations Director here in Wisconsin for the American Heart Association. Today I'm joined with two of our board leaders.
My name is Dr. John Raymond. I'm president of the American Heart Association Board in southeastern Wisconsin, and also president and CEO of the Medical College of Wisconsin.
And we are here today to testify in support of Senate Bill 412, ensuring that all students learn basic compressions-only CPR before they graduate. I'm going to go off script a little bit here, just based on some of the questions that we just got, and just explain the difference between certification and what we're talking about here today. There is a class and a certification which is much more comprehensive of a CPR training. It's something that we definitely recommend for medical professionals, for our EMS and firefighter friends, for anybody in the professional medical world that's doing CPR. But what we're talking about here today is much more basic of a training. There is no certification that goes along with it. It's really just basic exposure to the general mechanics of doing CPR, but it's not nearly as in-depth as what we'd be asking our medical professionals to be going through, which is a 2-year certification class. So I hope that answers your question. But back to the written testimony, we're here to testify in support of Senate Bill 412. Our goal with this legislation is to both save lives and also to give our youth in the state the skills that they need in order to respond and react in a cardiac situation and be those lifesavers out in our communities.
Thank you for allowing me to testify. Each day in the United States, approximately 1,000 people suffer from cardiac arrest outside of the hospital setting. Of those witnessed by another person, less than half receive CPR prior to EMS arriving, oftentimes because the person witnessing the arrest really doesn't know what to do. This leads to a dismal survival rate of only 11%. we can and must do better. In fact, recent studies published in the New England Journal of Medicine and the Journal of the American Medical Association demonstrate clearly that bystander CPR, any type of bystander CPR, saves lives. So we're not talking about full certification, but truly just a 30-minute exposure to simple principles of assessing the patient, asking for help, and starting hands-only CPR. Cardiac arrest is a leading cause of death. It can happen anywhere, at work, at the gym, while out shopping, and most commonly while at home, where we spend most of our time. It strikes suddenly and without warning, and what happens in the first few minutes can mean the difference between life and death. We heard the anecdote about the bicycle rider who was resuscitated by 3 nearby teenagers. I can tell you that there were 2 episodes in Milwaukee of people suffering cardiac arrest after shoveling snow last Monday night. There were no bystanders to help intervene. This really is an issue for the entire state. To survive a cardiac arrest, CPR must be started promptly to keep blood flowing to the brain and vital organs. Sometimes first responders are nearby and can respond quickly, but many times, especially in the northern part of the state and in low population density areas, this simply isn't a reasonable expectation. It may take 5, 10, 15 minutes for first responders to arrive. By then the damage is done and there's very little likelihood for survival. So we really implore this committee and the full Senate to take into consideration the life-saving potential of a simple 30-minute CPR class. Thank you.
So we focused on the schools. We focused on the schools as a excellent place to offer this training. The compression-only CPR is a simple procedure to learn. The 30-minute exposure to this basic training has shown to be adequate in allowing children to understand the basics of CPR and overcome their apprehension in providing that kind of intervention and help if it's needed. This is a curriculum that can be embedded within the already existing healthcare curriculum. So it's already within the health class, so it's not a new class that's being added. It's just a portion of the existing class structure. Many schools across the state already have model programs in place, and some of them team up with their local fire departments and EMS agencies. And others work with their local hospitals, physicians, other groups to help out. There are schools like Hayward High School that have their own equipment already in place, and they already have trained faculty. There are many, many models that we can use to implement this, but we believe these programs can and should be replicated in schools throughout the state. The AHA is very involved with the implementation phase, and we're partnering with police, fire, EMS, and several other community resources willing to help in their local communities to provide this training. Additionally, the AHA, as you've heard, is committed to putting $75,000 in place to buy mannequins and provide the training DVDs throughout the state to help these schools implement the training.
As Senator Olson said, Wisconsin is not alone in considering efforts to train youth in CPR. To date, 27 states have passed similar requirements, adding thousands of lifesavers in their communities each year. If passed here in Wisconsin, we'll add almost 60,000 CPR trained individuals to our communities each year. And this training takes less time than it takes to watch a sitcom. With regard to the cost of a kit is about $625. It can be used for multiple different trainees over multiple years. So this would not be a recurring annual expenditure. And I have indicated to the American Heart Association that Medical College of Wisconsin's Advancing a Healthier Wisconsin Endowment is willing to entertain a grant proposal from a certified not-for-profit organization to fund whatever kits are necessary to provide this life-saving training to every high school student in the state of Wisconsin.
The medical community is pretty united in agreeing that this is worthwhile and necessary to pursue. This past June, the Institute of Medicine released a report that showed after surviving cardiac arrest that one of the major recommendations to improve our chances of surviving is to train our youth in the provision of this hands-only CPR.
And one last point we want to make is that this isn't just about saving lives. Of course, that is important. That is a very high priority for us. But this is also about giving our youth the skills and the confidence they need to step in and help in a medical emergency. We hear from volunteers and people we work with all the time that they witnessed a cardiac arrest and they didn't know what to do. And that feeling of helplessness can haunt you for a long time. There's a lot of what ifs that go through your mind. What if I would have known what to do? Would I have been able to help them? And with this bill and being able to train our high school youth, we can give them the skills and the confidence they need so that they're able to step in and don't have to have that what if their life does bring them in a situation where they are faced with a cardiac arrest and they're the only one there to help. So in conclusion, we strongly support Senate Bill 412. We are asking the committee to support it also. It will substantially increase the number of CPR-trained individuals in our state and in our local communities ready and able to help when, like we talked about, sudden cardiac arrest, nobody sees it coming. You don't have warning signs. You don't know that you're any more likely than anyone else sitting in the audience to experience it. And this bill will put more people in our communities ready and able to respond when the situation arises. So we ask for your support for Senate Bill 412, and we welcome any questions you have.
Just a quick question. Trying to get the logistics on this. How many kits do you think are out in the state right now?
That's really hard to answer. We would only have an estimate, and we don't even have a really good estimate about what the AHA equipment is, but there's Red Cross equipment. You're going to hear from several of our fire and EMS partners that are here today. They're in the schools. They're bringing the equipment that they have because they all have equipment too. We have hospital partners that are here who have their own equipment that they bring into schools. That's, I think, part of the reason why it's so hard to say this is how it's going to happen. There's not going to be a one-size-fits-all model here, and that's part of our plan. Again, when Senator Petrowski was talking about our work with the superintendents and the school boards and others, trying to design this in a model that's as flexible as possible to allow schools to decide for themselves, how is this going to work best in your school? We want to make sure it's happening. We're going to embed it in the health class. Other than that, you guys decide how you want to do it. We have all these partners out across the state ready and willing to help. AHA is going to put mannequins and training DVDs in each of the CISAs, so you can kind of check them out like a library book if you want. And we're seeking out grant opportunities and philanthropic opportunities for schools.
That's what I was driving at, is every school wouldn't have to have its kit and mannequin. CISA could have it, and you could sign it out for a week or however long it takes, send it back and go to another school. So the cost of this, I would think, unless the school says we want our own, that's up to them. But if you didn't, there should be enough money in the system, and what we heard from you, that there should be plenty of kits available at no cost to school districts. So it really isn't an unfunded mandate as far as buying anything. It's unfunded mandate on time, but we buy time. So that's what the state does, is pay for time. So as I see the partners that are going to testify and you folks, it appears to me that a reason not to be a school be able to do this is not that there's not a kit, because there will be a kit available that you can use to teach kids during that window that you're offering this health class. Is that correct? Okay. Questions? Senator Bewley.
Thank you very much. And I'm hoping that by the time this hearing is over, I'm going to be 100% convinced that money is not going to be a problem. So I'm 99% of the way there. Help me with my very, very last fear. And it's a silly one, so bear with me. Tell me that I should have no concern about an overzealous 225-pound football player deciding that I'm having a heart attack and is going to do CPR on me. He's not going to hurt me, is he? I mean, not necessarily a he, a she, or anybody. What is the risk of someone who's not, certified, ready to go, doing anybody some harm, breaking ribs or whatever?
It is a possibility. We can't deny that. But the 30-minute training should allow this child and this teenager to leave the course with a basic understanding of when to apply this skill and when not to. And what we found is that when it's necessary, the provision of CPR absolutely saves lives. So we want them to err on the side of saving a life. But they will receive that kind of basic training and information.
Yeah, I guess I'd trade a broken rib for being dead any day of the week.
We tell people all the time that doctors can fix broken ribs. They can't start a heart beating
Can't fix
again.
dead, yeah. Senator Noss.
Yeah, back to the cost question Senator Bewley brought up and myself. And I actually did this training when my daughter was probably 13 years old. Our local fire department did it. It was, I thought, a good thing to do. So on the cost aspect, and a waiver may be a possibility that if, and I have no doubt you're well-intentioned, but if enough of those kits aren't brought forward in the school districts and to mitigate my hearing in a year or two, you guys strapped us with this CPR training and defibrillator, and it'll probably be a moot issue, but if the waiver aspect were put in there that if a school district didn't get the kit, didn't have access, or they had to buy it, and they probably would go ahead and buy it, I would guess, that they could then get a waiver at least for that year or that period of time until somebody stepped forward. And I suspect if they contacted you guys, you'd probably step forward and say, we'll cover you. But there are well-intentioned bills that go through here that end up not ending up the way we expected them to. So I don't know, I just wanted to get your, that waiver aspect. I think it'll end up most likely, from what I've heard, being a moot issue, but then legislators are covered, and that mandate issue and the cost and so forth.
And I think it gets back to what Senator Olson was saying too, is that there are going to be so many different avenues for schools to access mannequins, whether it's using the mannequins and the DVDs that we're going to place in the CISAs, whether it's teaming up with the local fire department or the local hospital. I would be concerned about what the threshold is as to how hard a school would have to work. I am very, very confident. Included with our testimony is the list of all the stakeholder groups that we're working with that are very ready and willing to help their local schools implement. There are resources out there. I think a school would be very hard pressed saying that they can't find anyone willing to help them and that they don't have access to the mannequins that AHA is placing in the CISAs. That I really don't see that happening. We also, as an organization, we speak for people that are going to suffer these cardiac events and strokes and their loved ones. And speaking for that group of people and needing trained individuals around us to be prepared and ready to respond, we really do believe strongly that every high school student needs to learn this, and there is the equipment out there for schools to find the mannequins and find people willing to help them do the training.
Okay, so the answer is no. I guess I had hoped to hear that, okay, Nas, we're going to show you, you put your waiver in, and in 3 or 4 years, we're going to come back and tell you we told you so. But I didn't hear that, which creates doubt. Thank you.
Okay, John.
Any further questions? Thank you for your testimony. Appreciate it very much. Thank you.
Senator Nuss, if I could just correct one misstatement. It was Senator Petrowski who
Okay.
cited, not the
Sure.
other states legislature, not Senator Olson. Thank you.
You're welcome. John, I think it's COYW, from the Wisconsin Fire Chiefs, and Robert Whitaker, North Shore Fire and Rescue, Brown Deer. Speaking in favor. Could we get, before you start, I got the 2 slips, but just so for the record.
Should have a slip for
Okay,
Dave Bloom.
you're good. Okay, thank you. Whoever wants to begin.
Sure. Good afternoon, and thank you for having us today. I'm Robert Whitaker. I'm the fire chief at North Shore Fire Rescue. We serve 7 municipalities on the northeast side of Milwaukee County, recently celebrating our 20th anniversary of a consolidated fire organization. I've been with North Shore Fire Rescue for its entirety. and prior to that, for several years, doing EMS work at other places in the state. Throughout the career, I've been a paramedic and an EMT basic. And the unfortunate reality of careers that we have and many other health professionals have is at times you hear and see unfortunate outcomes, but at times you see positive outcomes too. Always looking to achieve those positive outcomes, as has been testified already, and I won't repeat, there is significant data that would show victims of cardiac arrest who receive bystander CPR prior to the arrival of EMS, their survival chance doubles. And that's national statistics, and it has been backed up. Just recently, I did some research in Milwaukee County. That number stands as survival doubled in 2014 for people who received bystander CPR as opposed to those who didn't. So Senate Bill 412 would ensure, as has already been testified, that all youth who would get through grades 7 to 12 would receive the hands-only CPR training, which, as has been testified, and I understand there may be other opinions, takes about 30 minutes for us to accomplish when we do it for bystanders or the citizens. In my career, I've seen the difference. I would just call one call that I had, a late 20-year-old male playing basketball at Nicolay High School in Glendale. As he went up for a layup, suffered a cardiac arrest, and fortunately his co-players or his players that he was playing with had been trained and jumped into action, and he's walked out of the hospital as a survivor. I've seen many other stories like that, and those people, he was lucky to have people with him that were trained in CPR. I know there's been a lot discussed about the impact this has on the school districts and the school systems, and in our area, we are committed to work with the school districts and school systems, and as soon as next week, begin working with the Whitefish Bay School District to have all of their freshman class go through a hands-only CPR training that they have come to us and asked us to provide to them. So we have already reached out to other superintendents and school districts in our area, and they are very supportive of implementing a similar program, and we're working with the local school systems to do so. So in the end, I would ask for your support and testify that we, as the fire service and EMS providers, are looking to assist these school systems and districts with providing the training or the resources they need, whether it be firefighters and EMTs or borrowing our equipment and things like that to make this possible.
Thank you. Gentlemen?
Thank you. John Cohen, Fire Chief, City of Greenfield. I'm in Milwaukee County, also the Milwaukee County Fire Chiefs and Wisconsin Fire Chiefs Association. I believe they're going to pass out, you hear a lot of statistics. This is a really important actual happening to our fire department, our community, and obviously to a family. I don't know if you have the paper in front of you, but the incident was last February 1st, Super Bowl Sunday. Milwaukee had a snowstorm, and American Heart just talked about 2 people not surviving a snowstorm. Our paramedics went to a house. A gentleman had sudden cardiac arrest, and in the midst of shoveling, they ended up shoveling the driveway, and that picture went viral across the United States and internationally. That was great, but really the reality is there's a person behind that picture. And if you flip the picture over, you'll actually see that the gentleman survived. And that's only, I believe, because, and as a disclaimer, it was not a high school student, but it was his wife that performed hands-only CPR. The American Heart just talked about 5 or 10 minutes. Those are amazing times if you think about it, because when you factor in 5 to 10 minutes, it's for someone to call 911, the dispatcher to take the information, the firefighters to ready themselves, get on the rigs, and respond to the scene, and once they get to the scene, to gather their equipment and get to the patient's side. Last night, I looked at our call that our resident survived, and we did amazing. It was 3 minutes and 22 seconds from time of call till the time our paramedics got to the scene. Again, you have to add roughly a minute for our firefighters to get out of the rig, gather their equipment, and get to the patient's side. So generally 5 minutes. That's an amazing time. If you can imagine, and I won't use you, I'll use me falling over right here today, how long would it take from the Madison Fire Department, waiting at the curb, just to get up to the 4th floor of the Capitol? We need this legislation. Our paramedics need to have patients that are survivable once we get there. We have taught a generation to call 911. We now need to move to the next level of, while they're waiting for us to get there, they need to do something. And we feel it's imperative to start at the high school. So just as we've been successful with fire education, and we've educated a generation on fire education, and we're seeing less fires now, that in the future, as we bring out 58,000 people that know hands-only CPR, we will have more patients walking into our fire stations and giving us a thumbs up. So I appreciate being able to testify today. I obviously support this bill. And I guess the last comment I'll make is that I hope that many fire and EMS departments around this state embrace this. There are many fire and EMS agencies in this state that are struggling because they need volunteers. They aren't all paid professionals. And instead of this being an encumbrance, I hope that they use this as an opportunity to get into the schools and recruit people and strike up a conversation on how they can benefit their communities even further through volunteering for their local fire and EMS departments. Thank you very much.
Thank you.
Senator House Committee members, thank you for the opportunity. I'm Dave Bloom, representing the Wisconsin State Fire Chiefs Association. American Heart Association and my colleagues have covered most of my comments. I provided the comments in writing to you. Just a couple of points. The CPR has gone through a lot of research in the last 5 to 10 years, and there's, as you've heard, tremendous upgrades in how CPR is performed now, and we're having tremendous successful rates, but we need to increase those success rates. And as you've heard, the state fire chiefs support this bill. We hope that you support this bill. And I can tell you from the other conversation and the financial end of the equipment that I don't know of too many, if any, of our members that would not provide equipment to the schools and even the training to the schools to get more members and more residents of Wisconsin CPR trained and able to handle a patient until we arrive on the scene. That's my comments. Taking questions.
Thank you. I suppose if there's one drawback to the hands-on only CPR is that you cannot give it to yourself. So that would be helpful. Senator Darling.
Thank you, Senator Nelson. I have to say welcome to my police chief in my district, Chief Whitaker. Thank you for all you do, and the rest of the chiefs, thank you for all your service. And I agree this is a really important issue. The question that I've been asked by my school districts, I think were ones that you brought up, is this another unfunded mandate? And they are kind of up to their eyeballs with a lot of mandates right now surrounding testing, curriculum, and way too many mandates from the state. And I know that Whitefish Bay is a real leader with using their gym classes to zero in on health. So they teach the kids how to take their blood pressure, how to eat healthy, how to exercise, and they put their gym programs through the rung of healthy lifestyles and decisions. So I could see them using their gym class time for that half an hour or whatever it is to use that. That's very good. But some of your financial contributions will be greatly appreciated, so they don't have to deal with that. The training of their staff would be an issue, but you're obviously talking about filling that need. But a lot of other school districts do not use their gym or PE or whatever they call those programs, use that for a lifestyle, health-based education. They're more into the traditional, let's learn volleyball today, basketball tomorrow. So when you go around the state, I hope that you can talk about how the Whitefish Bay model is really a positive one and has had a lot of positive outcomes, and this training would be appropriately fit there versus another add-on program. So that's just my suggestion, that we look at broadening the education of how this service can be delivered. So it's just a comment more than a question. But thank you for all you do. I really appreciate it.
Thank you.
Senator Bewley.
Thank you very much. And again, I want to assure you and everyone that I am really in support of this bill, despite what I'm about to ask you. And that is that you represent an area that, obviously, you were able to get to the capital, but I represent the most remote rural area of the state. So my first question is, could you comment upon what you would assume the fire chiefs in Spooner? No, they don't have, well, they do, but they're all volunteer. I have 3 full-time staff fire departments in my entire 7-county district, 3. And the rest are volunteers. And so I don't know what the fire chiefs up there are going to say about this. I didn't have a chance to ask them. But what would you say, just from your experience? How would you be able to say, all those fire chiefs up there, they're gonna, yeah, you bet, we're gonna try to help them out. What?
Obviously, we are a state organization, and it's up to an individual organization to support or not. I do see, I've been doing a little bit more with political work, but if you notice that this bill has a diverse range of support, it's not just the fire chiefs. It's the police chiefs, and when you can get the police chiefs and the fire chiefs to agree on something, that's pretty monumental. And then you add in the hospital systems and the healthcare systems. We were up here recently for a lobbying day, and I sat with people from my area, and it was a nurses association, and they are excited to get on board. So it's very difficult, I think, for us to answer for individual organizations, but I think the groundswell of support from multiple organizations is going to be there because they see the benefit. And I think AHA and Chief Whitaker talked about the negative sides of what we often see. We really want to see a positive impact. And how do we do that? We put our efforts on the front end in educating people in prevention and how they can be better prepared for emergencies. So although it's difficult, I think the support is pretty varied and widespread, not just within the fire chiefs, but through a lot of partner organizations, as you can see at the top of who's supporting this bill. I don't know if I answered your question. I have a tendency to do that.
I would just comment that as you stated, you only have 3 full-time departments. The majority of them are volunteer. And the reason those volunteers are there is they want to make a difference in their community. And I think they'll welcome this training into their schools and have those new graduates working in their Northwoods area available to do CPR when it happens near them, so that they can continue that life until emergency resources get on the scene.
Again, I agree. I know that in every corner of the state, the spirit is going to be very, very, very willing, but in some cases, the wallet is weak. And the volunteer departments that we have in rural areas, someone who is a volunteer first responder or a volunteer firefighter will be mounting a campaign to raise money, begging for money for their own departments, and then find out that they're coming home, somebody's coming home from school and saying, Mommy, Daddy, we have to raise money to participate in this. Isn't that great? Well, of course it's great. Of course it's wonderful. And the groundswell that you're talking about, I know that it's there. But I very quickly looked. We have testimony from Wausau and other places, and I looked at the American Heart Association. Incredible organization. It has offices in Milwaukee and Madison. And almost everything here has telephone numbers with 608 and 414. And so the range of great enthusiasm, I believe, is out there. But what's in this room is Wausau and South. And I need to be able to know that, I want to know that when I vote yes on this bill, it's going to take care of my people. And I don't know that yet.
I think it's important to recall what the AHA testified about a little earlier, is that the bill intentionally wasn't designed one size fits all. And I think from the perspective that you, as I understand your question, it can't be throughout the state either as to who may assist a school for providing that support. In some parts of the state, you may have a hospital system, most areas have a hospital that has some level of medical professionals working there, that they're all trained in CPR. Every hospital I've ever interacted with has some level of CPR training center that they utilize to train their employees. And I think while you pointed out, and I agree, you have a lot of, let's call it south of Wausau groups here. There are still those healthcare professionals in communities like Minocqua, Spooner, and other places that may not have full-time EMT or firefighters or paramedics, but they have hospital systems that require all their employees to be CPR trained and certified. And my interaction, at least in the Milwaukee area with the hospital systems, is they are more than happy to help provide assistance through some of their community support programs. In fact, my wife is a nurse practitioner for one of them, and they commonly seek those people out to volunteer in schools or other places to do health education or promotion, or talk to kids about what Senator Darling was talking about to support the school system. So I believe, and I can't say for a fact, but I believe that when you move throughout the state, just like you have to look at an EMS provider in some areas is generally the fire department. In the northern part of the state, it may be a hospital system, it may be a third-party private ambulance company, but all those places have resources to train people in CPR, and I believe, as Chief Bloom testified, they all have a level of public education commitment that they make as part of their volunteerism or their career. And I think we just have to remember that it's not going to be a one-size-fits-all. It's not always, in every area of the state, it's not going to be the fire department. It may be a private ambulance company. It may be a hospital system that has a community outreach program.
And this is really, easy. We're not teaching certification.
Good.
We're teaching really awareness. I think it's quite possible that an organization could go in and train the trainer so that other people could deliver this course in probably 30 minutes as well. Because it can't be solely taught by DVD, but obviously a DVD probably will be used in conjunction with live teaching. So it doesn't just fall, I think there's a real opportunity to train other people to become the trainers, maybe ancillary groups that just want to do something for their community. It is so simple, and as was previously testified, you can't do wrong, essentially, because if you do nothing, the statistics are against you. So we're trying to train people to do something. So it doesn't just fall on a fire department. It won't just fall on a police department. This is an opportunity to engage other organizations within the community and teach them to go out and do it, or just simply individuals. I think, hopefully, 5 years from now, we look back and just see the groundwell of support. And to your comment as well, I think the more, and we've seen this on a local level, the more we can engage people, and it's easy to engage them when they need us, calling 911. But the more we can engage them in non-emergency activities, the more they are aware of what we do, and they're more likely to support us, because a really, really small percentage of our residents call for our 911 services. But if we can educate 1,000 children in CPR, and they go home and they tell an adult, now we've sort of created this groundswell of support for organizations to continue to reach out in our community. So I think a lot of focus has probably been put on the fire departments to deliver this, but I think there's such an opportunity to engage others in a train-the-trainer style that it shouldn't be much of a burden on anyone.
I truly want to believe that. I really, really do. But, and I know I sound like a naysayer, and I'm not, I'm just trying to be very, very realistic.
Sure.
You're talking about that groundswell of support. That's all volunteer. That's all help out the school do its job. Help out the first responders do their job. They're not getting the funding that they need to do their jobs. So in the rural areas, we are constantly begging for that groundswell of support. Help them, help them, help them. And now here's another one. Help them. We have 911 that isn't funded fully, and we're going to go bankrupt in 2 counties because they can't fund it.
Right.
We have 911 that will not work because we don't have cell phone coverage. We're begging for safety, and I understand how important this is, but I don't want to make a promise I can't keep. And that's why I'm hoping for a waiver. Just maybe there's 2 schools out there that are going to say, my God, I can't get it. Florence, Mercer, Solon Springs. I mean, they just might not be able to get it. Danbury. I mean, there's places where they're going to say, I can't get it. Give me another year. I'll do it next year or something. So I guess that's all I'm trying to say to you.
Understood.
Okay, any other questions? If not, thank you very much.
Thank you.
Thank you.
Up next is Scott Caston from the Oak Creek Fire Department, speaking in favor.
Good afternoon, Chairman Olson and members of the Senate Committee on Education. My name is Scott Caston, and I am a lieutenant with the Oak Creek Fire Department. I sit before you today, in support of Senate Bill 412. For the last 3 years, I have taught hands-only CPR to freshman health students at Oak Creek High School. Our goal is to establish an entire student body that is trained in hands-only CPR, and as of today, we are 3/4 of the way through that. We have one class, one group that has not received it. So as of today, we're 75% of the way to our goal. Just to give you an idea of how we have structured our training in Oak Creek, one day each semester, in place of a typical classroom session, students are taught hands-only CPR. The Oak Creek Fire Department provides the mannequins and the DVD, so it's of no cost to the school district itself. Each class period begins with an overview of the training. I provide key points to remember and offer an initial demonstration of hands-only CPR. Once the students see the actual mannequin on the floor in front of them, you can see a change in their demeanor. The class period transforms this from just another Tuesday into real-life training. These kids understand, they watch the news, they know that there's a chance that sometime in their lives they're going to have to use this training and perform hands-only CPR on another human being. From there, the students view the American Heart Association's DVD. After the DVD, we break out into smaller groups to practice the hands-only CPR. Once each student has had the chance to practice their newly learned skill, we reconvene as a larger group. Each class period, I'm amazed at the in-depth line of questioning that I receive. The formerly timid group of freshmen have now viewed themselves as potential lifesavers. Based on my experience teaching these students over the last 3 years and my 15 years as a healthcare provider myself, I fully support Senate Bill 412. We must empower the next generation with the knowledge and training to someday save a life. Thank you for your time, and if you have any questions, I'd be more than happy to answer them.
Okay, any questions? If not, thank you for coming over and testifying.
Very much.
Up next is Malin Mitchell from the Professional Firefighters of Wisconsin, speaking in favor.
No, he's not here.
Then we have Rachel Gallagher from the Wisconsin Association of School Nurses, speaking in favor.
Good afternoon.
Good afternoon, Chairman Olson, as well as the Education Committee. My name is Rachel Gallagher, and I'm a school nurse and the president of the Wisconsin Association of School Nurses. Today, I am here representing my association, speaking in support of Wisconsin Bill 2015, Senate Bill 412. This bill would modify the Wisconsin statute, which we've already talked about from previous testimony. The Wisconsin Association of School Nurses believe this life-saving instruction should be a requirement for all students. In December of 2015, a student in Bakersfield, California, collapsed while running sprints in a physical education class. At the time of the incident, the district nurse was providing services in another school building. When seconds count, students and staff did not initiate CPR or cardiocerebral resuscitation or call 911. If the students were armed with life-saving knowledge and skills, the student life could have been saved. Let us not have this happen in Wisconsin. Let's prepare our students to respond. Equipping students with this life-saving skills make our schools, homes, and communities safer places to live, work, and learn. Providing this instruction will make high school students more career and community ready. CPR or CCR or AED instruction is a requirement of many entry-level positions held by young adults, such as lifeguards, daycare providers, and certified nursing assistants. We need our youth to be prepared to safely fill these necessary positions. The Wisconsin Association of School Nurses would like to thank the Education Committee for the opportunity to support Bill 412. Thank you for your time. Any questions you might have?
Thank you for your coming and testify. You've heard concern from our committee members that schools may not be able to fulfill this requirement. You have members in probably every school district in the state, probably. Talking to them, is there any concern that they will not be able to have the kits to provide this instruction on a timely basis?
I think there are many options out there for school districts to obtain the necessary equipment, and school nurses are often instructors along with volunteer fire as well as EMS responders to help with the instruction to make that seamless, if you will. And so I have to believe that there would be necessary resources available to school districts. When we brought this before our membership, it was a unanimous vote that this was an important piece of legislation.
Okay, thank you. Senator Bewley.
You know I'm going to ask.
Yeah, go ahead.
Could you just comment how many schools, not districts, but how many schools, physical buildings have school nurses?
That is a great question, and I believe the Department of Public Instruction could best answer that question. As far as our membership is concerned, we have 300 nurses across the state of Wisconsin that are school nurses. Now, keep in mind, Milwaukee and Madison certainly have a great majority of those nurses, and we do find in the rural areas that they struggle to fund school nursing.
Because I want to point out that there are I know of many schools that don't have nurses, and just as an example, the entire district of Rice Lake has one half-time nurse for the entire district. And they
I happen to know that nurse.
Yeah, and they consider themselves lucky that they have a half-time nurse for the entire district. Thank you.
And I do understand your concern, but if you are a school nurse prioritizing your time and effort, what greater way you could spread your limited time than teaching staff as well as students to respond to a life-threatening situation. So in other words, in the hierarchy of what you could prioritize, I would think this would be number one, to respond appropriately to emergency situations.
Steve, Senator Doss?
Steve's fine. The cost issue that I and Senator Bewley have raised. Initially, my superintendents in my area did not support this. Laudable goal, no problem, but they really, really are concerned about another mandate that is not funded. So I guess we get back to the waiver or some aspect of that. We can always hope, and I think it probably will materialize, but we don't know if it will. And to take that issue away, if we put a waiver in here where it's documented by a school district that they can't afford it. It may only be for 1 year or until they can get the resources. Will it ever happen? Maybe not. But it might. And then we're going to sit here and someone's going to ask, why didn't you put a waiver on this or something? It's another mandate. Or if maybe instead of a waiver, if a school district can document that they don't have enough resources and organizations have not stepped forward, perhaps even a majority vote of the school board. As long as they document it, then a majority vote of the school board for that year they can, or even a semester, until they get the equipment, can have that lifted. You don't have to answer if you, that's fine. I understand that the way it's been going is that everybody, don't worry about it. It's easy, when I look at the list, it's easy to, it would be for me too, I guess, to say let's do it if someone else pays for it. And that's kind of, with some of the legislation we deal with, there are groups that come in and organizations that say, oh, this is wonderful, don't make me pay for it. And it's a great idea. And CPR is a great idea. It is a lifesaver, there's no doubt about that. There are other things that could be, and we may have to deal with in the future too. But anyway, so the waiver aspect, I think, takes care of that problem. And I based on what I'm hearing, it would alleviate my concern. And I think maybe in 3 or 4 years, once this is rolling, you will be able to come back and say, we told you so. Nobody out there has asked for a waiver. And that'd be great. But it's the just in case.
My comment back to you, Senator Nass, would be whenever school districts have some flexibility in being able to implement a mandate, I think that's preferred. With the majority of mandates that are out there, I can understand your concern, but I think that if there isn't an end date where it has to be fully implemented, it will be kicked to 1 more year down the line. So my concern is to have an end date when it should be fully implemented.
Well, the waiver would take care of that problem. But, okay, thank you. Appreciate it.
Senator Darling?
Thank you very much, Mr. Chair. I had mentioned my concern that I'd heard from my school districts as well about another mandate, another mandate in the back of way too many mandates. And so I think that Senator Nass brings up something very important. I totally agree that this is very important as an issue, but I think there has to be some flexibility as to how school districts can build in a program that works for them. Because I just did a tour of all my school districts in my district, and that was, they all were really up to their eyeballs in mandates, and this particular bill was mentioned, and I think it's a real issue. So why it's a very good idea. We sometimes think because it's such a good idea, we can mandate it, but I think this one, I would agree with Senator Nass that we really need to build some flexibility in it.
Yeah, I mean, the committee has the authority and the power to amend the bill, and if that's what it takes, I assume we can work with the author to get that done.
Great.
Okay.
Up next is Mary Jo Gordon, representing herself, speaking in favor.
Good afternoon. My name is Mary Jo Gordon, and I'm a resident of Seymour, Wisconsin. Mr. Chair and members of the Senate Committee on Education, I thank you for this opportunity to testify in favor of Senate Bill 412. My testimony today provides both a personal and a professional perspective on what I believe is the most important lesson a student can learn: how to save a life. My family and I have an inherited heart rhythm disorder that can cause sudden cardiac arrest, primarily in children, teens, and young adults. In 1979, my youngest sister suffered sudden cardiac arrest, meaning her heart stopped beating. She was on her way home from school, and no one that she was with knew how to do effective CPR. As a result, she was left profoundly brain damaged. She was only 17 years old. I should add that her twin sister was standing by and watching as this was happening because she did not know how to do CPR. And someone earlier talked about the haunting that goes on. That was 36 years ago, going on 37, and it still haunts all of us to this day. 2 years later, another of my sisters suffered cardiac arrest, and my parents, who had just taken a CPR class, successfully performed CPR on her and saved her life. Several years later, my 11-year-old nephew suffered cardiac arrest, and his dad, my brother, did CPR on him until paramedics arrived. I'm here today because people knew CPR when I too suffered cardiac arrest in 2007. I'm a survivor. So yes, everyone knowing how to do CPR is absolutely essential. I wouldn't be here today if it weren't for that, nor would my nephew or my other sister. My family's stunning experience highlights the importance of knowing CPR, and it sent me on a professional mission to ensure that everyone learns this life-saving skill. To that end, I have certifications in emergency medical services in Massachusetts and Washington State. I'm an EMT paramedic member of the American Heart Association. I've held certifications as an American Red Cross and American Heart Association CPR instructor for more than 30 years, and I've trained hundreds of healthcare providers in basic and advanced cardiac life support. Of the more than 2,000 individuals I've personally trained over the years, I am most proud to say that the majority of my trainees have been high school students. CPR and AED training was part of the health class curriculum and required for high school graduation in the district where I worked in King County, Washington. And Senator Bewley, I just want to add off script that I worked in a district that was right on the edge of the grid in Washington State. It was a massive rural district. We were mostly volunteer, and our response times could be more than 15 minutes easily. So I know the importance of having individuals, bystanders, and family members knowing how to do CPR. I've also trained students as young as 9 years old with families that have risk for sudden cardiac arrest, just like mine. And now, as has been mentioned earlier, thanks to extensive research by the AHA and other medical professionals, hands-only CPR is much easier for anyone to learn, and it's very effective in practice. I've enjoyed teaching middle school and high school students because they're so eager to learn, and they have remarkable retention. I've heard many stories, like the 19-year-old student who had taken my class as a freshman in high school and then successfully did CPR on his college roommate 5 years later. There's another student who successfully did CPR on his grandfather and saved his life. And working as a medic, I can say that cardiac arrest calls were always the most challenging of our responses, and not just because of my personal experience. When we could arrive on a scene and see that CPR was in progress by either family member or bystander, there was always that bit of relief that our chances of saving that patient were going to be that much better if CPR had not been administered before we arrived. And as I mentioned, it was a rural fire department, and we had a lot of calls that took a long time to get to. Personally and professionally, I know all too well that 1, early activation of 911, 2, effective CPR, and 3, use of an AED are the cardiac arrest victim's only hope of survival. In my opinion, learning CPR is the most important class a student can take because it's the only class where they're going to learn to save a life. That is a tremendously powerful return for 30 minutes over the entire year or entire course of a student's career. I thank you for your time and attention, and I will take any questions if you have any.
Thank you for your testimony. Any questions? If not, thank you for teaching kids and people to save other people's lives. You should be very proud of that. I can believe that.
Up next is Rick Wask from the Adams Friendship Area School District, speaking for information only.
Good afternoon, Education Committee. from an informational standpoint, I just want to.
You're
Sorry,
gonna,
we're
he's coming
speaking
back
later
a
on
little
something
bit later.
else.
Yeah. You guys are eager beavers to talk about
Yes,
mental health.
believe me, everyone's excited. Just to provide a clarification to the Senate Education Committee regarding health requirements and how they work in our school districts. School districts are required in grades 7 through 12 to provide health instruction as a graduation requirement. So this graduation requirement for health instruction is already in place. As was previously mentioned by Senator Olson, school districts in essence, or sorry, the state in essence buys time in school districts. So this requirement would be part of the existing health curriculum, existing health class instruction, and ultimately there is some flexibility in how that's done. There's the requirement that there is instruction in hands-only CPR, but not certification. And I think those are two very different things, and they have very different cost impacts. So providing from our school district's perspective and my school district's perspective, this bill does provide flexibility and getting a life-saving technique brought to the forefront for all students in our public schools. And there is flexibility in doing so that school districts can, because I've been in other school districts that have done Red Cross certification for everybody taking health class as a local decision and, you know, funded it locally. This law does not require that. This law simply requires instruction in health classes that are already mandated. So I just wanted to make that clarification as far as that's how the school districts see, or that's how our school district sees this legislation.
Okay, thank you. Any questions? If not, thank you very much. And we'll see you in a couple minutes.
Up next is Chris Kulo from the Wisconsin Association of School Boards, speaking for information only.
I think he left.
And then one more time, Malon Mitchell from the Professional Firefighters of Wisconsin. Nope.
Okay, that then concludes our hearing on.
Senator Bewley.
Oh, Senator, yes.
I have one more question that I didn't ask, and I'm wondering if Heart Association would be willing. Could I ask another question of them? Is it too late?
I think they.
You gonna go get her?
Oh, here, she's right back.
Oh, great.
Good.
Could I ask a question of you? Okay.
We actually have one more person who wanted to testify. I'm sorry, she thought I filled out a slip.
Oh.
If that's still okay.
Sure.
Okay. What we've been told is the format is using this kit with the dummy and the whatever. Is that required? Is there a way to do the training with other implements or devices so that you wouldn't need to make the investment?
From our perspective, no.
Okay.
I mean, there are training levels certainly where you could watch a video, but the research shows that really the way people learn and have that comfort that they need in order to do it and to do it effectively is you need an actual hands-on a mannequin practice. So the mannequins really are crucial in making sure that the student is learning what they need to learn in order to do effective CPR.
Okay, all right. I'm asking that because, you know, I don't want to draw a line in the sand and say I'm not going to support this bill without any flexibility or waivers, because I don't think that's the case. I want to be able to vote for this bill. So any reassurance that I can get that the rural school districts are going to be able to pull it off, that's all I need to know.
Yeah, and I wish, you know, I can certainly visit with you and other members who have concerns, but you know, I know it's hard to take our word for it, but there really are all these resources out in our community. We are stepping forward with resources that my national organization is willing to put in Wisconsin. I do want to make sure everybody realizes that that commitment is contingent on legislation passing, because we're not going to put financial resources into the state without reassurance that they're actually going to be used. It's just, I think, a delicate balance of, like Senator Petrowski and others have said, we were trying to be as flexible as possible with how schools can implement and giving them as many opportunities as possible without being too prescriptive. And that leaves it to the point of where, In some areas of the state, it will be the fire department. In other areas, it'll be the local hospital, like we're going to hear from next. There are just so many different partners, and without being prescriptive and saying it needs to be done one way over the other. If we added funding to it and said each school had to purchase their own equipment, that's being pretty prescriptive too. There are schools who I don't think want to do it themselves. They prefer, like Lieutenant Kasten, to have the local fire department come in, bring their equipment, and do it all themselves. And the teacher helps supervise, but kind of is standing off to the side a little bit more, and they're letting the fire department do it. So we really wanted to draft it in a way that allows schools to decide for themselves what works best for them.
Okay, thank you very much.
And
Susan Kinchy from the Edgerton Hospital speaking in favor.
that was close.
Good afternoon. Thank you for adding me to the agenda. I apologize for not having the paperwork done. My name is Susan Kinchy, and I'm a registered nurse. I've worked in cardiology since 1990. I live in Marshall, but I practice in Edgerton at the hospital there, Critical Access Hospital, a very small rural hospital, where I'm the manager of the Cardiopulmonary Diagnostics and Rehabilitation Department. I really appreciate the opportunity to testify in support of Senate Bill 412, teaching hands-on CPR to every Wisconsin student. I think it's one of the simplest yet most important pieces of legislation that may come before you this year. It's one bill that truly can make a difference between life and death. I've been certified in CPR my entire career and recertified every other year. As a healthcare provider, I do have that repetition. It is required. I've been teaching healthcare provider CPR for the past 8 years, and 6 years ago I went through the training to teach compression-only CPR, which has been a wonderful opportunity to reach out to the community and teach hundreds of everyday people who really want to make a difference. And the most exciting area where I teach is at the local high school in Edgerton. Each semester, as well as the summer semester, I teach juniors hands-on CPR as part of their healthy living class. I teach for one class period a semester, and it averages 16 to 24 students in that class period that I teach. I bring the hospitals, CPR mannequins, and our automatic external defibrillators to the high school. I have taught 65 kids just in the month of December. Actually, there were 3 sections of the healthy living class, and so 65 students were taught in 1 month. Their teacher, Barbara Gosman, assigns them to teach at least one person as part of their homework. It is that simple. I can teach those children in a short amount of time, and they, in turn, can teach their friends and family members. The Edgerton Hospital provides this community service because we think it is so important to our community. Our athletic trainer and I make certain each student has experience of doing compressions on a mannequin, which addresses one of your questions as to do you really need your hands on a mannequin. That really makes muscle memory and imprints the practice of CPR. The students are very engaged and very active, and just as you heard in previous testimony, their questions are very, very appropriate. 3 years ago, in February 2013, one of the students I had taught had the opportunity to put her training into practice when her little sister found the neighbor unresponsive. The student, Julia, and her mom performed CPR until the EMS arrived and took over. Julia said it was terrifying and exhilarating at the same time. She determined that everyone needed to know CPR and decided to take that on as her responsibility. She and her high school basketball teammates came to the hospital for a morning of training during their Christmas break, and then they sponsored an event called the Heart of a Champion, where they taught over 80 community members during halftime of the basketball game. I was there as their technical advisor, but each team member was able to teach at least 10 people how to perform CPR and potentially save their loved one. The students felt incredibly empowered and were thrilled to know that they could make a difference in their community and in the community of the visiting team. This is the t-shirt that they sold in support of their event and donated the money to American Heart to provide equipment to other high schools. I'm very passionate about teaching CPR. It is the only thing I do in my personal and professional life that makes such a huge difference, and I strongly encourage you to support this bill. Thank you for your time.
Thank you for that story and your testimony. We appreciate it. Is there any questions? If not, thank you very much.
Thank you.
Now, I think that concludes the hearing on 412, and we will move into the hearing on mental health. We're just a couple minutes late, but legislative time is close enough. The reason that we are having this informational hearing is because it is very evident that schools across our state are having to deal with mental health issues in their students. And a lot of those don't have IEPs. They have mental health issues, which causes them difficulties in getting along with others and their teachers and things like that. So it was brought to our attention that this is an issue that schools are really grappling with, and we thought it was important to have an informational hearing to find out the magnitude of the problem and what schools and CISAs and groups around the state are trying to do to deal with this issue, and if there's anything at the state level that we can be of assistance in our school districts to help deal with, I think, an increasing issue with mental health. Students will have mental health issues. So the first person, I think, Jenna,
Is Steve Fernan from the Department of Public Instruction.
welcome, and I think you have a PowerPoint, correct?
Good afternoon, and I'll start by thanking Chairman Olson and members of the committee for allowing our department to share some information on this very important topic. We're going to show in just a minute a slideshow that I'll try to move through very quickly, but just a little bit of background. With this particular issue, we met approximately 3 years ago to form a task force that ultimately convened a statewide school safety summit. And out of that summit, the results of the discussions were that if we could focus on a number of activities, strategies that would improve school safety, we'd spend the majority of our resources and time on mental health. That as school district administrators and principals and pupil services staff tell us that we deal with a lot of behaviors that most likely are covering up some underlying undiagnosed mental health issues. So as a result of that, our department sought to secure some resources that we might put into a statewide mental health initiative. We applied for a number of federal discretionary grants, including the School Climate Transformation Grant from the U.S. Department of Education, a Project Aware grant from the Substance Abuse and Mental Health Services Administration, and a Safe Schools, Healthy Students grant also from SAMHSA. And while those particular projects have some very specific requirements, we were able to divert a number of funds from those various grants to braid together a funding source that would help us provide a pilot around school mental health. So what I want to share with you is a little bit about how we've organized that particular initiative and how we feel it might be informative about what we learn, the materials we develop, the training protocols we develop that could support mental health services in schools around the state. While this particular pilot is working with 54 schools across the state over the next 2 years, we feel, again, the training materials and the guidelines that we develop can be very helpful. Also, the approaches at the individual schools involved in these projects we think can also be helpful in informing what we might do with across the state. So with that, you have, I believe, the slides in front of you, and I'll try to move through this very quickly. Center for Disease Control estimates that approximately 1 in 5 students has a undiagnosed or a diagnosable mental health issue. In Wisconsin, the Youth Risk Behavior Survey told us that in 2013, 1 in 4 high school students reported that they had been sad, depressed, weren't able to function as they normally did for a period lasting up to 2 weeks over the course of the last year. That's certainly signs that they may have some depression. And as I mentioned, 1 in 5 children, according to CDC, may have a diagnosable mental health issue. That would mean in Wisconsin that would be up to 174,000 school-age children a year may have an undiagnosed mental health issue. Now, we recognize that many of those may be very short-term and very mild, but we also know that it can advance to the point that they are so severely depressed and hopeless that they may consider and contemplate suicide. That in Wisconsin, if we use that estimate from CDC and the fact that 60 to 90% of children with mental health disorders either don't get diagnosed or don't get treatment, that could be a range of 100 to 157,000 students that are not receiving any care for their mental health issues. Of those that do receive services, about 3/4 of them, we believe, are receiving them through a school-based program. And that could be their traditional pupil services, school counselors, psychologists, nurses, and social workers. It can be the growing number of school-based mental health clinics in Wisconsin. I believe we're approaching 200 in schools across the state. It could also be through coordinated service teams that counties are providing in most of the counties at this point in time. But that's where school kids are, and that's where we can and do need to provide those services, even though, again, many of the kids are not receiving them. We also know there's a disproportionate access to care. Children of color, children living in poverty, and sexual minority adolescents have a disproportionately poor access to those services. We know that with the number of mental health providers in schools, that it's far below the recommended ratios that the various national organizations recommend. Whereas school counselors, we have about 466 students to each counselor. It's recommended that there be 250 to 1. So we're about half as many as is recommended. And when we look at school psychologists, it's about 956 students to each school psychologist in Wisconsin, a little over 1,000 students for each school social worker, and almost 1,600 students that each school nurse. And you heard Rachel Gallagher talk about the fact that we have a number of nurses that work in schools across the state, but they are serving a very high number of students on their caseloads. So the ability to provide those mental health services strains the system in terms of the number of staff that we have working who are specifically trained in the pupil services disciplines. When we further look at community-based mental health services, the darker the shade of green in the county map here means the higher ratio, meaning more residents to each mental health provider that's available in that particular county. So we can see we've got some pockets where there's significantly high numbers of residents for each certified mental health provider in that particular community. So what's the ultimate or the most severe problem? And I think we would all agree that it's a student who would take their own life. They feel so hopeless. They feel that they have no resources. They have no ability to deal with the problems they may be experiencing. And certainly stigma and shame become part of that. And we see that in Wisconsin over a period from 2000 to 2013 that we had over 600 students or school-age adolescents take their own lives. That's the second leading cause of death among that population in Wisconsin over that period of time. Nationally, suicide is the third leading cause of death, and it impacts about 10% of the students who die nationally. In Wisconsin, it accounts for about 14% of our mortality among those particular age group. So the Wisconsin School Mental Health Project is one, again, we began with braiding funding from a number of those federal grant sources, and our objectives are to improve student mental health by participating or adopting a framework, and I'll talk a little bit more about that in a moment, to improve mental health so that they can improve student learning, to focus on mental health, to improve conditions for teachers and other students so they can learn, because we know students with an undiagnosed, untreated mental health issue may be disruptive to their classmates and to the teachers, and also because all children and youth deserve it and are entitled to it. Now, there's a significant number of issues that we charge our schools with dealing with, and these are just a sample of the various mandates and services they try to provide to schools. So how do we provide mental health services to our students in our schools with all those things we're trying to juggle? So our teacher here is doing cartwheels, trying to do all that. To think about adding mental health services is certainly a challenge. So what we recommend and what we're trying to attempt in this mental health initiative is a comprehensive, coordinated approach that addresses school mental health by building on the infrastructure they already have. Many school districts in the state have adopted PBIS, positive behavioral interventions and supports, and have been training their staff in how to differently engage students. Rather than reacting to behaviors, to be proactive, to teach, to try to incentivize the behaviors we want, and we think that that's a great foundation upon which to build. And many of these different strategies we feel can do that using that excellent infrastructure. So we are looking at an integrated approach and making connections through effective implementation. What are the strategies that can be most appropriate? So having a continuum of supports for those students, having a strong universal implementation. So not just for a few students, but for all students. So when we talk about a multi-level system of support, we'll share a little bit about how we see that happening, and also providing culturally responsive, evidence-based practices. Also, impacting student and teacher relationships. Who do kids spend the majority of their time with? In the classroom with the teacher. So if we can provide support and training to those classroom teachers, so again, they're looking at the kids they're dealing with, not for the behaviors, but maybe what's underlying. It might be through providing trauma-sensitive schools training, understanding what kids may have experienced that is producing those behaviors, and also trying to take away the stigma around mental health. Also having family and community engagement, reaching out beyond the school staff to those community partners, those mental health providers, those county organizations and other public and private agencies, and also having strong leadership from the building and district level leaders. So practically we see three different models of service delivery emerging. One is that mental health services will be delivered by pupil services providers with referrals to community-based agencies and organizations. So by providing the training to psychologists, counselors, social workers, and nurses, we feel that that's one model that schools could adopt. Specific training around a strategy called SBIRT, screening, brief interventions, referral to treatment, is one particular training model that may very well help with a school adopting its own in-house delivery system. A second approach is a growing number of school-based mental health clinics or satellites that are licensed, certified by the Department of Health Services, that are co-located in schools to provide those services. And we see right now about, we're approaching 200 of those in existence that are certified and operating across the state. And we feel as part of our framework, that could be a model that schools adopt. Now, one thing, as you're looking at where we might go in this state, we know that right now consultation between mental health providers and schools is not a reimbursable or a billable service under our state Medicaid guidelines. Having the ability for those mental health providers to be able to bill Medicaid for those services would result in the kind of collaboration that we're envisioning. And the third approach is community-based mental health service providers as full collaborative partners. How do we make sure that we bring those community service teams, those wraparound services to schools through memorandum of understanding, through mutual aid or cooperative agreements, so that we can have those services being provided through community-based organizations brought to and connected with those that are being provided by the school. So with that, those models of service delivery, we're seeing a multi-dimensional or multi-system, multi-level system of support, again, much like PBIS, with the foundation providing services for all students in a universal or Tier 1 approach that may very well include providing classroom instruction. What are the warning signs that you may be depressed beyond just a situational breakup with a boyfriend or girlfriend, something that's lasting? What are those things that you might be able to identify and come forward for help? What are those kinds of school-wide approaches where we can provide training to staff so they have understanding of trauma that kids may be experiencing, so we get rid of the stigma and they look beyond the behavior and what might be underlying. With a smaller number of students at a Tier 2 approach where we work with those who may be at risk, this is where a strategy such as SBIRT, screening, so that this pupil services staff who may have a student referred to them can be screened to determine what is underlying, and then to be able to also provide brief interventions for a period of time, and if that is ineffective, to be able to refer to community-based mental health services, even those that might even be in the building through a co-located satellite clinic might be another approach to provide for some. And then also for the very few, those more in-depth therapeutic interventions, again, that could be provided by the satellite clinic providers in that school-based setting, or with those wraparound service teams from the county. So again, with that multi-level system of support, that three-tiered approach, we also see it's necessary at all levels to be linking with community-based organizations and systems of care. So collaboration is the key, which is why I mentioned the ability for community-based mental health providers to be able to bill Medicaid for the collaboration they're providing. The consultation services will make it a richer level of support for those students. Otherwise, we may not be having that level of collaboration between mental health providers in the community and schools. So with that, I'll stop and ask if there's any particular question you have of me, and maybe I'll just say just a minute or two more about the community mental health, or excuse me, the statewide mental health initiative. As I mentioned, we have 54 schools that are participating over the next 2 years. They will be receiving in-depth training through a series of 13 modules on trauma-sensitive schools, so they can begin to help their staff reduce the stigma that may be involved, and also to be able to recognize the issues that may be underlying behaviors. We also have training modules that are available in an approach called Youth Mental Health First Aid, where all the staff that may come into contact with students, not just teachers or pupil services staff, but the bus drivers, the cooks, the janitors, that they all can recognize and be able to notify staff that can follow up as to what they might be observing. We will also be providing particular guidance through a mental health framework that I think in the first slide we said coming soon, and we've just moved this to print. I have a few copies that we can share with the committee, but this is a document that will provide more information on the various approaches that schools might take to provide a mental health framework in their particular school. So all in all, the bottom line is we do want schools to be safe places for all staff and students. We want it to be a place where it's conducive to learning, and we know that that is often interrupted or impacted by students who are struggling with mental health issues. And it not only impacts their own learning, but also those of their classmates and then the teachers to be able to deliver curriculum. So we are hopeful that we can be successful. And the number of schools that you've invited to provide testimony on some of their specific strategies that they're employing, we think are excellent choices, and we're hopeful that through this process you'll be able to learn some of the things that we might be able to do as a state to help us advance children's mental health. So with that, I'll stop and ask if there's any questions.
Thank you, Steve. we spent about an hour and a half talking about a bill dealing with CPR, telling schools they need to deal with this. I assume schools didn't go looking for this problem. How did this evolve over time, and how has this grown, and what is it costing schools to deal with the range of students? Because this is becoming, as you said, 24%, a big issue. And, when I was going to school, which was forever ago, I don't remember schools dealing with this. I was probably pretty oblivious to what was going on in that area anyway, but when did this really start kicking in, and what are some of the reasons, and is this going to be a growing issue, or give us a picture of where this developed and why schools decided they had to handle it?
I think there's a lot of different contributions to this particular issue. A number that we have heard is that we have fewer pupil services staff that have the ability to intervene and provide the in-depth support and services directly to students in schools. As we've seen these students who are presenting issues that may be related to anxiety or depression because they are facing more and more stressors in their life, and we know that there's also more and more isolation. One of the things about technologies is great and that it can connect us, but at the same time it can isolate us. And that when we do the YRBS, one of the things that just startled us was the amount of screen time kids talk about spending each day, whether that be in their personal devices or television, and that we see many of the youth risk behaviors actually declining, because I think there is that social isolation that is occurring because of the increased use of technology. So I think the fact that kids may be more isolated, that they may not have the level of support for the issues that aren't being addressed either at home, they can't be addressed in school because we have less staff to work with them, that I think that has contributed to some extent. I don't know if we have expected more of students and that there's more stress on them to achieve. That could be part of it. So I think there's a lot of contributions. One of the things, as we look at suicide in particular, and you saw some of the data about the high numbers in Wisconsin, that there is a number of theories around that particular issue, and one of them is that we have a fairly high rate of alcohol abuse or alcohol binge drinking among our youth, and while it's started to come down to the national average, it's always been higher. And we know that inhibitions are reduced when students are under the influence of alcohol. Also, we have high access to lethal means. We have, I think, the 14th highest percentage of households that have guns because of our hunting culture in Wisconsin, and that's overwhelming the cause of completed suicides among youth in Wisconsin. We also know that it's not just in Wisconsin, but across this issue, there's still stigma. Kids, just like us, are unwilling to come forward and talk about issues, about problems. And those are some of the reasons that have been theorized why our suicide rate is higher. One of the other things is, I think we have one of the lowest ratios of mental health providers with a specialty in adolescent services, that their practice is specialized in serving children and adolescents. So the ability to get specialized care is also less available in Wisconsin. So those might be some of the reasons why suicide in particular has been higher in Wisconsin, but overall I think there's a number of reasons that contribute.
Questions? Mr. Bewley.
I'm hearing impaired, and I'm going to have to...
There, okay, now it worked. Could you clarify for me and perhaps for others, you mentioned reimbursement under Medicaid. Could you sort of describe what things are covered in reimbursable and what things aren't?
My understanding, and some of the providers probably explain this better than me, is that direct services are reimbursable. So where we're doing assessment, where we're doing direct intervention with a client, those are obviously reimbursable. But where we're not working directly with the patient, we're working perhaps to consult with the schools. If a therapist gets a release of information and is doing some joint case management, sharing information, trying to do some joint planning, that those kinds of consultation services are not a reimbursable activity. So that kind of collaboration that we talked about as desirable is something that they would be doing gratis, that's not something that they could necessarily, and I think in other states their Medicaid guidelines have allowed them to be able to bill for those particular consultations. And others may be able to help elaborate on that.
Okay, thank you. Any other questions? If not, thank you very much for coming and testifying.
Up next, we have a group testifying together from the Adams Friendship Area School District. We have Rick Waske again, Barbara Granzi, Jason West, and Ann Femright.
Now you can come up. Thank goodness for thumb drives.
Good afternoon. I am Rick Waske, the District Administrator for the Adams Friendship Area School District in Friendship, Wisconsin. And on behalf of our school district and the families of Adams County, I would like to thank Senator Olson and the Senate Education Committee for the opportunity to share how our district has been addressing student mental health issues in recent years. I represent a large rural school district in which high poverty, high property valuation, and some very significant needs regarding community mental health are present. While we have a long way to go, we are proud of the steps we've taken to address the needs of our students and families while working with a continually shrinking district budget. It is through the strong leadership of the speakers I will introduce today, along with many others, that we are making a difference for our students and families one day at a time. It is at this time I would like to present the dedicated professionals that will be sharing our story this afternoon. I would like to introduce Mr. Jason West, a student advocate at Adams Friendship High School. Seated next to him, Ann Femright, the Student Services Grant Coordinator for the Adams Friendship Area School District. And leading off our presentation today will be Barbara Granzi, our Director of Pupil Services.
Good afternoon. Now I'd like to tell you a little bit about Adams Friendship. Adams County borders the edge of the Wisconsin River, houses the second and fourth largest bodies of water in Wisconsin, and has pristine woodlands, thus making it a tourist destination for many. Nonetheless, those that call this beautiful county home are often faced with unique stressors such as lack of transportation, lack of employment opportunities, and lack of skilled childcare, and are more apt to experience greater challenges accessing quality mental health care than those in more urban settings. Adams County residents have a shortage of mental health providers and services. The ratio of population to mental health providers is 2,560 to 1 in Adams County compared to the state's ratio of 623 to 1. There were times in the last year when people needed to wait at least 8 weeks to see a therapist at Health and Human Services, and often could not be scheduled for a second session for at least 3 weeks. Moreover, Adams County is ranked 63rd for overall health outcomes among all 72 counties. Adams Friendship Area School District is 550 square miles and consists of 3 elementary schools, 1 middle school, and 1 high school. The percentage of Adams Friendship Area School District students who qualify for special education and support services is at 18.6%, as compared to the state average of 13.5%. Moreover, 4% of our population qualifies for an emotional behavior disability. That is 150% higher than the state's average of 1.6%. In addition, these needs are often magnified by financial barriers such as lack of access to health care providers and poverty. Poverty among Adams Friendship Area School District's families is daunting, as 72% of our students are eligible for free and reduced lunch, which is twice that of the state average of 36%. In addition, we have 28% of children in poverty compared to 18% statewide. 50% of children in Adams County live in households that receive food stamps, whereas the state is at 30%. Unfortunately, literature suggests that children in poverty are more likely to report higher rates of depression, anxiety, and antisocial behaviors, thus only compounding other stressors. Due to many of these stressors, child maltreatment is often entrenched in our families throughout multiple generations. County child abuse and neglect statistics from the last 5 years indicates a 90% increase in Child Protective Services reports, from 248 cases in 2010 to 471 cases in 2015. Of these numbers, there was a 294% increase in children alleged to have been neglected. Voluntary child welfare cases went from 30 cases in 2010 to 74 in 2015, an increase of 147%. Juvenile justice cases have doubled from 60 cases in 2014 to 123 in 2015. Many of these students served by Adams Friendship Area School Districts arrived to school unprepared to learn due to the numerous compounding issues related to poverty and a lack of mental health resources. Despite these troubling statistics, you will soon learn how hard our district has been working to address the aforementioned data. Jason West will now share with you a few experiences he has had while living and working in Adams Friendship.
Good afternoon. Adams Friendship has been my home for most of the past 25 years. I've seen the mental health issues in our community for some time now. These issues became even more apparent to me once I landed my first job out of college with a place called Bridges for Youth. Bridges was a nonprofit organization that ran an alternative school for the Adams Friendship students. These students were placed at Bridges to work on both academic and social-emotional needs. Shortly after starting, I was tasked with working one-on-one with a student by the name of TJ, a 15-year-old freshman that had yet to earn any high school credits. TJ's behaviors and defiance were so severe that I had to work with him separate in a room all by ourselves. I was instructed to talk to TJ during our time together, work on establishing a relationship, and trying to get him to do as much schoolwork as possible. At first, TJ was only willing to talk. Getting him to do any schoolwork was next to impossible. During our time together, TJ told me about how his father was murdered a couple years prior in an altercation at a bar. He talked about his current living arrangement with his mother and boyfriend that he didn't get along with, and how he was in and out of foster care throughout most of his childhood. I was starting to understand why this young man didn't seem to care much about his schoolwork. He had personal issues that needed to be addressed that were more important to him rather than his math or science. TJ and I continued to work for 2 or 3 hours daily throughout that school year. Eventually, TJ did start doing schoolwork, more than he did talking. At the end of the year, TJ worked for a solid couple weeks on his computer applications final. It was a project to Microsoft Excel where students had to create a game using different ways to code and color the program. TJ went all out on this project. He incorporated music and pictures of his liking. A few days after submitting this for grading, he received a no from his teacher. He received an A. She also let him know that it was the best project that she received all school year from any of her students. This was the last time I worked with TJ, but this isn't the end of his story. In December of 2013, Bridges was informed that we would no longer be coming back due to budget cuts in the school. At the same time, the high school was losing one of their counselors. In January 2014, I was hired to replace him. Immediately in my new role, I could see that the mental health needs were well beyond the 20-plus students I worked with while at Bridges. Students would come to myself and the other counselor by the handful for things well beyond the scope of that of a school counselor. Many times we'd refer them and their families to our county health and human services. However, it would take a month for them to be seen and then maybe another month for a follow-up appointment. This brings me back to TJ. TJ had mental health issues and was seeing somebody once a month, but it wasn't in person and it wasn't in an office face to face. It was over a TV screen. For this, TJ's needs were not being met. His needs were far greater. And that is never more obvious to me on June 14th, 2014, when I began to read an article on the internet about a 19-year-old boy and his girlfriend that jumped in front of a moving train in Juneau County, declared a double suicide. As I continued to read that article, I learned that the young man was TJ, the first student that I felt that I got through to, the student that I thought had promise if he got the help he needed, but he didn't. His mental health was so severe that at the age of 19, he thought that jumping in front of a moving train was a better option than going on with his life. The lack of resources in our school and community are often the topic of discussion. However, it always goes back to the lack of funding. We realized that we didn't have the capacity to help our students alone, so we branched out and contacted a community mental health provider out of Wisconsin Rapids. We were able to work on an agreement with them to come into our school and do mental health counseling with our students 1 day a week, right in our building. This was great and still is to this day. However, it didn't solve all the issues. Like most private firms, they could only see the students that had certain types of insurances. We were again finding that some of our most needy students were not being seen. The students that I'm currently working with are kids of the people that I grew up with in Adams Friendship. They are my neighbors' kids. They are my coworkers' kids. They are the future of the little community that I still call home. They deserve better than what we are giving them, and I'm not too proud to say that we need help. A very troubling statistic that comes from our 2015 Youth Risk Behavior Survey shows us that 19% of our high school students reported that they have seriously considered suicide in the past 12 months. The number seems extremely high to me, and I'm not okay with that. I know that we can't reach them all, but I'm willing to try, especially if that means I don't ever have to read another article about another one of my students that said suicide is a better option than living their life. Thank you. Ms. Ann Femwright, Grant Coordinator.
Good afternoon. As Mr. West illustrated, schools can play a pivotal role in early identification and intervention of mental health problems. Each year, our students spend at least 1,300 hours at school. It is prudent for school communities to lead coordinated efforts within the school and larger community for improvement of student outcomes. Through grant-funded activities and programs, we are working to identify mental health problems before they reach crisis proportions, decrease stigma and negative attitudes, and increase supports. Through a braiding of our grant funding sources, we are aligning and integrating initiatives to extend the reach of programs and activities. Our ultimate goals are to improve school climate, school safety, early identification, and increase access to school and community-based mental health services. Prevention is key for addressing problems and for fostering student growth and development. Due to student need, we have been focused on fixing immediate problems rather than preventing them. The grants will allow us to increase the number of prevention activities to decrease the time spent in a reactive manner. Our elementary and middle school classroom teachers are committed to improving student emotional well-being and mental health through the delivery of daily universal prevention curriculum. Over time, this may decrease the number of students who require more intensive supports. Additionally, evidence-based prevention curricula implemented by our health educators and school counselors include social and drug resistance skills, bullying prevention, conflict resolution, sexual abuse awareness and prevention, mental health promotion, and suicide prevention. Through district-wide trauma-sensitive schools training, staff will understand the potential impact of trauma on behavior and learning. They will learn skills and strategies to support youth in classrooms who are impacted by trauma. Restorative practices training for all middle and high school staff will encourage a more caring and responsive school climate, restore relationships when harm has occurred, as well as proactively reduce disciplinary issues. In rural communities, school personnel may be the first to notice signs and symptoms of a developing mental health problem. In youth mental health first aid training, participants learn to recognize signs and symptoms that may indicate a mental health or addictions problem and practice applying an action plan when interacting with a youth experiencing these issues. At least 125 first aiders will be trained for each year of our grants. Mental health seminars will be held quarterly to increase staff, parent, and community capacity to identify, understand, and appropriately address mental health issues. Despite the presence of prevention and mental health awareness training, we must continue to respond effectively to minimize the impact of existing mental health problems and prevent crises. A student assistance program will be implemented in our high school to identify and assess students' needs in the areas of substance abuse and mental health. A mental health screening program will allow for early identification of mental health problems at all grade levels. Both of these programs will provide support and referral to appropriate follow-up services. Safe School Ambassadors is a bystander education program that will be implemented in our middle and high school to address peer mistreatment, bullying, and violence. We have been able to have a ratio of 1 social worker to every 800 students by hiring 2 school social workers. To meet the unmet mental health needs of students, our school counselors, school social workers, school psychologists, and nurse will receive training and professional development to increase their capacity and skill set. They may be providing the only mental health supports for youth who are awaiting community-based services, or they may be the main provider for youth. Additionally, we will be adding a second school-based mental health satellite office in our schools, as well as inviting community mental health therapists to provide small groups on topics such as anxiety, managing emotions, and social skills. We are attempting to break the transportation barrier by providing transportation for students to continue mental health therapy at our in-town school-based satellite offices. Additionally, 2 school social workers or counselors will be compensated to continue their work with students throughout summer school. As you heard today, our generous grant funding of approximately $1 million this year alone provides students with the continuum of evidence-based prevention and intervention programs targeting mental health issues. For all of the activities mentioned, grant funds pay for staff, curricula, professional development, incentives for parent attendance, materials, consultants, trainers, as well as time spent on strategic implementation planning. Through collaboration with school, parents, and community partners, we are working to deliver effective and consistent mental health programs and services. Ultimately, this will create a sustainable infrastructure, eliminate barriers by improving the social and emotional development of all students, and enable learning. And to conclude our story, Mrs. Granzy.
As you've heard today, our district, while faced with many challenges, has been prevailing. We, however, would not be making the gains that we have without the numerous grants we have been awarded, which leads us to question, will we lose our social workers? Will we be able to continue to transport students to counseling appointments? Will we be able to provide youth mental health training to our staff and community members? What will happen as our total state aid continues to drop? I can tell you that our needs have not lessened because we have 63 fewer students than we had last year. Will the decrease in aid and grant monies lead us to decrease our pupil services staff? The same staff that many families expect and want their child's mental health needs to be met through? Often causing many of us to question if we are dealing with issues beyond our scope of practice. Our current staff turnover over the last 3 years is 19%. In analyzing what has led to our higher than normal staff turnover, we have identified that working with students with mental health needs is exhausting and can take the toll on the best of educators. Good educators don't leave work at work. The families touched by our staff's caring leadership can attest to that. We have been awarded approximately $1 million through these grants just this last year, which is a considerable amount of money to a district that only has an overall $19.3 million budget. How are we going to sustain our current services, which at times still fall short? As a district, it is our sincere goal to decrease the number of students who feel they do not belong at school, to increase the mental health resources we have available to our students, to not have any student consider suicide, going hungry, or being abused, to have the same resources available to my children, neighbors, and students as any other children in Wisconsin, regardless of where we live. Thank you. Do you have any questions?
I'm quite sure we do, because I know I do. Thank you very, very much for that testimony. You were very prepared. This was excellent, and thank you for what you're doing for those kids. You hit on it a little bit, and the first question is, what will happen when the grants are done? Are these one-year grants? Because I know that Bridges program, I remember, I represent part of Adams County. I remember that when that came and then went away relatively faster than I thought it was going to. What's the game plan?
I can mention the grants that we do have. We have Project Aware. That is a 5-year grant, and we are in the second year of that 5-year grant. We also have the elementary and secondary school counseling grant, and we are in year 1 of that 3-year grant.
So you have a little time, but
Exactly.
when the money's gone, it's gone, and you've got to figure out, have you figured out, Rick, how you're going to sustain this without these grants? Are you going to look at passing a referendum or something like that?
Yeah, absolutely. One of the very critical aspects of these grant programs is training staff, the youth mental health first aid that was mentioned, the trauma-sensitive schools training that was mentioned. That's training that's universal. Trauma-sensitive schools is being given to every teacher and professional staff member throughout our district this year. It's a one-day training program, and every single teacher will get it. We started youth mental health first aid last year, and probably some of the highlights I've had in education were joining groups like bus drivers, custodians, support staff, in participating in that training, which this year also will go through our teachers and professional staff, to get them to understand, because again, a lot of times our first responders, we were talking earlier about first responders, the first responders to mental health crisis are not always mental health professionals. In fact, quite often, it's many of the hardworking people throughout our buildings that may or may not even have formal education training themselves. So we need to, hopefully through these grants, we can build infrastructure and the universal understanding of mental health crisis and how to deal with it. But it does bring up, some of the questions like social workers and additional professional support. When the grants are gone, that is a point of concern. So we're trying to build that base of universal training, but the reality is, when you saw our district budget and you saw how much we're receiving in grants right now that we've submitted for, there will be a shortfall, and we're going to have to figure out in the next 2 to 4 years how we're going to continue to try to do the best we can for our kids.
When you look at the students who have these issues, have you looked at it saying, is this chemical imbalance medical or environment? Which is the leading contributor to students with mental health issues?
I think they all play a big part. I would say poverty plays a big part too.
Environment, in other words.
Environment.
Yeah. Access to health care.
Access to health care is a big one for us.
Yeah, which is environment. I mean, you're a poor district. We're going to hear from some districts that aren't poor, and it's going to be interesting to see their numbers, but just curious on what is the root cause. Other questions? If not, Senator Bewley.
Thank you very much. The grants that you have are federal.
Yes.
They're federal. And when they're done, are you able to reapply?
I think we can. We could always apply. I don't know that there would be an automatic, extension of those grants.
And would you consider yourselves lucky in getting that? I mean, how many schools in the state of Wisconsin have the kind of success with federal grants that you do?
We consider ourselves very fortunate.
Okay.
We're lucky due to our demographics.
I think demographics have a lot to play with.
Yeah.
Yeah, as far as the AWARE grant alone, there's 3 districts in Wisconsin.
Do you know what they are?
Adams Friendship, Ashland, and the Milwaukee Public
Milwaukee.
Schools.
Okay, thank you.
Okay. Any other questions? If not, thank you very, very much for being here and sharing this with us.
Up next is a group from the Baraboo School District. We have Danny Scott, Kathy Thornburg, Ann Wren, and Christina Olson.
Hey, I'm just going to chime in. This is Senator Larson. Just want to make sure my district is present.
Welcome, Senator.
Thank you, Senator.
Chris. Thank goodness for technology, right? Looks like they're leaving you high and dry.
I know, right? Jeez. All right. First of all, thank you for giving us the opportunity to present to you this afternoon. This is a topic that is very dear to all of our hearts in the Baraboo School District. And so just to reintroduce ourselves, my name is Danny Scott. I am the Student Services Director for the school district. I have with me Christina Olson, who is one of our professional school counselors at our middle school, Kathy Thornburg, who is one of our counselors at our high school, and also in the audience we have Lori Miller, who is our district administrator, and Ann Wren, who is also one of our other high school counselors as well. The Baraboo School District is about located northwest of Madison, about 50 miles from here. We have a student population of just over 3,100 students. Our percentage of students that qualify for free and reduced lunch is around 45%, but we have some of our elementary schools that are approaching 70%. Unfortunately, we do not have a federal grant to help support our efforts in this area, and actually over the last 2 years, our district has experienced over a $2 million budget deficit cut and reallocation that we have had to deal with to just maintain services for our students. The mission of our school district, however, is to prepare our students for excellence in all areas of functioning, and this includes the area of social and emotional health as well. So we're going to highlight some of the things that we have been doing in our district, as well as some of the challenges that we continue to face.
It's when Danny came to us and said, you know, we were going to be speaking down here, and some of the topics were going to be what are the things the Baraboo School District is doing to address the mental health needs in our district, and what are some of the positive things and what are some of the challenges. We reached out to all of the counselors in the district. We have 8 counselors, and asked the question, what types of things do you feel like we're doing to address the mental health needs of those students in our district? So on this slide are listed some of the things that we felt were the main things that we do to address mental health, some directly and some indirectly. At the top, we've got SEG groups, and these are groups that are actually run by our school psychologist at the high school, and we've got a video of her later, so I'll let her kind of explain what she does in the SEG groups. We've got Web and Link Crew. Web is actually a program at the middle school, and Link Crew is a program at the high school. They're transition programs for our students that are entering middle school and high school. And in an indirect way, these are helpful to our students in that our students have a mentor when they come into the middle school and high school. So at the high school level, we have 5 students to 1 with a mentor. So they're welcomed right away when they walk in the door. They have a student to go to, because as we know, at the teenage level, it's kind of easier to go to another person your age to talk to than to maybe go to an adult and share some things that are going on. So it's been a very positive program, in that, sometimes a Link Crew member that has volunteered to work with younger people came to us and said, hey, I got one of my kids that's struggling, and how can I get them some help? So they're kind of a barrier, or they're not a barrier, they're a person in between that freshman student and the counselor maybe, or the administrator that they can go to. So that's a very positive thing. Sometimes we do presentations to our staff, which might be, we'll focus on a small area, maybe it's cutting, or some type of mental health issue. We'll present to our staff when we have a chance. Collaboration with local agencies. What that means is sometimes we might have a situation come up at our school that we aren't sure how to deal with, or we're looking for a resource. We might have to call to our police department or to Department of Human Services, or maybe to one of the therapists in town, and just ask a question about, okay, how should we handle this situation, and where should we go to get some help? Collaboration might also be a student that may have been in treatment for a couple weeks, and the parents signed a release so that we can talk to the therapist to see what kind of things were done to help the students when they were in treatment, And what kinds of things can we do then at the school level to help them when they return? We've got student needs assessments. Our high school did take the youth risk behavior survey as well that Steve was talking about earlier. Mental health first aid. Ann and I have been trained as national instructors for mental health first aid. So we're trained in the adult and we were trained in the youth. So we kind of went on our own outside to do this because we were trained ourselves to be first aiders and learned the value right away. We do this every day. We do triage every day with students to figure out how to help them and recognize maybe a mental health situation that might be going on. But we thought, wow, we could really get this out to our community and to our teachers and have a lot more people trained to recognize symptoms of issues that might be going on. So we got trained in Minnesota and in Texas, went to a week-long intense training so that we could do this and provide this opportunity for our school district, for our community, and for other school districts as well. We also, I think that the last one was PBIS. I'm going to let Danny talk about that a little bit.
Yeah, so as Steve Fernan mentioned with the school mental health grant initiative, how that is braiding its efforts with positive behavioral interventions or supports, or PBIS. We have PBIS implemented across our district from our 4-year-old kindergarten programs up through our high school. So it's looking to promote and teach those positive behaviors within our school buildings and promoting the social and emotional health of our students as well. As you've heard, statistically, 1 in 5 students experiences some type of mental health crisis in their developmental years. I can guarantee you there's probably not a mental health diagnosis out there that we haven't seen within our buildings. On the screen, you'll just see some of the ones that we deal with almost on a daily basis. But what you may not realize is that 4 out of 5 of these students do not receive the professional help that they need. So schools are left as the first responders, and so we are really desperate in our efforts to try and help and support these students, but we need help in doing so.
One of the key responsibilities of schools is to create a safe and nurturing environment. This should support physical and mental health for all students while fostering their social and emotional well-being. As we collaborate within the district and work together as a team, we are fortunate that we have been able to have successes within our district. Like Kathy had mentioned, we have 2 national mental health certified trainers in our district, and we have trained approximately 90 staff. Through this training, they have provided the tools needed to reach out and help others with mental health struggles. They give them hands-on activity practice so they're more able to respond, and they gain the awareness of the mental health needs within our building. The hands-on experience also helps the staff member or the individual completing the training gain that confidence that they will need the day of or any time that they need to help others. The district-wide collaborative K-12 monthly meetings and weekly admin counselor meetings that we have is key within our district. During this time, you're able to work as a team. As you know, I always think of it as a chair, and not one person can do it alone. So you have the students, the parents, the counselors, the community services all working together. And within the district, you also need to have that chair. So counselors cannot do it alone. We need to work together as a team, with our pupil service team, with our staff, with our admin to help students and to come up with interventions and support systems. Another success we have is we have a collaboration with our community agencies. We work closely with DHS and law enforcement to help our students. We are a school, like Danny had mentioned, that has PBIS, positive behavior intervention support systems that helps to promote school-wide environment. We have this within all of our buildings at either Tier 1 or Tier 2 level. We have Web and Link Crew, which is a 6th grade transition program, but more importantly, it's more of a peer role model. It builds positive relationships, and it's another support system for those students. We were one of the schools chosen for the Wisconsin School Mental Health Project. This cohort, the first cohort, consists of 1 in 14 schools, so we are looking forward to the first training and getting on board. We're hoping through the School Mental Health Project we'll develop policies and practices that support and that will help improve our learning environment for our students.
finally, our student service support staff, our professional school counselors, and school psychologists. We're fortunate to have both school counselors and school psychologists. Both roles help educate, prevention, intervention, and referral services. As was mentioned, almost 80% of the students who need mental health services are not receiving them and are receiving them within the school. So that lies on only a few trained professionals that can do that.
We have some videos, short videos, less than 2 minutes, from several of our staff members within our district talking about how they work to support our students, so we'll show those.
Anybody good lip reader?
I was fortunate enough to take mental health training for both the adults and the youth. What I found the benefits of that was it's really taught me to dig deeper into both the adults and the students that I work with.
Yeah, if your computer does the sound, maybe the mic will pick it up. Where's a fifth grader when you need them?
It's really true.
Hmm?
That's really true.
She is one of our special education teachers who has participated in the mental health first aid training. And so working with our special education students, she talked about how daily she uses the skills that she received as part of that training to help support our students in that area.
slide before was actually our school psychologist, and she was talking about the SEG groups that she runs that I mentioned earlier. And some of the things she does, she's worked with students with anxiety, with depression. She kind of puts a survey out and sees what the need is, and she goes with the greater needs, and kids can volunteer to come down and meet, and she runs sessions for about 8 weeks during a time where it's not an academic time, that they can just come down and meet and talk and discuss some of the issues going on. So that's really been a bonus. But we have 1,000 students at the high school, and she's maybe reaching about 12 students every 8 weeks. So for the challenges, we definitely have challenges at Baraboo High School and Baraboo School District, and some of them most recently have been the budget cuts with agencies like Lutheran Social Services. We were blessed for the last maybe 8 years that Lutheran Social Services came in, a therapist, and would work with our students for free. And so we had students that could access services from our therapist, and for whatever issues are going on in their lives. It was kind of nice for our kids because it was an outside person, someone that they didn't know that they could go and talk to about whatever issues were going on. And they didn't have to make an appointment outside of school that interrupted school time. It could be at a time that was kind of a downtime at school for them to be able to meet, so it was really a bonus. And it was, I think in October, the therapist came to us and said, we just had budget cuts and I'm done. So, which left a bunch of our kids without services and kind of in the middle of some therapy with this person. So we were really sad about that losing this service. I know a lot of districts don't have that, being a free service coming in, and we were very lucky, but it was really a big loss. Intervisions is another place we have in the community that a little bit different. It did cost families, and they could use insurance to pay for counseling, but we lost that service as well to budget cuts this year. We did have a school social worker for 1 year, which was last year, and again, we just got her up and running and got some great things going, and lost the school social worker due to budget cuts as well. We put the professional school counselor role up there. That's what Christina and I are, and I said we have 8 school counselors in the district, but the reason we put that as a challenge is there's a misunderstanding, I think, that school counselors are able to do therapy. We are not trained therapists. We're not mental health experts. We're school counselors. So we work on social, academic, career, quite a range of things, but we cannot do therapy for students. So once it gets to the point when we're meeting with a student and we realize that maybe this is more a serious issue, it might be depression, or they're having some severe, maybe it's bipolar disorder, or they are a suicidal student, we have to reach out for other services. So that means, we might contact the parent and say, here's some resources in the community you can use, hopefully if you have insurance, but we aren't able to do all of that in the school district. So I think sometimes people that aren't involved in schools think, well, we've got counselors that can handle that. We're not completely able to. We can kind of do the triage at our level and assess the situation, but when it becomes more serious, we have to reach out for other help. Time, resources, and space needed to address student mental health needs are always an issue. Time being that our kids are busy and staff is busy. Got a lot of things that they have to accomplish throughout the day. So sometimes that the mental health needs of our students get pushed aside or just not recognized because people are busy. Limited places to send students that need long-term treatment. We have some students with some pretty serious mental illness problems, and we've had students with suicide attempts, or to the point where they were thinking about an attempt, and we need to get them some help. And we start with Department of Human Services, or it might be the police department, and they will go from there, do their assessment, and take it to the next level. We've had students that go into treatment for a couple weeks, but it's pretty rare that we can get that service, or a student can get that, because there aren't places for kids to go. And 2 weeks really isn't long enough for them to come back and be ready to read and write and do math, because if their illness is severe enough, the 2 weeks isn't going to do it. It helps. It's kind of a Band-Aid,
but they come right back into the school system, and then we try to educate. And the last being the money for continuing professional development. We mentioned the mental health first aid. We have trainers in the district, but there's a lot of great workshops and things that we would like to send our staff to or bring into our district, but money is definitely an issue for being able to do that.
Some continuing needs that we face as a district that we've kind of highlighted previously, as well as you've heard from our Adams Friendship peers as well, is collaboration with our community mental health agencies. I want to share with you a story that happened yesterday, actually, in one of our buildings in our district. We had a student experiencing a mental health crisis. This particular student has a county-appointed social worker. We reached out to that individual for support while trying to keep the student at school while they are experiencing this crisis. The county social worker placed a call down to Meritor, which is one of the only community-based inpatient child psychiatric units available in southwestern Wisconsin. Meritor told us this student's needs were too severe. They wouldn't take him. So guess what? He's left in our building for us to try and support. So those are some of the challenges that we face on a daily basis. We continue to struggle with off-site alternative education options. There are some students in our district that have such severe mental health needs they cannot be educated within our four walls. It's not a good environment for them. So we get creative. We have students coming into our buildings for services after school. We have staff that are willing to stay after school for hours to work with these students because they cannot function within the school building with all of their peers in that building due to anxiety or depression or whatever mental health issue they may be facing. Education for parents. This is unfortunately a topic that still faces a lot of stigma in our community and in our society, and so educating our parents is a continuing need about exactly what a mental health crisis is and what a mental health need is. Parents seem to have no problem understanding diabetes or asthma, but when you talk about anxiety or depression or psychosis, that's just a foreign topic to them that they really need our support in helping to understand. Wraparound services. We are fortunate that our county does provide wraparound services, but they have a waiting list. And so that leaves students, again, attending our buildings every day that don't have the supports that they need in order to be successful. As we're starting our budget discussions for the 2016-17 school year, one of the identified needs that we've placed at the top of our wish list is behavior interventionist. We have interventionists for reading. We have interventionists for math. We have gifted and talented interventionists to support our high academic learners. One thing we don't have is behavior interventionists to support our students with those significant mental health needs. So as a district, we're hoping that we'll be able to fund that type of a position for our district moving forward. So what can you do to help? Recognizing youth mental health as a priority is a first great step. Until we can reduce the stigma around this topic, unfortunately, our movement across this nation will not get any traction. Support accessibility for children and youth who are uninsured or underinsured. As Christina mentioned, we attempted to bring in one of our outside counseling agencies to provide services within our school building, but due to insurance issues, that we weren't able to provide those services for our families. Support academic and functional outcomes for children and youth with a mental health diagnosis. Support identification of mental health issues for children and youth through mandatory screenings. We do mandatory screenings for academic needs. Why not mental health needs? Create a school-linked mental health grant program that's similar to what's been successful in the state of Minnesota, that provides financial dollars for districts to collaborate with outside partners and to bring mental health service agencies to operate satellite clinics within our school buildings. And finally, allocate additional dollars for student services staff and behavior interventionists. As Christina and Kathy mentioned, we were fortunate enough to have a school social worker, one school social worker serving our student population of 3,000 students for 1 year, and then we lost that position due to budget cuts. I would like to end our presentation with this quote. This is from Gordon Smith. So we take our kids for physical vaccinations, dental exams, eye checkups. When do we think to take our son or daughter for a mental health checkup? This has become a national crisis and one that our staff and our students are facing every single day. So thank you for your time. Be happy to answer any questions you might have.
Thank you very much for that presentation. As I listened to Adam's Friendship and you ladies from Baraboo, I was thinking about the perception that people have of public schools in our state, in our country, that you're only there just educating kids. And then I see what you're doing that isn't educating kids. It's helping cure kids to a point in dealing with serious mental health issues that I don't think you get enough credit for or enough support for. And it really concerns me if we go down the road where parents have choice and can do whatever they want, money following the kids. Who are you going to be left with? And what is it going to cost to take care of a larger percent of kids that you have in your school district that require intensive, expensive services, because that's what you got to do. And then at the same time, holding you accountable for the outcomes on report cards and things like this. Do you want to respond to that at all? 'Cause I'm sure you do.
Can I actually add to that? Let's see if this works. Yes. When we look at the students and the needs that they have, we also have to look at the staff. So those that are still left in the building working with these students, we experience that secondhand trauma with working with their families day in, day out. I can't tell you how many times on weekends or nights or mornings you're taking phone calls, or you're working with those families, or you're going to pick up kids or go drop off kids, or they're in a mental health crisis, you'll drive down to Merida to see them. But then you also have to look at your own family. And then you're walking back in the building and you have 10 students that you may be working closely with, one with an eating disorder, one that's suicidal, one that's self-harm. What about the staff? What about that counselor? What about that person? How can we help them to keep mentally healthy? Otherwise, what we'll leave is, like Adam's talked about, their turnover rate. Staff are going to start turning over. And because of burnout, because of that secondhand trauma that they're experiencing, and that's not good for the child. So not only we look at for what we can do for the child, but also what can we do for our staff members to keep them mentally healthy.
Any other questions? Senator Nass.
I certainly don't expect you to answer this as it's, I suspect, pretty deep. We can look at the costs right now, and certainly there's a lack of funding, admittedly, for a number of areas and other obligations that the state has. But in this case, as in others, there's getting to the root of the problem. I mean, we can address the kids now, and that's a good thing, no doubt, but they're going to keep coming. I suspect it's probably divorce, drugs and alcohol, child abuse. When I grew up, I just did not see it like it is today. No way. And so we in the legislature and elsewhere in the various departments need to try to get at the root of the problem. Are there other things that, I guess some of those contributing factors that we can, and that's difficult, obviously, trying to get at the divorce rate. We can deal with child abuse and some other things. But anyway, I think that's where, in the end, we got to go to try to stop the tide from coming in at a greater rate than it is. I don't know. There's not really a question, I guess. It's just more of a frustration.
Well, let me expound on what Steve says, because I think he's right. And I wonder, we heard Adam's Friendship. They have huge poverty. It seems like everything I read, the bottom denominator on a lot of this is poverty, which causes divorce, which causes self-medication, which causes all these things. Is that what you're finding in Baraboo at all, or?
I think that's certainly a contributing factor. For example, we have, I think our families are under a great deal of stress these days. Either a single parent family or a two-parent family working long hours to support their family economically. For example, I know of a family where the children, it's a single mom working. Students stay up until 2 a.m. in the morning because that's when mom gets home from work. That's if they want to see mom, that's when they need to interact with her, which then leads to the students coming late to school every day. So it's just a compounding factor. So I think certainly poverty is a pretty significant piece of the puzzle, in my opinion.
Thank you. Any other questions? Oh, Senator Risser.
Well, thank you for your presentation. While money won't solve all the problems, more money would help a little bit. Seems to me like, Senator Olson, that maybe a presentation like this should be given to the Finance Committee. After all, they have control of the purse strings, and we can give them higher ideas. But it certainly is true that there's a point of diminishing returns. You can cut just so much. And in some cases, it's obvious to me that we've overcut. That's our decision. We have to decide where to draw the line. But the Finance Committee is the one that turns around and decides pretty much what to do with the money. And I think a presentation like this could well be made to the Finance Committee if they'd take time to listen.
Well, you got two members right here, and you got the co-chair. So I think we're all ears, aren't we, Senator Darling?
We'd be more than happy to come back.
I think we might have you come back. Thank you very much for coming.
Thank you.
Sharing your story and what you're doing.
Thank you.
Up next, we have another group from La Crosse School District, Regina Siegel, Alicia Place, and Christine Madison.
Welcome, ladies.
Thank you. Thank you.
Come on, let's be friendly, ladies. Come on. You're all from La Crosse. You got to ride home together, I'll bet you. Regina doesn't bite, I'm pretty sure.
Not today. Good afternoon. Are you able to hear me okay?
Very good.
Great. Well, thank you so much, Senator Olson and other senators here of the Education Committee, for allowing us to come before you today. My name is Regina Siegel. I'm the Director of Pupil Services for the School District of La Crosse. With me, I have Ms. Alicia Place. She is a social worker for La Crosse, and Ms. Christine Madison, who is a kindergarten teacher in La Crosse. We are going to talk to you a little bit about La Crosse and some of the situations that we're facing, but I thought today that you would get a lot of information and data and statistics, and you might like to hear a story from the heart. And we are going to share with you just a little snapshot into a kindergarten classroom in an elementary school and some of the mental health concerns that we are seeing there. So, we come before you today as educators, as parents of the School District of La Crosse, as collaborators with our community, and as advocates who believe that healthy children, families, faculty members, and community members are necessary to make our community stronger, in La Crosse we are a very vibrant community who believe in collaboration, and not only believe in collaboration but expect it of all organizations. Please understand that when I talk about a healthy community and healthy children and families, I'm referring to the physical, social, emotional, and behavioral health of our children, not only that of academic health and physical health. We are pleased to be asked to share our journey with you today towards creating a healthier Wisconsin. As Steve mentioned before, Mr. Fernan, we struggle with increasing behaviors, and I think you've heard this as a theme throughout the day. We see in La Crosse behavior of a child as a way of communication. So when we see behavior that is absolutely unacceptable in the classroom, that's impairing the learning of other children, we see that as a cry for help and look to find the source of that and work with the family and the community and the child to address that need. Our school psychologists and school social workers are trained as mental health providers and are able to provide some levels of mental health supports for our students, along with our wonderful counselors and nurses and other pupil services staff. But as our counselors spoke about earlier, there's so much more that is in the position that they have that they are not able to address all of the individual needs of all of the students who come. We are seeing in La Crosse more and more younger students truly struggling with mental health issues that before we only saw in our older youth. We used to be dealing primarily with issues of suicide prevention, of AODA use, of weapons and violence at the secondary level, and now we have preschoolers who are having complete mental health breakdowns to the point of not being able to be physically in a classroom because they are sobbing and crying and defecating and doing things that are their way of communicating their need for help and services. We have therapists coming into our schools who are saying, this child needs so much more help than you as a school are able to provide at this time, and we work with them to meet those needs. So I will be bringing the district perspective and briefly talk about some of the structures, policies, and procedures that we've put in place in La Crosse to help address these needs. And then Ms. Madison and Ms. Place will be the heart, so to speak, of our presentation and will help paint a picture of the face of what a child struggling with mental health needs looks like in our schools. So as we collaborate to meet the needs of children and families, I'm going to speak briefly about our Rebuilding for Learning effort and in specific our mental health liaison partnerships that we've created in the school district of La Crosse. We have about 32 programs in our district that address mental health from a universal area of working with all our students to that individual level. But I'm choosing to focus on this mental health partnership today. And then again, for Emerson Elementary School, a brief case study of one of our youth. So 5 years ago, we began working with Edelman and Taylor from the university, from UCLA. And we worked with them, spoke with them, found out about ways that they are seeing huge gains in mental health and community collaboration in healthy communities and healthy schools and productive schools. And part of what they really worked with us on and that we in turn have taken into our district is the old idea of taking a whole village, and that it's not just the public schools that are educating and supporting our students. So in La Crosse, our county supervisor, Steve O'Malley, our mayor, Tim Cabot, our superintendent, Randy Nelson, and many of our community partners, both from private businesses and our public sector, work together regularly and get together regularly to talk about issues that affect La Crosse for youth and families within our schools, as well as the whole community. So working together, we're addressing issues like mental health needs, physically healthy and safe communities. And then some of our partners that meet annually for our Rebuilding for Learning Summit are health systems and hospitals, our private and public therapists and counselors, some of our nonprofits, such as the Boys and Girls Club, the Y, our community foundation, a St. Clair Health Mission, Family Neighborhood Clinic, and our cultural and faith-based organizations and higher learning institutions. And I have a brief video at the end if we have time to show you a little bit about that. We began with just a meeting truly of our mayor, our county supervisor, and our superintendent, and that small group has grown to our last Rebuilding for Learning Summit this past summer, which had almost 300 folks from different organizations, of which the school district had, I believe, fewer than 25 people there. So in your handout, it's got the blue writing on the front, the Community Liaison Mental Health Supports. Just briefly, I thought I'd share with you that out of this Rebuilding for Learning effort, we are building, we're networking and building partnerships with folks whom we wouldn't have necessarily interacted with on a regular basis before in our work. And starting in elementary school, at the time I was the principal at Emerson for a decade and had the opportunity to work with Alicia in that role. We began partnering with, who is now, the woman is now the head of our pediatric behavioral health unit at Genrich. And we started talking to her because we were working with some of these situations in our site-based teams with students that we weren't quite sure what else we could do. We had done 20, 30, 40 things for a student and intervention and made community and family connections, and we still weren't meeting all of the needs of the child. So we brought in Dr. Olsendorf, and she worked with us and would listen to the cases, and she was available to both Ms. Place and myself via phone and email and visit. She would come in and observe students when we had releases and really helped guide us and support us with the student and their needs. And so out of that, we created voluntary partnerships. We have a structured program that are called these mental health liaisons between the schools and mental health specialists. We ask for them to make a commitment of about 10 minutes to an hour a month. That is all that we ask. Some of our specialists we have are therapists at the county, at our hospitals in town, private and community-based therapists. We have the head of the school psychology department at the University of Wisconsin-La Crosse, and other private therapists in the community who specialize in mental health. And the focus of these liaisons is supporting the adults who support children. I'm very concerned about Christine and Alicia and our staff members who, like our previous school district was talking about, work with these very significant needs day in and day out. What kind of self-care are they getting, and how can we best support them? Our mental health liaisons are another professional, another support, a safe haven where they can share their concerns and their needs and know that there's no judgment. Let's talk about what would be the next step. Let's work together to meet the needs of the child. So it's really focusing on the staff and supports. Some of the activities that have come out of that are mental health liaisons have conducted needs assessments in our schools to find out what it is that staff members see as the primary issues in the schools related to mental health. There's been staff development. So, for example, at Emerson, I was surprised to learn that there were a lot of questions with depression in elementary students. Teachers, kindergarten teachers, second grade teachers, fourth grade teachers were seeing depression amongst their students, wanting to know how to work with that. Work with students who had some personality disorders. So Dr. Olsendorf came in and did a 1 or 2 hour staff development program for us based on bipolar disorder and talking about that and depression. Overextended youth, that's something we see a great deal. Navigating the mental health system so that Ms. Madison, when she meets with the parent, is able to in turn talk to that parent and in a safe way that the parent will know both Ms. Madison, be able to meet directly with our mental health liaison if they wish and get the support that they need for their child. Our mental health liaisons sometimes have come to parent-teacher conferences free of charge, supported by their hospital or clinic or business, and are on hand for parents. We've had standing room only when we say Dr. Olsendorf is going to be there. You're welcome to come if you have concerns about behaviors or mental health in your family, discipline, that kind of thing. Parents are standing room only, want to talk to someone and get supports. So for Emerson Elementary School, we're going to talk a little bit about a young man, and Ms. Madison will be introducing him to you, who struggled in the area of mental health. He had wraparound supports from our community as a result of our Rebuilding for Learning efforts and our personnel in the schools. And we'll introduce you to little William now. Ms. Place, would you like to talk a little bit about Emerson?
So, Emerson Elementary is about 400 students pre-K through 5 in La Crosse, the heart of La Crosse. We're actually located right next to the university. So we have a wealth of resources being so close to the university and wonderful nature centers. But we also have the highest percentage of homeless students that attend Emerson because of 2 local shelters in La Crosse. The students go to Emerson. So the Salvation Army and then our women's shelter. So we have quite a dichotomy of students because we literally have kids who are living in vans and campers and at shelters, and we also have students who live in multi-million-dollar homes, as you see here. But I really want to make it clear that mental health really does not see boundaries. It's in all socioeconomic classes, racial, ethnic groups. We see it everywhere. This is my 11th year as a school social worker, and I remember early on in my career going to meetings with our community partners at the county and juvenile justice and talking about all these programs for kids 12 and older. You had to be 12, you had to be 12. And I remember saying, like, well, what about our preschoolers and our kindergartners? And I think that over the 11 years, we have just gotten more awareness about what trauma does to children. And so I think to address some of the questions you had earlier, I think there is just more of an awareness of some of what we're seeing, although I do think the rate at which we're seeing things is also increasing. For reasons like poverty, I think the environments that we allow children to live in creates a lot of issues for them when they come to school. So it really spans many, we talked about Children's Code 48 criminal codes, laws, things that our county can and can't do to protect our children, things that we can and can't do. So at Emerson, we had a student, William, who we first met. He came to us January of his preschool year, so he was 4 years old, middle of the year. He and his mom and 4 siblings, he was the middle child of 5, had come to La Crosse to escape a very dangerous domestic violence situation from a different state. And very, very violent situation with mom, and the kids were also, what mom reported, were victims of dad's abuse. When William first came to us, he was what we kind of thought a pretty typical 4-year-old preschool boy, had a hard time sitting and a hard time focusing, and mom was very concerned, but we really just worked with it, and really it seems like it's going to be okay. And for the most part, we were able to just really maintain him in that preschool classroom. At the end of his preschool year, he missed the last about 3 weeks of school. Preschool isn't mandatory. And mom just kept telling us that he's so out of control we wouldn't be able to handle him. So we really ended the year with not seeing him. In the fall of his kindergarten year, the family came to open house and then disappeared for over 3 weeks. I nearly every day tried calling different numbers I had to locate the family. Eventually connected with them. They were living in a local motel, mom, her 5 children, and her new boyfriend. So when the family came back to school, it was just markedly different with the children, with this new boyfriend in the home. A lot had changed. They're now homeless, living in a motel. This new boyfriend has a very significant history of violence. The kids just were different. The year before, they were very open with me. Mom was very willing for services. They came back the next year and they were very guarded, and things were just very different. I don't know that mom could see or would see that her children struggle, maybe because of the boyfriend and past experiences now being relived with trauma. So when William came back to us, it was a very different story for him.
So after I met William, within the first 3 weeks of school, when he started to attend, he joined my classroom. And it didn't take long to realize that the quality training that I had and my 4 years of education did not prepare me for what I was about to encounter with little William. So some of the things that William would do in the classroom were not typical of other kindergarten students. He would have frequent meltdowns, which would consist of crying, screaming, slumping to the floor, kicking his legs, throwing chairs, crumpling up any paper or activity that we were working on. He would act very similar to what you would see in a 2-year-old's tantrums. And one of the only skills he had to cope with anything was to suck his 2 fingers. And I can picture right now him sitting in his little chair and just all balled up in his little 2 fingers. When anything wouldn't go exactly how he had anticipated going. He couldn't transition from one thing to another. One of the only safe spaces he found in our classroom was hiding under my chair and banging his head against the desk. And it didn't, if things didn't go exactly how he wanted, he would struggle. So my concerns became not only about little William and his safety, but the safety of all the children in the classroom, in addition to academics and how am I going to teach them how to read and all of those things. So there were several challenges, one of them being that I was the only one in the classroom, so I didn't have any teacher assistants or additional supports. He required an incredible amount of attention, energy, and focus. And it became a question of how am I going to meet his needs along with all of the other children in the class. I had daily communication with phone calls with mom and boyfriend, who William started to call Daddy after being in the relationship with him for 2 weeks or so. He was Daddy. Very bizarre conversations that quickly we began to realize something was not right. I had concerns from other parents in my classroom at parent-teacher conferences where they would ask me about William and how what they could do to support him, concerns about him and how he was going to be successful and how they could encourage their own children to help him be successful and ensuring their safety and academic success as well. With this, I began to look for other resources to help me. So I went to Alicia, our social worker, to find out ways that I could best help William in the classroom.
So, Christine and I talk, it's one thing for the social worker, the principal, someone in the building to support her, and to talk about what we can do, but it's the day-to-day, every day, from 8 a.m. to 3:10, William's in her classroom. And so it's one thing to talk about how are we going to help, and another to actually get things going and to do. So because of some of our partnerships with the community and our mental health liaison and knowledge of trauma, I was able to pull mom in and really get her agreeable to doing some counseling, some therapy for the kids. I think a part of her did want that help, wanted her kids to get better, and I think a part of her was looking for a diagnosis, but deep down, obviously, I know that she wanted her kids to get help. So because of her situation, they were still in the motel. Mom's vehicle no longer worked. We did some school-based therapy, so we were able to get a therapist who would be coming into the school and was able to see all 4 of the school-age siblings together, in one afternoon. She'd see them individually, but see them all at school. So the benefits of that, as you can imagine, is she is one person seeing the whole family. And as a school, I know the gentleman from DPI mentioned in the beginning about Medicaid doesn't reimburse for the informal consultations. We were very fortunate that his therapist, Carla Fenney, often stopped in my office first to say, okay, what's been going on the last few days? Where are things at? What's been happening? What have you heard from Mom? She would talk with Christine before and after the appointments, and she would just volunteer her time. She came in to do some problem-solving team meetings with us to talk about what we could be doing different, and she was able to use language with William in her therapy sessions that we used at school. So we were using similar language to teach him calming down techniques and how to handle himself. Another benefit of Carla is throughout this whole process, as you can imagine, and Christine will talk a little bit more about this, we suspected abuse happening, in addition to the past abuse that these children had all been suffering. But William was very coached, and so sometimes the things that we would see, or the things that he would say, or that gut feeling we had was not enough for County Human Services to open a case, but it was enough that we could tell Carla, hey, here's the latest thing. And so it was one of those things that we just had to kind of keep nitpicking along the way, and keep calling the county, and eventually the county did get involved. There was enough for that as well. And so I'll let Christine kind of tell you a little bit more about some of his reports, and then.
And in addition to the therapy he was receiving, the therapist was specially trained in dealing with children who had trauma. So no training that I had or would allow me to support him in a way that she could. So that was one thing that was so helpful for him. So we started to, as Alicia mentioned, we started to see indications of abuse. I saw bruises. He would, and when I would ask him about things, he would just say, he would have this long, elaborate story. And when I would talk to Alicia about it, the siblings had shared this exact same rehearsed, bizarre, elaborate story. Then one day, he would miss school, and he would come back with some kind of physical mark. One time he had a big goose egg on his forehead, and a few days after, it was scabbed over. And initially I say, oh, what happened, William? And he said, he didn't mean to do it. He didn't mean to do it. My daddy loves me. My daddy loves me. And so right there's a red flag. And then after that, he would say, why do you ask me about my owies? Or don't tell Mrs. Place. I'm not supposed to tell, and don't tell Mrs. Place any of this. And one of the most heartbreaking things that happened was he came to school with a new tattoo that Daddy had given him. And what it was on his chest, his Mom's boyfriend had written, I'm a gay little boy, go Pecker go. And just the fact that someone would do that to a 5-year-old child and he didn't even understand is just beyond me. And he was expected to be in school and to learn. I'm sorry. So anyways, with the collaboration of his therapist, myself, and Alicia, we were able to get Wyatt into a safer environment. Eventually, there was a situation where Mom took the blame for one of the abuse situations, and even after realizing her children would be taken away, she still wouldn't admit that he had done it when they had disclosed it. He had done it. So, with that said, we did make, this is a happy story because he did make games.
Good, we're hoping so.
I'm going to say, can I just jump in for you? Yeah, just give me a minute. So eventually we were able to work with County Human Services. They finally had enough to place all the children into foster care. And it was almost immediate when they were placed into foster care, the actual relief that we saw in the kids. Being more open with us, they just felt safer. You could tell it was like no longer that they needed to hide. They were luckily placed in a couple of wonderful homes. The kids had to be split up because there was no one that could take all 5 of the children. So
through that, the therapist was able to continue therapy throughout the summer, and now William moved to our neighboring district because his foster family is in the neighboring district, and Carla's been able to maintain that therapeutic relationship with him. And so what we were able to start last November is able to stay with him. She's working with the foster family. She's still working with all the siblings, even though they're in separate homes. So I feel like our collaboration and what we were able to get started has really benefited the whole family, really. And, you know, they haven't been able to be returned to mom. She is still choosing some bad things with boyfriend over the children at this point, but I feel like at least he's in a good, safe place.
He's safe, and he made academic gains, he made social gains, he had friendships at the end of the year. The last day of school, he noticed some of the other children were giving me some going away gifts that they had made or that the families had bought, and he said, I don't have anything to give you. And I said, oh, your smile is all I need. And then he, to back up a little bit, a few weeks prior, he had this little blue dinosaur that had been his most prized possession, that had caused lots of drama in our classroom, and he came up to me a few hours before we were going to go home, and he gave me his little blue dinosaur and said, I want you to have this. So anyways, he's doing well. I think about him often and the impact that other children with mental health issues have in the classroom and the struggles they face.
And what we were able to do then with William and with his therapy, because of some of our collaborations and partnerships and releases that we have, and people who know me might say that I'm known more for asking for forgiveness than permission, and all within the law, of course. But we have done some things in La Crosse that I'm really excited about, and that have really opened a lot of new ways of communication. And as part of our Rebuilding for Learning efforts in La Crosse, we had folks there who said, you know what? Let's write a grant where we can have some of our community mental health professionals who are trained in trauma-informed cognitive behavioral therapy, so that we have 40 or 50 therapists from areas not just in La Crosse, but who can work with our students specifically on trauma such as those that William endured, and with his whole family. And it really has been a blessing to our district. Another result of Rebuilding for Learning is our Boys and Girls Club. So working with these now over 300 people, our Boys and Girls Club wrote a grant and worked with their board, and they have hired a full-time mental health therapist that's located in our Boys and Girls Clubs in La Crosse and across the river in Minnesota, and work with the students and families on a regular basis. Similarly, the YMCA has hired a family and student liaison who works with mental health providers and schools and collaborates. La Crosse County, another one of our partners in this effort, has written a grant and delegated funds, and the board has made an ongoing commitment for neighborhood social workers who, unlike typical social workers, do not have a full caseload, but are able to have hours right in our schools and be on hand for parents and become a liaison, and their offices are right in the neighborhoods, in buildings in the neighborhoods and homes. We also have new police community liaison workers who similarly they don't have specific roles other than to build relationships and trust amongst the La Crosse community, so that when they come into the homes and work with families, everyone is at the table and the family knows these people and their faces that they're familiar with and trust. So we feel that Emerson is, and William is just one example, and I have this all the way through, of course, our 21-year-olds who we serve in the school district of La Crosse. But I'm a firm believer, being an elementary, middle, and high school principal prior to my previous role as pupil service director, that it starts young. And young William, who we knew at 4 years old, was struggling when he becomes a high school student and needs additional supports. I think the more that we can do for intervention and prevention at all levels, from actual prenatal care to adulthood, is so needed, and I'm so thankful that you have invited us here to share our story. So with Little William, there's Emerson Elementary, his school. When we have Miss Madison and Miss Place working at the school level and district level supports in our district, along with community providers such as his counseling service, we let our students know that they're connected, they're a part of us, they're important to us, and they are not alone. And we will be committed to them, and we're thankful that the state of Wisconsin is committed to our youth as well. So thank you for your time. If you have any questions or...
Again, thank you for that story. You know, we hear lots of numbers and things, but when you give us a story of what's going on, it really hits home hard what you're dealing with. And they didn't train you to do that in college, I'm pretty sure.
And this was Christine's second year.
Yeah,
so
it was
Oh, great.
Yeah.
So anyway,
But I've learned a lot. Now I feel more prepared. So
yeah. Well, unfortunately, you will probably have to deal with more of these in
Exactly.
the future. Any questions, Senator Bewley?
It sounds like you're awfully well-trained in trauma-informed care and ACEs. Okay, where did you get that?
Well, it began actually with Dr. Olsendorf at Emerson, and she came in and did some informal training with us and ACEs, and then we have an annual Rebuilding for Learning Summit, and we continued with training there. And then in our schools, our counselors, social workers are highly trained. We are able to support them in staff development.
Do you find the fact that you're all familiar with it and the language involved in it and the basic, is that helpful to you as a community when everybody gets trauma-informed care and ACEs? Is that...
Absolutely. Yeah, and I would say just our building specifically, the rest of the staff, not just specifically we are just getting trained. Our principal is bringing in some outside resources that are training us specifically in it. And hearing other people today, and when I hear those words, knowing what they're talking about, and then I can look for that in my students. I think,
Absolutely.
What else would be better than that? Yes.
Yeah, okay. Then I want to ask you what you would have done in my situation so that maybe you can help me. I was at a panel with other legislators who I do not need to name them, but we were talking about it. This was a room full of superintendents and principals, and they were describing the mental health challenges, not quite in the depth of what you did, but just in general, in all of the school districts, and of course this is in the north. And a legislator who was listening said, "You are supposed to be teachers. Your job is teaching. This psychology stuff is not your job."
So we know that when children...
And I was dumbfounded, and of course, so...
Many things come to mind.
And I agree. We are there to educate children, on many fronts, I would venture to say. But we know through research and through physiology, psychology, that if children are in their fight or flight mode, there's nothing that's coming until they feel safe and they have a caring adult who is connected to them. There isn't going to be any learning going on or teaching for the whole classroom, as it was with this young man. So I'm a firm believer, I think we as a district, that we have to treat the whole child. It's not something we're asking to do, going and looking for more things to do with our district resources, but that is, in order to educate the child, we have to have the child present and with us and able to learn.
And with the connections that you have and the staffing that you have a school social worker. How many school districts do you know of that have a school social worker? Even some have school psychologists. It's like, whoa.
So we have counselors or social workers, so it's not ideal. Ideally, we'd have a team, but for our elementaries, they have a counselor or a social worker who is partners with that school. And then, for example, Ms. Place also does, she does some classroom guidance. She's in the classrooms, all of our classrooms. Our counselors, we've done a lot of training with our staff because our counselors also are doing some of the traditional social work pieces of the position. And it's been tough with limited resources. We're doing the best that we
But you're
can.
able to keep them on.
And I would say my first 6 years in the district, I rotated between 3 different schools.
and what I was able to do in 3 different schools is so vastly different than what I can do being in one school every day, building relationships, being there as a support person. So when we talk about adding staff and having more resources available, it's so important.
Can you imagine the schools who don't have a social worker?
No,
Yeah.
because I'm just thinking right now what I would have done without a
What would you have done without one? Right. Yeah. Well, there's a lot that don't,
Right,
obviously. Yeah.
exactly.
Okay. Thank you.
And I just wanted to add, the National Child Protection Training Center used to be out of Winona State University, and Gunderson Lutheran about 2 years ago acquired them, and that's now a part of Gunderson Lutheran. So there's all sorts of grants and things. So Gunderson Lutheran is actually, their staff is who have been training us on the trauma-informed care, and it just might be a resource for other areas of the state to look to Gunderson since they have the National Training Protection, Child Abuse Training Protection.
Okay, thank you very, very much. We appreciate your taking the time, coming down and sharing your story with us, for everything you're doing.
Up next, we have the Menasha Joint School District, Chris Vanderhayden, Mary Winsett, Brenda Litwin, and Marcina Theory.
Chris, you shaved the beard. Oh, okay.
Okay, can you hear me? Do I have it on or did I turn it off? We good?
I don't know, try it the other way too, we'll see.
What, good? Are we good? Yeah, I think good. Okay, first again, thank you, Senator Olson and committee for giving us the opportunity to come here today and share our specific efforts to address the mental health needs of the students and families in our area. Today I have with me Mary Wisnett from United Way Fox Cities, Marcy Theory, who's our Director of Student Services in Menasha Joint School District, Brenda Litwin, who's the head of our Menasha High School Counseling Department, and I'm Chris Vanderhayden, Superintendent of Schools in Menasha. Menasha is a town of about 17,000 located on the northwest corner of Lake Winnebago, kind of sandwiched between Neenah and Appleton up in the Fox Valley area. We have about 3,800 students that we serve, and we have a poverty rate, although not as high as our colleagues from Adams Friendship, of about 60%, which is actually pretty high for our area up there. We're kind of a pocket of high poverty up in that Fox Valley region. We have 2 of our schools who were recognized for their efforts in PBIS last year by the state of Wisconsin, so we're making good efforts in that, good strides in those regards. I'm going to have Mary start out and talk with you about the PATH program, which it started in Menasha, but impacts many of the schools in the Fox Valley region. So I'll turn things over to Mary.
Thanks, Chris. And thank you for allowing us to talk to you today about our PATH program in the Fox Cities. PATH stands for Providing Access to Healing, and it's a school-based program that's designed to increase access to care. And one of the things that we had seen in the Fox City is very similar to what you've heard all afternoon long about the high rates of children with depression, anxiety, suicide rates. We were experiencing all of those same things in the Fox Cities. And so we were looking at reasons why kids were not getting the care that they needed. And in studying the issue, we found that there are a lot of barriers to care in the community. While we have great providers that are out there and are willing to take on kids and willing to provide services, kids aren't always getting to those clinics. And it could be barriers that include lack of financial resources, lack of reliable transportation for low-income families that can't necessarily always get their child to an appointment, parent work schedules, if parents work in entry-level positions or work part-time jobs or maybe work 2 jobs, they aren't always able to get time off during the day to take their child to an appointment. Certainly, stigma of mental health is a barrier to care, as well as, unfortunately, lack of parent engagement. Sometimes parents are faced with mental health issues and just really can't take their child to an appointment. So we began the PATH program in 2008 as a pilot in the Menasha Joint School District. And we provided therapists in all 3 levels, elementary, middle, and high school, because we wanted to get a sense of where was the greatest need and, quite frankly, where were we going to see the greatest results. The pilot ran for 3 years, and we had enormous success. And so as a result, we had other districts coming to us asking for the same services. So now, starting in 2011, we expanded the program over a 2-year period, and now we serve a total of 10 districts. So in addition to Menasha, we serve Appleton, Freedom, Hortonville, Kimberly Little Chute, Kaukauna, Seymour, and Shiocton. The services are provided by licensed therapists, so it's the same level of therapy that would be provided in a community clinic. And we work with a consortium of providers, so it's 3 mental health agencies that work together. So in some cases, to staff a particular school district, we might have more than one agency involved. It's got a little bit more complicated now that there's a school licensure rule that all of the school needs to be licensed as a branch office, but we've been able to work through that. We are not in every school in every district. We wish we could be, but resources are limited. So right now we are in those 10 school districts, we are in 29 schools. And PATH is also operated year-round, so it's not just during the school year. And we've been able to work very closely with all of the buildings, and many of them are open to us during the summers and during school breaks so that we can provide the therapy right there in the schools. So the question, why school-based? Why did we choose to do it that way as opposed to another route? Well, certainly when we looked at all of the reasons why kids had barriers to care, we felt that school was probably the most logical place to locate therapy. Hopefully that's where kids are spending most of their time. So if we can't bring the child to an appointment in the clinic, let's bring the clinic to the child and where they're spending their most time, and that would be the school. So it eliminates the barrier around transportation, parent work schedules, and things of that sort. Because United Way is involved, services are provided regardless of ability to pay, so that eliminates many of the financial barriers that some of our parents face. But I should really should stress that it's not always financial barriers that are the biggest issue for parents. It's a lot of the other things too that we see, and not just necessarily financial. We also found that for a school-based program, it reduces the missed appointments because kids are in school, so they're not facing the barriers to getting to an appointment elsewhere in the community. And they also have less missed classroom time, so you don't have all that transportation time to get to and from an appointment. So we've also tried to vary the schedule so that they're not always missing the same class. And we try to schedule the appointments around study halls and things of that sort. So we really do try to minimize the amount of missed classroom time. By co-locating in a school, we are able to increase our case management with the schools and provide any kind of additional support and working in a collaborative nature with the schools. And the one advantage that we didn't expect to see, but we certainly have seen in all 10 districts, is that students are self-referring to the program or they're referring peers to the program. So a very positive is that some of that stigma that we as adults face around mental health, we have not seen necessarily in the schools. Kids recognize that they have issues. Some of them are flying under the radar, and maybe people aren't picking up necessarily that they have issues, but they recognize that they have issues, and so they're self-referring to the program. In terms of the success of the program, we measure outcomes on all of our students, and we measure them in 2 major areas. One is certainly mental health. We want the kids to get better. So we measure their mental health, and we measure it from the therapist perspective as well as from the student and family's perspective. So based on a clinical assessment, is the student showing reduced symptoms, increased functioning? And then from the student and family perspective, are they feeling better about life? Are they achieving their treatment goals? Are their relationships better? And I won't read you all of the numbers. You can certainly see it in your handout. But roughly, we're seeing about 70% of a success rate with all of the students that we see. And that includes the students that are currently in the program. And our clinics, our providers are telling us that those are actually higher outcome results than they actually see in their community clinics. And we think that they're higher because we have fewer missed appointments and the therapy is on a more regular basis. We actually see our students once a week, sometimes even more frequently, as opposed to in a community clinic where they might only see the student every other week or one time a month. The other thing that's maybe unique to our program is that we also wanted to determine what was the benefit to the community having a school-based program. So we know that on an individual basis, the program is making a difference with kids. But what is it doing for the school district, for the community as a whole? And so we were very fortunate to have the University of Wisconsin-Madison do 2 cost-benefit analyses of the program. One was done in 2012, and it was based solely on data from the pilot program in the Menasha Joint School District. And then the second one was done 2 years later and looked at data from all of the 10 school districts that we serve. And what we found is that the benefit per student is roughly $50,000 to the school, to the community, in cost savings. So to the school, it's fewer truancy rates, fewer therapy or counseling that's done by the school personnel, things of that sort. To the community, it's reduced costs around social services, the criminal justice system, and certainly to the student, there's also reduced medical expenses. They're not having as frequent hospitalizations, doctor's appointments, and that sort of thing. In terms of the challenges that we face, certainly funding is going to be an issue. I'm sure that's a subject that you've heard all afternoon long. Currently, the program is funded through in-kind support from our 10 school districts. They provide us with space to provide the services as well as their staff to identify kids that are in need of mental health services and consider those barriers and then get parent consent so that they can make a referral to the program. But the program is heavily reliant on philanthropic dollars. We do bill insurance whenever possible. And about 40% of our revenue does come from insurance. And you might think that's pretty low, but there are a lot of families that don't have health insurance, or they maybe do have health insurance, but they have very high deductibles and very high copays and really can't afford to pay. So we really don't see that our revenue from private insurance is going to increase significantly. It does depend on the district, and we have certainly a good cross-section of districts within our service area. So some have a very low percentage of families that are low income, while others have a very high percentage. But right now we're averaging about 40%. So really, we're kind of precariously balancing on what I would call a two-legged stool. One that is supporting the program through insurance payment, and the other leg is supporting it through philanthropic dollars. As we look at the long-term sustainability of the program, while United Way is very committed to maintaining this program, and we really see the benefits of the program, the question is, can we maintain the same level of support, for many years to come? And in researching where school-based mental health has been the most successful, it's in those states where it's a public-private partnership. And I think in the Fox Cities, we've really managed to have a good start in that public-private partnership where United Way, local mental health agencies and school districts have worked very closely and very successfully together. But in the states where it's been very successful, Minnesota, Illinois, New York, there's also been that public component where the state has also provided funding. So we feel it's important to have philanthropic dollars because there are always going to be kids who can't afford to pay for services. There are always going to be components of a program that are not always going to be reimbursed by an insurance plan or Medicaid. So that philanthropic element is still very important, but we think a three-legged stool is certainly much more stable, in which we have charity as well as public support and insurance reimbursement.
Thank you, Mary. Now, Brenda and Marcy will talk a little bit about some of the specific efforts we're making at Menasha, in the Menasha schools.
The Menasha Joint School District Student Service Team includes counselors, social workers, and school psychologists, and we work together to implement programming and curriculum for all of the students in our district. We support students in creating and maintaining positive coping strategies for emotions and impulsivity that might take away from their well-being or their learning. Student assistant programming, or SAP groups, are run kindergarten through 12th grade. In small group settings facilitated by a student service team member, students explore and practice healthy strategies to learn how to appropriately manage emotions, including, but not limited to, grief, sadness, depression, anger, anxiety, grief from family divorce or change, or emotions stemming from having family members with substance issues. The groups run for 8 weeks and they meet once a week. The curriculum allows for the students to learn about these emotions, sense the emotions in themselves, and then practice healthy strategies to use when they are feeling that emotion. Student assistant program groups are requested by the students themselves, especially at the high school level, or the students are referred by parents and guardians and staff. The issue becomes the number of students who are requesting the group and the number of staff who can facilitate groups each semester. For example, at the high school this year, first semester, 172 students requested to be in an SAP group. With our staffing, we were able to run 4 groups, which equated to 34 students. We are also piloting an evidence-based curriculum, kindergarten through 12th grade, in the district, which works specifically at decreasing anxiety. The Coping CAT program is a cognitive behavioral therapy intervention that helps children recognize and analyze anxious feelings and develop strategies to cope with anxiety-provoking situations. The program focuses on 4 related components. 1, recognizing anxious feelings and physical reactions to anxiety. 2, clarifying feelings in anxiety-provoking situations. 3, developing a coping plan, for example, modifying anxious self-talk into coping self-talk, or determining what coping actions might be effective. And 4, evaluating performance and administrating self-reinforcement. By incorporating adaptive skills to prevent or reduce feelings of anxiety, a workbook is used to guide the child through consideration of previous behavior in situations in which the child felt anxious, as well as the development of expectations for future behavior in anxious situations. We are piloting this with individual students, small groups, and entire classrooms. The success of Coping CAT will be determined by the data we are collecting from each student pre- and post-group, including attendance, behavioral referrals, and academic success. Once again, staffing is limiting the number of students who are able to complete this curriculum. In grades 6 through 12, the Menasha Joint School District also implements the evidence-based SOS Signs of Suicide Prevention program to all students. We use this curriculum because it is proven to educate students about the relationship between depression and suicide and to teach them to act, acknowledge, care, and tell a trusted adult. Research has shown that students are more likely to talk to each other than an adult. So it's critical students know how to get the right people involved when someone is talking about hurting themselves or completing suicide. Every student takes a depression screener, and any student whose scores show concern are talked to and their parents or guardians are contacted. The education piece is critical, so all the students know what to do and where to report to when another student is telling them they are depressed or suicidal. The success of this program is twofold, including education and students who are in need and referred to outside care with physicians, therapists, or to the PASS program that you just heard about. I am one from a team of 5 at the high school, and each of us talked to 60 students who showed concern on their depression screener this year. A concern for our team is the high number of students and their families in need of mental health assistance, and the amount of time we can provide to them due to staffing.
So we chose to focus more on the higher level prevention kinds of things because we felt they were a little unique or different based versus some of the universal things that everybody's doing. We obviously have some of the same things happening universally with PBIS and ACEs and trauma-informed care, although those are 2 areas that are really on our agenda for next year to train all of our staff in the trauma side of things. We started with our focus on our highest need kids and our pupil services staff. As we look at our ongoing challenges, I think it was interesting your question about, the luck of having a social worker. We are truly blessed in Menasha because our board has maintained a reasonable sized pupil services staff, but I think you can see the enormous problem that there is when even a district who is fairly well staffed with pupil services, we have 3.8 psychologists, 4 social workers, and 10 counselors for our 8 buildings. It's still, when you look at the numbers, 1 psychologist is responsible for 947 kids. So even though compared to some of our colleagues that we heard today, it sounds like we have the right number of staff, but one person certainly can't really have their thumb on 947 kids' mental health needs. Obviously not all of those have needs, but you have to know the kids to know if the needs exist. Social work, same thing, 900 kids per person, multiple buildings, those kinds of things make it still challenging and ultimately a funding issue as far as, it isn't a lack of support on our district's Board of Education. They've not, they are very supportive, but there's just only so many dollars and choices have to be made when you look at those decisions. In addition to that, the PATH program has been a true blessing for us, but we service 2 out of our 8 schools. So we have a large number of kids and schools that don't have access to that service because we need to service the whole community, not just in Menasha. So again, although we have some of these things, there's just a need for greater access for families and kids. In addition to that, I think other people have already talked about the public awareness and the stigma. We don't see it in our schools and in our classrooms, but we still have parents that have significant issues with just having the conversation about their child's mental health needs. And sometimes if you can do that in the safety of the school, we're more successful than we have been in trying to get parents to go other places to talk about those issues or to get the help that they need. In addition to that, I would say, although we've worked around it, in the event that you're ever in a position to be able to address some of the licensing issues for school-based mental health and some of those kinds of things, anything we can do to ease that process for parents, as far as the amount of paperwork and the fact that schools have to be a licensed site now and some of those kinds of things just created more barriers and more steps that parents have to go through. And quite frankly, in most cases, just getting the parent to the table to have these conversations is really what we want to have happen, but then to all of a sudden lay a pile of paperwork in front of them obviously makes that access a challenge. So just another area that wouldn't cost money, so I don't think you get that very often, but it would be another area that could really help us if that was a little more streamlined and not so daunting for parents. So I guess in conclusion from our portion, we ask that you consider to find a way to dedicate some funding to help build that 3-legged stool that we talked about in regards to the PATH program. I think all of us that have presented so far have really created a case where it is a community, school, state problem, and it can be solved, and I think we can treat kids if we all work together.
Thank you for having us and allowing us to share our stories, and we'd be happy to answer any questions.
Thank you very much. I think there's a bill I just saw out there that looks at this licensing for on-site. So I think that's sort of in the hopper. I don't know if it'll get done because we're not going to be around here that long, but there's some people that are looking at that. In fact, Representative Kitchens has that. Any questions? Just you and me. So
Yeah. I have a few questions about what came first, United Way going to the school district or the school district reaching out? How did United Way come to the Menasha School District?
We do a community assessment every 5 years. And in 2006,
the community assessment showed some pretty startling data around children's mental health. We saw that 25% of our kids had experienced depression within the past 30 days, and 14% reported that they had attempted suicide. And so it was the United Way volunteers who said, well, we fund a lot of mental health programs in the community, and it's done regardless of ability to pay because they're using our funding to support those kids. Why are they not getting the services that they need? So that's when we began to study the issue more closely and realized that there were a lot of barriers to care. And then we went to the Menasha Joint School District. Our office happens to be located in Menasha, and really the profile of Menasha is really based on the kind of students that we thought we would be targeting. Low-income families that probably were struggling and were not going to appointments in the community. So we approached the Menasha Joint School District, and they were very open, and they were wonderful to work with on the pilot.
So the United Way is that philanthropy leg of the three-legged stool.
Yes, we are, but we've also received tremendous support from our local community foundation as well as other grants. So we have acted sort of as the administrator of the program, but then also as the fiscal agent, and we have sought out other funding in addition to our own.
So as fiscal agent, then you do the billing and you go after the reimbursements?
No, the providers bill because they're the licensed agent. We are not a licensing
so it's
body.
the providers themselves.
Yes, they do the billing for the insurance, and then we provide them with grant funding to cover those students that don't have reimbursement, and also to pick up the cost of other kinds of activity that might not be reimbursable.
Okay, there's the key. So you provide them with funding for those students who don't have insurance.
Correct.
So it's not a disincentive for them. They'll come in and they know they're going to get paid.
Yes.
Because in school districts that I've been working with, they can't get the providers to come into the schools. Number one, because now they have to have an office, and they can't do that. And number two, they're going to say, we can't make it work. If we're going to have to depend on insurance and Medicaid, we can't make it work.
Correct.
Okay, thank you.
The other 9 schools, do they pay you anything for you coming in to do this per child, or?
No, it's all in-kind support from the
Okay,
schools.
so you just sort of handle this thing for them?
Yes.
Okay.
Yes.
Good.
And, not.
Do you want to expand?
Not to.
You got one statewide. Yeah.
Not to tout our own horn, but one of the things that we found is it's been a real advantage working with a consortium of providers, not just one provider, because it's a tremendous burden, and not every therapist feels comfortable doing school-based mental health. I think one of the other school districts mentioned that many of the cases are pretty intensive. Multiple diagnoses, particularly at the high school level. These are kids that should have had therapy years ago and didn't have it. And so this is a kind of a unique niche, and so not every therapist in every agency feels comfortable doing school-based mental health. So we have found it to be a real advantage working with multiple providers. And when you have multiple providers, you really need to have that unbiased organization sort of helping to manage things, and that's really the role that we've played in that.
LRB 2841-1.
That's it.
Deadline to sign on January 8th. Good. Let's rush it through.
It's got to get introduced first. Thank you very much for everything you're doing. We appreciate you coming down.
Up next is Jim Hasley from the Wisconsin School Psychologists Association.
Welcome, Jim.
Thank you very much. I appreciate the opportunity to present to the committee. So, as mentioned, I'm Jim Hasley. I'm the chair of the Mental Health Committee for the Wisconsin School Psychologists Association. I'm also an assistant director of student services here in the Madison Metropolitan School District. I'm speaking strictly from the WISPA perspective at this point. And I hope to take a little bit different take on it. Not sharing a story of a specific school district, but rather thinking about it more broadly from the perspective of pupil services providers, within school. And Senator Bewley mentioned that...
We're sorry. Your conference is ending now. Please hang up.
It's not ending. We're still going.
Senator Bewley mentioned that incident where another legislator had stated that your job is to do math and science and reading. And the reality is that part of the job of schools is to, and I think for everybody in the state, is to help children to grow up to be adults who are contributing members of society. And so if we're not taking care of the social emotional needs of students, we're not going to reach that goal, even if a student can do math and if a student can read. So given what we've heard today, you've heard a lot of numbers, a lot of information about the prevalence of mental health challenges with kids. I want to take a little bit different take on it. I want to think about it as a continuum, because mental health really occurs on a continuum from mental illness to mental health or psychological wellness. And so it's been documented time and again that mental wellness has a positive relationship to school achievement. Again, going back to that point that if a child or an adolescent is to learn math or to continue progressing at reading, they need to be mentally healthy in order to optimize their academic skills, their performance, and their ability to contribute to society when they finish their schooling. To reach that, or rather, conversely, mental illness has an inverse relationship to school achievement. So any school mental health initiative has to include services, supports, and interventions that not only address mental illness or have treatments for those mental illnesses, but also assist children and youth to develop the skills and virtues that enable them to thrive. So some of the things that I think are really critical to this is that we've heard about positive behavior interventions and supports. It's critical that those initiatives continue to be supported and coupled with instruction in the development of social emotional learning skills. We also know that some of the prevention that we need to do means that we have to integrate practices that support the development of skills to cope with life's challenges. Okay, so being mentally well isn't just the absence of mental illness. It's also having the skills to cope with the challenges that come before you. Absent those those skills, Senator Olson, you mentioned before, is this biological or is this environmental? Probably the most challenging cases you would say answer yes to that, where it's both having a biological disorder as well as lacking the coping skills to cope. But absent a biological disorder, if someone was challenged significantly, they also may not be able to cope optimally. And so they may be a person that has a mental health challenge because of the degree of challenges they're facing. So there are a number of things that have also been mentioned, including trauma-informed schools and schooling. Responsive classrooms is an approach, and developmental designs are approaches that help classrooms be more psychologically safe for students, set up conditions for them to make progress academically. The other thing that's important to recognize is that the professionals in the schools have the skills that are necessary to meet the mental health needs of the vast majority of kids. If we think about those mental health on that broad continuum, are they treatment providers? No, they're not treatment providers. But can they help those kids who are challenged significantly by their environments and by the life circumstances that they're facing? Absolutely, they can. You mentioned, I appreciate very much that you brought this topic up to begin with, that we can even come before you and testify. The School Psych Association was hearing similar feedback from our members somewhere around 6 or 7 years ago, and in response to that, we put together a professional development training track leading to a mental health certificate. And so at each one of the conferences that occurs twice per year, there's anywhere in the neighborhood of 13 to 15 hours of training for school psychologists psychologists and other professionals on mental health and how to help intervene or how to intervene to help children do better in school. So when it comes down to it, the things that are really important, we believe, is that, again, those services and supports need to be in place for all students, both universally as well as services for the children, the adolescents, the youth who have distinct mental health challenges or who've received a diagnosis of a mental disorder. One of the things that we also need to think about is there are a lot of kids in schools who are struggling but don't have a diagnosed mental disorder. In those situations, they may or may not be able to receive services within the community or even in a school-based mental health setting, and those would be individuals who school-based pupil services professionals in the form of school psychologists, school social workers, school counselors would be assisting them to be more functional within school. So in thinking of the continuum and moving from services and educational supports for all students all the way to treatments, we've got to think about, oh, I'm sorry, let me get on to the next page. Another aspect of this is that for kids and adolescents who require treatment for mental disorders, the collaboration, whether it's in a school-based setting or in a community mental health setting, is absolutely critical between community providers and school personnel. You've heard that mentioned already today. The other thing that we need to consider is collaboration with parents as well, because they're going to be critical to help that child function better both in school and in the community in general. One of the things that, in looking through and preparing for this, is the the state's Office of Children's Mental Health has talked about a couple of things, and one of them being that this whole continuum is thought about from their perspective as kind of a public health approach, where we're looking at prevention as well as intervention as opposed to a primarily clinical focus. So part of what I wanted to convey today is that mental health sometimes is talked about very narrowly, and it's actually talking about mental illness. And so that whole public health perspective really expands it in the way that I've talked about, where to create psychologically well and mentally healthy children and adolescents who can contribute to society, we need to have the prevention services in place and interventions in place for kids that are showing risk for mental disorders, as well as treatment for kids that have mental disorders. The other thing from the Office of Children's Mental Health report that I think is really important is thinking about kids who have experienced adverse events in their lives, that they're using the best adaptations that they can. So is it truly a mental illness, or are they really only adapting to the world in the best way that they can? And our focus is really having to be on helping them develop skills to adapt in a better way and to be more productive and be more successful in school. So to work on this, you've heard it before today that funding is an issue. The ratios that Mr. Fernand put up are certainly indicative of the fact that they're pretty high when you're talking about a ratio of 1,000 to 1 for school psychologists and similar ratios with other pupil services professionals. That's going to be difficult to serve the students who need to be served within the schools. I firmly believe that to the extent that we can help those students who are having difficulty, we can prevent students progressing to the point where they do have a mental disorder and they do need more intensive and expensive treatment services. So I think one of the ways to do it is to increase the funding available for special education services. Now, you started off today, Senator Olson, by talking about that a lot of the children that schools are struggling with don't have IEPs, so they don't have identified disabilities. One way that could also be addressed would be to consider expanding MA funding or eligibility for MA funding beyond students with disabilities and beyond the momentary time sampling that's in schools at this point. We've also heard some conversation around the counselors, I forget which school district they were from, talking about that they're not therapists. We heard from the La Crosse people about the school-based personnel, the pupil services personnel providing services that are mental health services to those children. When we look at some federal legislation ranging from No Child Left Behind to the Affordable Care Act, right up to the latest act with Every Student Succeeds, they define school-based mental health providers as state licensed or certified school counselor, school psychologist, social worker, or other state licensed or certified mental health professionals qualified under state law to provide the services. Where that's significant for us is that, if I understand it correctly, our state only allows individuals to be considered as school-based mental health providers formally if it's a license under the Department of Safety and Professional Services. This is a little bit broader definition that we could consider, you could consider whether or not it's reasonable to expand that definition to include professionals who are certified through DPI as opposed to only under Safety and Professional Services. So, again, just in general, my agenda today was to really think in terms of broadly defining what mental health issues and concerns are, and to really think in terms of what we can do to help prevent the progress of some kids into having a mental disorder, as well as helping to promote some really important initiatives that have already started in the state around school-based mental health services. So.
Very good. Thank you very much.
Thank you.
Senator, any questions? Okay. We appreciate you sticking with us, and hopefully it's been an informative day.
It's been a very informative
I know it has for us. And I know the chairs are empty, guys, but they're having to testify and be other committees, so it's just the way it turned out. But I think we're on tape for posterity, so make sure your makeup is good, now that I tell you that.
Up next is Randy Hughes from CESA 6.
And Debbie. That's all right. Come on up, Debbie.
You don't want two more, do you?
Good afternoon, ladies and gentlemen of the committee. My name is Randy Hughes, and I am the coordinator of mental health services for CESA 6. And beside me is Debbie Chisnell, who is our executive coordinator for our director for special education at CESA 6. We would like to thank you for this opportunity to share with you some very important information about the issue that is having, I think, probably the deepest impact in our state concerning and on our schools and families across the state of Wisconsin, and that is mental illness / mental health. I know you heard some of these facts earlier, but I'd just like to take a few minutes to repeat them. Approximately 20% of our youth, 13 to 18 years of age, experience severe mental disorders in a given year. For ages 8 to 15, that estimate is 13%. 70% of our youth and juvenile justice systems in Wisconsin have at least one mental health condition, and at least 20% live with a severe mental illness. And suicide is the 10th leading cause of death in the U.S., more common than homicide. And the third leading cause of death for ages 15 to 24 years, more than 90% of those who die by suicide had one or more mental disorders. And I would just remind you that on the back of your handout is the resources for that data. Several years ago in the Fox Valley, there was a mental health summit held. And at that summit, it brought together mental health professionals, mental health providers, family physicians, and school districts across the valley to address the concerns of a rising number of students with mental health needs. From that summit came many, many different things, but a few of them that I think were most important that recognized for as a school district. That one, school personnel, teachers, and even pupil service staff are not necessarily trained in mental illness issues. We can only go so far, which was very well stated earlier. There are a lack of programs and placement opportunities for students within our schools. That became very, very clear. My previous position before coming to CESA 6, I was the Special Ed Director and Pupil Services Director for Kaukauna Area School District. One of the most difficult things we had in that district, not only did we suffer through a period of 2 or 3 years, 4 years of 7 suicides, we recognized that we were struggling to find places where we could put students who were struggling with severe disability, severe mental illnesses. And because of that lack of placement, we ended up sometimes even identifying them in a special ed way so that we could provide services that way, just to get them some type of services that we had. Students with mental illness are often bullied and cause serious behavior within our school districts. And I think that was some of the things that we struggle with the most. 3 years of planning with medical affiliations, Affinity and Catalpa Health. And Catalpa Health is the conglomerate of 3 hospitals, St. Elizabeth's Children's Hospital and Theta Care in the Valley. And we were trying to find a solution to some of these answers. We were finally able to form a partnership with Catalpa Health for a day treatment program. That program consists of a half-day, level 2 mental illness day treatment program. The other half of the day was spent for education. The importance of that is that there are lots of places in northeast Wisconsin where we can send students for for help, but the problem is that they don't get the education there. And so when they return to the school district, they're often very far behind with their peers. And then what happens is that within 3 or 4 weeks, they're back in that deep hole again, suffering through that anxiety and the depression they're having, trying to get caught up in their educational pieces. So this half-day education and this half-day treatment was hopefully going to release that, and it's going to provide both of those things so that when the students came back to the school, they could be successful. We had 2 tracks of students, one 7th through 9th grade and the other 10th through 12th grade. And one of the importance of things too is that we recognize that when kids go through treatment, we had an example of a student who was in 9th grade who went through a treatment program in the morning. Then in the afternoon, while he was in the educational classes, he froze. He froze at his computer. And as our teacher approached him, he began to cry. He just couldn't stop crying. The nice thing that we're able to do is because the treatment center is right there, we were able to call his case manager. Case manager came down, took the student out. 20 minutes later, the student came back to class and was able to resume his studies and finished out the day perfectly. That's an example of this partnership and how this partnership can work to help students not only in their mental illness, but also in their schools. It's a program to provide coping skills to help deal with their mental illness as well as education classes while they're in that treatment. And it focuses on that successful transition back to the public school to avoid an immediate reoccurrence that may take place. Unfortunately, even with 2 years of planning, there were still some unforeseen pitfalls that we weren't aware of and that came upon us. One, medical staff and educational staff speak 2 different languages. There are 3 sets of laws to follow. The medical law obviously has to follow the HIPAA rules, and the educational law follows FERPA. And if the student's involved in special ed, we have to follow the IDA rules. And so those rules, those laws conflicted sometimes and caused some of those issues and really helped to pronounce the amount of issues we were having in the languages that we spoke. We found that based on accepted insurance. And if the child doesn't have insurance, then they don't necessarily have to treat them. We also found that the students that were being being referred weren't always accepted, and that we found later that they weren't accepted because they had severe behavioral issues. Schools have tight budgets, and we have no options but to provide FAPE in the best possible way. And so schools are left with all of the opportunities that they can have, but we must provide a free and appropriate education for all students. It doesn't matter what they have or don't have that might be a part of that. CISA has invested $150,000, and we're still struggling to support the students that we want to help. The students meeting the criteria for the day treatment program was not what we expected. Students that are accepted are the type that are withdrawn and falling underneath the educational radar with no behavioral challenges. And therefore, schools can address these students in a variety of ways on their own. We know that mental illness affects students differently. Sometimes it's inward, and those students have those difficulties going. And so what happens oftentimes is like the example I shared earlier. They go through treatment, and then they go back to the schools. And there are things that are taking place at the schools, whether it's bullying, whether it's the anxiety, whether it's depression, whether it's the whole idea of just getting through their classes because they missed the morning of school. How do they make that up? And how do they stay on track for graduation? These are good students. These are students who have this inward part that may even be in advanced courses. And so we don't necessarily see the things at the school, but when they go home and they deal with that anxiety and depression, we often find that maybe they're self-harming or they're getting into a deeper depression. And so when they come back to the next day of day treatment, they may be 1 or 2 days, taking 2 steps back rather than keeping that 2 steps forward. Students we thought that would meet the criteria have behavior issues due to the mental illness, and those students are not accepted currently in the program we are working. And that's a struggle. That's the students at the schools where there are severe mental issues and they're acting out in a way that's unsafe for them, unsafe for other students, unsafe for the staff, and the schools are looking for places where they can send those students to get the help in their mental illness and also receive the education they need in order to stay up in the education and on track for graduation. Our next steps are, we're not going to give up. We recognize that our schools in the CISA district has a need, and we want to be able to service that need and help our schools. We know that these students need support in order to be successful. And what we are going to do and how we're going to do that is we're still in a design phase. We're still trying to work through that. But we will work to provide training to school personnel to help them understand and to be able to work with students with mental illness and understand the effects that it has on students both inwardly and outwardly. Keeping the student in the classroom is of the most importance. When students are taken out of the classroom, that is a loss of educational time. Those students are no longer being taught the classes that they're being dismissed from. So whether it's a in-school suspension or whether it's a out-of-school suspension, the students have lost educational time. That is lost monies, that is lost resources, and that hurts these students with these mental illness and only compounds the fact and the illnesses that they have. We are working on a second iteration of the Student Success Center to meet the students' needs. We're not sure what that's going to look like yet or how it will be funded, but we are committed as an organization, CISA 6, to continue to work toward helping students both inwardly and outwardly that are struggling with mental illness. This is the program that we've worked on. This is the program, the partnership that we had with Kahl. And we're hoping to continue that partnership as well as look forward to helping these other students with behavioral issues so we can help them be successful in their school experience. Thank you so much for this opportunity to share with you.
David, you want to say anything? Let me ask you a couple questions.
Yes.
This really shows my ignorance. What is level 2 medical treatment?
A level 2 medical treatment is it's the DHS section 40. And
Oh yeah, that's what I thought it was.
yeah, and so then, so basically it has very stringent requirements upon what's expected. There's a level 1, which is basically, they may have a therapist working with them outside, so they come in back and forth for appointments. A level 2 is where it's a day treatment program. They have to have so many hours of psychology, so many hours of psychiatrist therapy. They have a case manager. There's an occupational therapist present. So they have so many hours per week that these students must be met in both group and an individual and family group time as well.
We heard from Menasha where they're, doing it in Menasha and 9 other school districts where they're going to the school to work with those children. Are the kids you're getting at a more needy than what there's a couple levels I'm thinking.
Yeah.
Theirs does one thing, you're taking harder cases? Would
I
that be?
think they're more severe mentally ill students. These are students that are coming out of St. E's where they've had residential treatment, but they're not ready yet to go back to school or have that outpatient therapist work with them. And it's also the students that have outpatient therapy but are still struggling in their families, in their homes, and in the schools, and so they get referred to the day treatment program as well.
I think as a CISA, we're looked to as that next level of services. As you heard from the school districts today, they're trying to do the preventative. They're trying to make sure they put in trauma-informed care with their school staff, and they can do that within their schools. And then when they get ramped up to that next level of student, who the behaviors come with, a little bit like William, then they come to the CISA to look for that support. So that's what this program was supposed to look like. And then we still didn't get to those students. We still got to a level 2 student who the school districts can find a way, because they probably are the higher academic students but have anxiety and depression, so they're not really causing trouble. So they can be serviced in the school in a neutral site, in the counselor's office, through some type of Odyssey-ware, internet-based education. The next step up are those kids that we can't keep in the schools, even though that's where they're landing, because that's what we have left. It's the schools. Meritor's saying can't do it. The Catalpa's saying can't do it. So they go back to the school. So that's where we're going now, is the districts, our 42 districts are saying, what are you going to do to help us? How can you help us get to that next level? And that's what we're working for. But as you can see, we have more work to do to get to that level.
What does it cost the school district to deal, because the insurance, hopefully if there's insurance,
Right.
pays the treatment half.
Right. For a school district, it's $125 a day for 4 hours of education to come to the day school. It's about $32 an hour for education for those students that come into the.
So if there is no insurance to deal with the treatment end of it,
They don't get to come.
they don't get to come.
No.
Where like Menasha, they take care of them because United Way helps deal with that. So if you don't have insurance, you're out of luck.
Right. I was at Kakana and United Way was there with their PATH program, and that is just a wonderful program. I mean, what it does for our students, and we had several students that were involved in that. But there just isn't, if the student doesn't have insurance, then Catalpa helped me look at what they call Catalpa Cares for an additional few weeks, but we have seen students dismissed because the insurance has ran out. And Catalpa will say, we're not dismissing you because you quote-unquote graduated. We're dismissing you because we don't have the funding sources to provide care.
And as educators, we don't get that choice.
Right.
They're our kids, and we need to continue to educate them. We just have to find the right way.
How many students are in this program?
We have had a total of 6 students in September. Our struggle is as Debbie mentioned, the students that are coming into Catalpa are high-achieving students for the most part. They're not behaviorally disordered, and so they're able to achieve. And once they're in Catalpa, and many of them are not even IEP students; they're regular ed students. So we call the school, and we had the conversation of the school bringing the student there, but most of the time the school is denying sending the student to the school section because of the fact that, one, it's a more restrictive environment for one thing, and they got to hold to that by law, but also it's just they have the sources to work with the student who is not behaviorally causing a problem. So there still is a question about how do they make up for the lost time, those types of things, keeping them on track. But schools generally have the resources and the things to do that. Schools can't afford to send a regular ed student for $125 a day. I don't think they can afford to send a student for $50 a day if in fact they know themselves that they can work with that particular student.
And so what you're telling me, I think, too, is that, correct me if I'm wrong, is kids that have behavioral problems, Catalpa won't take.
Correct.
Which the schools
Right.
can't handle.
Catalpa has made the decision that, in order to be able to really focus on the mental illness, they can't have to work through the behaviors to get to that point. So they're taking this particular level 2 student.
So where do those children wind up?
Well,
The behavioral students that have
Is that at your
underlying
alternative
mental health.
schools, Debbie?
Our alternative schools, our EBD, emotionally behavioral disordered schools are getting a lot of them, and the joke at our CISA is you can bribe an EBD kid with Mountain Dew to get something accomplished because they have a will, a choice. A mental health student you can't bribe with Mountain Dew. They're not doing it to be inappropriate or to get your goat. They're doing it because it's within them and it's a disease. I mean, if you have cancer, you get support. If you have a mental illness, you have to figure it out.
So how many students do you think we have like that there's no place for them?
I can only speak to my time as a director of special ed in Kaukauna, and I can tell you that I had students from kindergarten all the way through 12th grade that had such behaviors and mental illness disorders that we could not find places for them. And so oftentimes I had quite a few students that I would send to CESA 6 alternative school, or there are other placements for them, but the problem is that you never got the educational part. So when they did come back, they were so far behind educationally that they become so obsessed and depressed and full of anxiety because they can't get caught back up, and before long they're back in that deep black hole and trying to climb out of it, and there's that reoccurrence. And that was the reason why when I came to CESA and we started working with Catalpa, we really wanted to develop a program that would have a more successful transition. So when the students went back, they were ready to go back mentally. They were also ready to go back, and they could be at the same place as their peers and be able to move forward and not have all that coming down upon them. That was our goal, and it still is our goal.
Sort of like suspending a kid and expecting them to come back to school and be up to date.
Right. We've had 2 students who have graduated from Catalpa Health and that were part of the educational program, and they've had successful transitions back. So we're excited about that. We know that it works. It's just the struggle, and I understand the struggle of the schools because of the type of students they are. They can't afford the money to spend to send them to, $125 a day for.
Right, because they get no special ed money for those kids.
That's right. There's no, they get what's given to them for the whole year for each pupil, 8,000 to 9,000, whatever that is, and then that's what they get to spend. So if you're spending that on one student generally a stay at Catalpa is anywhere from 8 to 12 weeks.
Senator Bewley.
Well, first of all, I want to thank you for doing the compassionate thing, because if I'm understanding this correctly, these are kids who are probably chronically mentally ill and are going to get to a place where they're going to develop the right meds, the right coping mechanisms, the right tricks to be able to function, and they're going to go back to, and they're going to be okay. They may need to go back, but they are probably chronically mentally ill. It's difficult. I guess it's hard because I know that in many school districts, it's cheaper to label them as learning disabled in some way, because then they stay, you move them along, and it doesn't cost the school district as much as $125 a day. That's a lot of money. And you're really doing a very compassionate thing, because this is medical care that we would have hoped they'd be getting because they have a medical condition, but they're not treated that way. So that's very unique. I don't know of any other school district that has something like that is treating truly medically, mentally ill students in that way. But what about those behavioral ones who could be both mentally ill or what, and they're back banging their head underneath somebody's desk again?
And that's why we're on the second iteration. We know
Right.
after this year, from September until now in January, we are helping some, which is wonderful and great for those 6 students, but we have more than a handful who need something different. They need to be able to be referred, qualify, and get both mental health treatment and the education at the same time.
Are you able to keep them in school? Are you able to have them not fall to truancy, not fall to all of a sudden they disappear and you don't know where they go, are you able to hold on to them and keep them there? I know that there's not much you can do, but I fear so much for them that,
Students who are in treatment are staying.
right,
The students that aren't receiving treatment are our truancy and our dropout kids.
they're the most vulnerable. Okay, thank you.
Questions? If not, thank you very much for
Thank you for this.
coming down and hang in there. And you got a tough road to hoe, but
We're not giving up.
We're not going
that's what I like to hear.
We're not going to give up. Thank you.
Up next is Linda Hall and Scott Strong.
Welcome and thank you. Thanks for sticking around.
Well, it's been a long day for you, too.
That's why we're here.
See if I can make this equipment work.
You've done that before, I can see that.
Okay, good. Well, thank you, Chairman Olson and members of the committee. And I appreciate that you're having this hearing and your interest in this issue. My name is Linda Hall. I'm the Executive Director of WAFCA. We are an association of agencies and leaders in human services and support for families and children. We represent over 50 leaders in child and family serving agencies, and we advocate for more than 250,000 individuals and families each year. You may ask why we care about schools, services to kids in schools. More than half of our members are involved in at least one school and are daily getting requests for more involvement. So this is something that is very important to our members. With me today is our board member from WAFCA, Scott Strong, who is also Executive Director of Community Partnerships, which is a community-based agency specializing in early childhood, home visiting, wraparound and mental health services for children, young adults, and families. And we want to focus our remarks around expanding school-based mental health services to really really focus on the things that our members are doing in collaboration with schools to provide additional services to children at schools. And I would say that we have members who have been involved in the PATH program, which you heard from today. Lutheran Social Services is a member that's been involved in a number of schools. I think we have members who are involved in schools in all of your districts, and finding great success with kids, but there are also tremendous problems in terms of keeping these programs going, and financial sustainability is something that we're going to want to talk with you about. So we also have the challenge of being at the end of the day of having a lot of what we were planning to say was said by others, and it seems like that we have agreement on the facts around this about what expanded school-based mental health services are and what the facts are in terms of how many kids need help. But I just want to emphasize that what we're talking about, our interest is in bringing professionals from our agencies into the schools to help when children have mental health challenges that are beyond the level of what the school support staff can deal with, and to work collaboratively with the school staff in terms of finding ways to help the children and to make everything in the classroom go better. So this is some of the statistics you've heard today about why children are needing help with mental health services. I think that, when I think about what the problems are and how it relates to kids trying to get through the school days, they have a different things that are happening with them because of their mental illness. They're having racing thoughts. They're not able to focus on their work. And these symptoms create barriers for them, and they create problems in the classroom. We talked, you heard already today that most kids who access mental health services are doing it when they're able to get it through school because those barriers are gone. The problems of getting to an appointment, and it's just, and they also, I think, often feel more comfortable doing it at school with the people there that they know. You heard from the PATH program, and you know, we have I'm sorry, what I meant to do in the last slide was just really to emphasize that at the national level, we know that that children need assistance and that they're getting it through schools. We know that nationally. What we know because of the PATH program, we know that in Wisconsin that this is working is because they have had such a tremendous success. They are really a model program that have done a great job of connecting with kids, collaborating with a number of providers, all the folks that it needs to make a good program. And you can see that it's working when you look at some of the statistics. Most kids that are in the program, they have reduced symptoms. They are getting better academically, and they're graduating. All important things. And so we know in Wisconsin that this works. What I'd like to take a moment to share a couple of stories that our members offered to up in terms of some of the things they've been able to do with kids. And these stories both come from children who are in the PATH program. Just to give you a flavor of some of the obstacles that children are facing and how they're able to overcome them. There's one 16-year-old junior at a high school who is having a meltdown, and the teacher went up to her and said, you know, is trying to figure out what's going on with her. Finally finds out that she's in crisis because of something that's happening out on Facebook. She's feeling attacked. She's really involved with that. I think that's something that we see a lot of kids are, but she just can't get over it. And so the teacher takes her to the social worker, and then eventually they make connections with the therapist, and the therapist starts working with her on working on her self-esteem and having her think about what her engagement is with people on Facebook and how she might want to modify some of her behaviors in order to be more settled and to actually become more self-confident. After some time in working with her, she was able to do that. This girl who actually had been hospitalized and on medications, she had threatened suicide a couple times. After some work with a therapist, she actually was able to settle out, things got better. She's now participating in extracurricular activities at school. She's part of the chorus. She's got a boyfriend, and they're not sexually active, and she's getting good grades, and she's on her way to college. So important things. Another example is a young male who the therapist was working with during freshman and sophomore year, and he couldn't concentrate. He couldn't focus enough on schoolwork, and he couldn't focus enough on his homework. And he didn't want to take medication. He wanted to do something else to address this problem. And so the therapist worked with, she kept trying different strategies. She finally found a strategy where he focuses on 3 blue things in the room. After he counts up the 3 blue things, he looks back at the teacher. And that works in his head, helps him to refocus. And he has a similar activity that he does at home. So at night, he can get focused back on his homework, and he can get it done. This young man also now has had improved grades. His GPA went from a 2.2 up to a 3.2 within a semester and a half. And he now is planning to go to college. So we know that it works. there have been plenty of discussion this morning about why do we want to saddle school with more activities around these non-academic activities. But the reality is that it works. Part of the reason it works is because kids are there. This is where they're functioning. This is where they need help in functioning. It's less time out of class for them. And they're also able then to work with a professional who understands the school system and understands the community that they're living in school, which is important for them to practice new strategies to overcome the issues that they're having. The PATH program has a lot of good data, as was already mentioned. The La Follette School of Public Affairs has done some very in-depth analysis of the program, and it shows that schools work better. There's less time spent on truancy, less time spent on behavior problems, and it also saves school money. Even in terms of short-term benefits, they showed over one of the periods that they studied that $159,000 was saved because children were functioning better in the classrooms. And then it also shows the long-term benefits of the PATH program. The amount of $50,000 per student in the program over their lifetime, there's that much of a benefit. That also breaks out in you reach that $50,000 because these students who get help end up getting better jobs, they get more income, and they also are less likely to be involved in crime as adults, because we know that untreated mental illness with children leads to more problems when they grow up. But as was mentioned, it's a whole patchwork of funding that's keeping the United Way program going. And when we know that there are these kind of results that we can get from this kind of program, I think it's incumbent on us to create a sustainable stream of funding so that people can get down to work and just do the job of working with these kids and save the money over the long term. And so that is what we want to focus on. And this is the idea that we need sustainable funding has already played out in Wisconsin, because there was a program like the PATH program in Dodge County. It was in all the schools, in the whole Dodge County School District. All the schools in the county, they were all part of a program that did the same thing. And when the federal funding for their grant ran out, the mental health portion of what they were doing disappeared. And so now those schools don't have the therapists coming into the school anymore. So again, we know it works. We know it needs sustainable funding. So again, to talk about what you can do, it's really to focus on this issue of sustainable funding. We are part of a coalition that is advancing school-based mental health services, and has a legislative proposal that we've started to talk to folks about that has 3 components to it. One would be to require Medicaid to create a mental health consultation payment code. So you've heard today about how Medicaid will pay for direct therapy with a child, but it doesn't pay for the work that needs to be done to understand what that child needs, how to create the time that it takes to create the treatment plan, to do the coordination with the school to make sure that we're addressing the issues that the teachers are having with the youth. So mental health consultation payment code would help us to get paid to do that work. Our proposal also includes creating competitive grants so that schools that want to develop more of a school mental health program would have the funding to help do the things that you need to do in the school to do some training with teachers and create the culture that helps to support the work that needs to be done, the mental health treatment that needs to be done. And then the final piece is to say that we would like to have an increase to Medicaid to cover, we're not even asking for all of it, but to cover a greater share of the cost to provide mental health in schools. I think what Senator Bewley talked about, schools not being able to get providers to come in, it's important to understand that every time we go into a school to work with a child, we're losing money. To the extent that there is philanthropy available or there is a United Way that's contributing some money, that how much we lose may be a little bit less, but the reality is that we lose money every time we go into a school. Medicaid only pays about 40% of the cost to see that child, and again, doesn't pay for all that consultation piece. So there is a tremendous need. I think you're hearing from the schools that they want support, that teachers need the help. We need to make that possible. I also wanted to mention that there was talk earlier about the bill related to school certification of clinics. That's something that we are very interested in. We hope that you will consider being a sponsor of that bill. We also, another bill that is being circulated that's coming out of some of the effort around the Mental Health Reform Committee is a bill that would reduce prior authorization requirements under Medicaid, and it has a specific provision in it that would address day treatment and make it easier for us to develop day treatment programs. You may not know that day treatment programs like the one that was described by CISA 6, those kinds of programs have declined dramatically over the last few years because the paperwork to get a kid approved by Medicaid to provide that service is just so intense. And so we have another bill that we're interested in that would ease up some of that paperwork requirement, which would be of some help. So with that, I would like to turn this over to Scott, who is going to talk about the programs in Madison and where they are and where they're trying to get to.
Yeah, excuse me. Thanks, Linda, and thank you. And while Linda's loading up my quick PowerPoint, I just want to say that everything that you heard today is what we're seeing in Madison and Dane County as well. In my 30 years of doing this work, coming from a provider perspective, doing community-based mental health, we were at a point 25, 30 years ago that oftentimes the providers and the schools were pointing fingers at each other in terms of whose responsibility it is to serve these kids. We've come a long way with the development of systems of care for children's mental health, where we're partnering and collaborating with the schools and the providers, because it is a shared responsibility of our community. The schools, it is not their responsibility to fix broken legs and fix diabetes, and it's not their responsibility to fix mental illness. It's the providers in the community that have to work with them to respond to those needs. So what we have done in Madison, actually in the Madison School District, in working with them, a few years ago developed a mental health task force to take a look at this issue and what we can do better on behalf of students. So the model that I'll talk about today, and I'll go through this quickly because I know it's been a long day, is really to do an integrated behavioral health professionals in schools. And so instead of like a therapist that just comes in and leaves, the therapist actually there's an RFP that the school district puts out. Under this first year pilot, Catholic Charities is the provider, and we're one semester into the pilot so far. But essentially, the therapist comes into the schools, becomes an integrated part of their student services staff, and is working alongside with the school staff, which I think is a really great model. So the target population, as you would guess, students with intensive mental health needs. I talked about the collaborative partners. We're having it evaluated by the School of Social Work. We are currently working in 3 schools, 2 elementary schools and 1 middle school, and that seems to be where the greatest need is and where people really have recommended that we start. And it's an integrated mental health model. And what we're seeing, and Linda talked about this also, is that there's about 75% of the work is treatment, the direct work with the student. That's reimbursable through Medicaid and private insurance. And also that consultative piece, what we're finding from the school staff, pupil services staff, and that's the part that is the most beneficial, because the therapist actually being in the school can help the staff work on strategies that's going to help translate into the classroom. So what the student and the therapist are working on can now be translated into the classroom, and the teacher now is getting some skills to work with that student. And you heard that earlier from the Crosse district. It's really important for staff and teachers to understand mental illness so they can actually do more effective work with the students in the classroom. Basically, the goals: we want to improve social, emotional wellness. The staff, increase staff efficacy. That's the piece about helping the professional development of all the school staff understand what mental illness looks like and how you work effectively with a child in the school, so they can both achieve academically and socially. We want to obviously have it integrated in the schools, because that's where the better coordination occurs. You don't have to worry about all the different phone calls and leaving messages and playing phone tag with the therapists in the schools. If you're all in one location, it's much better coordinated. And then finally, to establish a continuity of care with families in the health system. So there are a lot of systems that are involved with children, and the more that we can coordinate this under one roof in the place that's most effective, the better off we are. There's a couple of things that we've noticed with regard to, I think there's one more in here, the principal's perspective. So these are just some highlights that a principal from one of the schools, or from a couple of the schools that are piloting this right now, have mentioned. They're seeing that their school staff are more invested. They are feeling like the staff are feeling like the school's better equipped to deal with students with mental health issues when there's actually a therapist in the school, because they know they can go to that person to say, I've noticed this in my classroom. Is this something that you're working on with a student? Are you working with a student on this particular issue? And what can I do in the classroom to help that? So they're seeing that they're feel more confident and more competent as a school to respond to these needs. They're seeing that there's more wraparound services, so the schools actually have a lot of services through their student services staff that they're doing with the students, but they haven't had that clinician in there. They have people that understand mental illness to some degree, but they're not clinicians. So having that clinician is that missing piece that they see. And then the finding that the barriers are greatly reduced. Oftentimes, school social workers are spending most of their time trying to get kids to a therapy appointment, whether it's through transportation, trying to make phone calls, etc. Having it under one roof has been really beneficial for them. I'm going to flip through these fairly quickly. This is just some little bit of data that we're seeing through the pilot. So currently, there's working with 42 kids through those 3 schools. Mostly 70% of them are men. They're boys. Mostly because I think we see externalized behaviors, but the pilot really is trying to get to those kids that have internalized behaviors, the ones that are isolating in the back of the classroom. We're seeing 3rd, 4th, and 5th grade is the area we're seeing most referrals come in. That's not a surprise to those that work in elementary schools. They're seeing that's where they're having a lot of mental health challenges. For the pilot that's actually in the middle school, they're seeing more 8th graders being referred. This just kind of describes, at least in our area, the housing issues and some of the poverty issues that we've talked about. This is an interesting slide. So 90% of the kids that are being served in this pilot, this is their first mental health treatment experience. And I think that's speaking to what you've heard earlier, where kids that have a mental health diagnosis or a mental health condition are not receiving services. So for whatever reason, these kids are not coming to the attention of outpatient therapy. But now that the services provided in the schools, the teachers can actually make that quick link. And the kids that have the highest need are now getting the services, whereas the barriers of transportation and other factors, parents' work, might be getting in the way of them getting to an outpatient appointment. Some of the barriers to access that we've seen, there's providers, reaching out to providers, work, transportation, family barriers, a variety of different things that we're noticing. We are working very closely with our local HMOs and commercial providers. Most of the kids in the program are connected to Medicaid. In our area, it's mostly managed care Medicaid. We have a little bit of commercial payment as well. But we've worked really closely before we started this pilot with the private commercial payers to make sure that they would do prior authorizations and pay for the service for the kids in the schools. That was a really key piece that we had to work out right away. And we will be evaluating the program. It's too early right now to tell what the outcomes are, but at least the anecdotal and preliminary data show that it's working. We've got kids that are being seen, kids that wouldn't normally being seen, and the school staff are feeling like it's been very productive and helpful. Taken to scale is something that we've been focused on since we did the mental health task force. Over the summer, we became aware of Wisconsin Partnership Grant. The school district pulled a few of us, the providers, and United Way and others together, and we wrote jointly for this grant. It's a 5-year grant. It was given to the school district. We plan to expand the mental health professionals in the school, in the Madison School District, and by the 5th year have a template and a manual of how to replicate this in other school districts. I co-chair a children's mental health collaborative in Dane County, and we are working very closely with our rural school districts as well, and they're chomping at the bit to have some of these professionals in the schools. So the goal is to actually get a model that's replicable and that we can easily translate into other school districts. So what we need, the grant funds are going to help with the coordination because that's not covered through Medicaid or insurance. The consultative piece we talked about, the grant is not going to cover the direct clinical work. That's being paid for through third-party reimbursement, and it's also covering the evaluation. We also have a systems framework trying to make some systems change, which is going to be helping us also. And I think the bottom line is what we're trying to, a couple more slides here, I think. Oh, there it is. What we really want to kind of focus right now is if we're going to take this to scale, it's got to be a blended funding model. It can't just be Medicaid. It can't be just philanthropy. It's got to be, we have to work really closely with our health insurers and health systems. And even in rural areas, there are health systems. And it's a benefit to them to have these students seen at the most appropriate place at the most appropriate time. And so what we've done is really begin engaging the conversations with our health providers and our commercial payers, as well as working with Linda to try to get higher reimbursement rates through Medicaid and some startup dollars to help school districts get this off the ground. But it's really going to take that if we want to have a model that is sustainable, both in rural areas as well as urban areas. So with that,
So, and just kind of to get back to the idea of what we're asking for in terms of legislative financial support, we're very much in the thought process of we need to take advantage of all the funding that's available. We need to take advantage of private insurance. We need to, work as effectively as we can. And we providers are willing to take on the work of doing the billing so that schools don't have to do it. So it's really a collaborative process that in order for us to get the most we can for kids in Wisconsin, we really need to fund sustainably. I'd be happy to answer any questions if you have.
Okay, thank you very much. Senator Risser.
Can you tell me something about this Community Partnership, Inc.? I don't know too much about it.
that's just our organization that I come from. We provide a lot of community-based services to, mostly with children with mental health conditions, providing wraparound services.
But I mean, is it 2 people or 5 people, or is it?
It's about 50 of us. There's about 50 staff that are doing those.
Statewide?
No, this is just Dane County, right, mostly. We provide home visiting programs, early childhood programs, adolescent wraparound mental health programs, and young adult mental health case management.
Does it cover the state, or is it just local?
Just local right now.
All right, thank you. All right.
Any other questions? Senator Bewley.
Okay, I'm going to ask you a very hard question, and it's going to be a hard question. You mentioned that you have 50 people with your organization right now, and you mentioned talking to school counselors and whatnot. And if you were to compare that with another school district, and I'm just going to pick one, that has no nonprofits like yours, no United Way coming in, no, nothing like that. One school nurse for 5 buildings, 3 counselors for 5 buildings, no social workers, no school psychologists. And the fact that if a kid came into the principal's office at any school in the state with a broken leg, like you mentioned, they'd get care. But if a kid went into one of the schools in Dane County, something would happen. If they had a mental health crisis, it would happen. If somebody went into the school district that I described, knowing that the resources were a fraction of what is in Dane County. Are the kids in Wisconsin getting an equal education statewide?
I can't,
You're not going to answer that, I know.
I'm not an educator, so I can't speak to that, but I would say, yeah, there's differences in terms of access and equity across the state in terms of what resources there are available. DPI is doing a fair amount of work on trying to address some of the issues in rural school districts, and I'm working on one of the subcommittees with them on what I would do is go into those, if it were me, go into those smaller districts and find out and try to develop a collaborative and find out who's available in those areas, but begin having the conversations. But you can't just expect it to happen without the conversation first.
No, I understand. The conversation's been going on for years. Okay. The providers are not there. Okay. I mean, you know how hard it is to go in because you lose money.
Right.
And the providers aren't, with the reimbursement rate that we have. The other thing that we have is we're right next to Minnesota, where the reimbursement rate is almost twice. Yep. We can't get providers. We have almost a crisis in Douglas County because of lack of providers. And I don't know what we're going to do, to be honest with you, because we don't have we have waiting lists for kids to get health services and mental health services. When I hear what you're talking about, I'm trying to gain positive ideas on what it is we can do, knowing the raw material that we have to work with. And it's tough, it's hard, but I appreciate what you're saying, and I'm grateful for being able to learn from you, so thank you.
Senator, we have members up in your part of the state who are very interested in doing more school-based work, but you can't, we are businesses, and you have to have some kind of margin. You can't lose on every service that you give, or you're not going to be around.
I know that, and I can't possibly begin to blame you. This is a funding problem. This is a reimbursement problem. And I understand fully what you're saying. So
what I'm suggesting is that if agencies knew that there was going to be a funding source there, that they would,
of course they would
invest in it.
Of course they would.
Our people want to help
I know
kids,
they do. I know they do.
We know that what kinds of trauma they've been through. We see, we've often working with, kids whose parents we've worked with. We know what can work.
Right.
We just need the resources to do it.
Right. Well, no, we have kids that, when they're in crisis, they end up calling 911, The parents do.
Or they self-medicate.
Or they self-medicate. Oh, yeah.
Which is a problem with a lot of the parents of the kids that we see behavioral issues with. The parents are self-medicating, and the kids are just coping, and their behavioral issues. Some of the stories that therapists share with me, you hear about what the kid was doing, and you just go. Then you hear what the kid's backstory is, what they're dealing with at home, and you go, oh my gosh, this kid is like a genius. That he's figured out how to do this behavior to kind of release some tension over what he's dealing with.
Right.
It's very troubling. It's hard to watch.
But thank you for what you do. Thank you.
Thank you very much for coming in and sharing what you're doing, and keep up the good work. Last person we have today is?
Phyllis Greenberger from Disability Rights Wisconsin.
And she's still here. And she's speaking from the parent advocate perspective, correct?
I do. Sure. So help me out so we can get started here. I have the PowerPoint for you guys. You can, is this one on? Okay. Got it. So my name is Phyllis Greenberger, and I'm from an agency called Disability Rights Wisconsin. And Disability Rights Wisconsin is a private nonprofit in Wisconsin that serves the whole state of Wisconsin for individuals with disabilities. What do I do to? Okay. Thank you. Okay, thanks. Okay, so and so we're part of federally funded programs, and there's one in every state, and we're the one in Wisconsin who serves people with disabilities and helps advocate for their needs. My name is Phyllis Greenberger, as I said, and I've been there for quite a while doing advocacy representing children and families. I usually represent kids in special education situations as well as children's mental health issues. So I work individually with families, I go to meetings with them, I help them get services, I help them work out issues in schools and special education, as well as have been on a number of statewide and local committees to improve services on a systems level. So I do both individual and systems work. And I'm going to skip some of my slides because it would just be repeating things that you've been hearing for the last several hours, though I really do appreciate you sticking around and giving me a chance to speak. So thank you for that. You've heard some of the why focus on mental health in schools. I have the same statistics as everybody else, so I'll skip over that. And it's challenging for mental health issues happen all the time. They are wherever kids spend a lot of time in schools. So schools, even though we'd like to have them maybe just providing academics and education, that's where students are. And so, as you've heard all day, they become de facto mental health providers. Juvenile justice has also become a de facto mental health provider. And just a story for you, I was working with a family, I got a call from a family who, it was a teenage boy who had been struggling for a long time, actually had been in the hospital once or twice to get services, was really struggling in school, lots of not going to school or going or leaving to go to school but not staying in class, struggling with issues. And the family was struggling to get services, and they were actually told to call the police because then maybe you would get in the juvenile justice system and then you'd get services, which to me is a very sad statement. So these are just some of the barriers you've heard to learning, and you just heard those from our last speaker, so I won't read them to you again. You can certainly look at the PowerPoint later. These are some of the issues: the truancy, chronic absences, higher discipline issues. So I want to talk about, I want to focus on a couple things that have just added a little bit to the story of what you've heard today. So trauma is also something that you've heard about. It's impacting students. There are some really good resources in terms of trauma-sensitive schools and some training. You've heard a little bit about that from people who are mostly gone, but some are still here today. I get the calls from schools like you're talking about, Senator, where they don't have a lot of resources. People call advocates when it's not going well. They don't call us when it's fabulous, of course. So I know that some of the stories I hear are just, that's what it is. Although you go to the school and the school is trying. They want to help, but they don't have the resources. I had so speaking of a student who had a trauma, a young individual, a little bit older than the student described earlier, but also elementary age, who parent found out after a period of time had been sexually abused by a trusted adult in their lives, and quickly tried to get support and services. Small rural area, struggled to get supports. The child was having meltdowns in school, running out of class, pushing other students. There was some aggression they were worried about. Definitely having that fight or flight response. Actually, there was a lot of talk about we'd rather he flee than fight because at least other kids aren't getting hurt then. But there's a safety issue if he flees out of school and he's a young child. So the parent was struggling to get resources. The school was actually looking at an alternative school and was struggling to figure out what to do. The child was sent home a number of times just because the school was super frustrated and they didn't know what to do. And so everybody was frustrated. Finally, Mom got some therapy 45 minutes away because it's a rural community. There was nothing closer by. And that therapist is working with the student who is doing much better. The school is, and things are getting better. I did some advocacy, helped them get some other resources. And the therapist, however, being 45 minutes away, has no way to pay to come to an IEP meeting or to come to school to help with services. Out of the goodness of that therapist's heart, she did participate on the phone for 35 or 40 minutes. She doesn't get paid for that time. It's a student on Medicaid, so as you've heard, there isn't reimbursement for that consultation time. But with that consultation, with that service, with the school continuing to work on things, with the parent and the school creating some better communication amongst them, this individual is also doing much better. So how do we do this? So positive behavior interventions and supports, you've heard some about this today. I'm not going to go into the details, but it's a very effective way of providing at a variety of levels supports for schools. We've got a really good system right now in Wisconsin. Positive behavioral intervention and supports. There's the DPI and the CISAs have a program that's really effective. A lot of schools have been trained. A lot of schools are doing a really good job at Tier 1, which is the level where all students are affected, and it teaches social and emotional skills to school and provides behavior training, social emotional skills, as well as behavior plans for like the whole school. So how do we as a school operate? But we need continued support to, I'm just going to get to those. What can you do? So we need continued support for positive behavior interventions and support so we can get it to all 3 tiers, because that is something that can be done in schools. It is for schools. And right now we have lots of schools at Tier 1. We need to continue that funding and continue that support so that we can get all schools trained in Tier 2 and Tier 3. And it takes training in Tier 1 and time before you're prepared really to do those other tiers. Secondly, exploring some options for schools with high poverty rates. You've heard about that today also, so that looking at class sizes and early elementary grades, it's hard to address trauma issues if you have a lot of students. It was hard, I mean, she even got teary, but dealing that one teacher who had a whole classroom of students and is trying very hard to deal with this one student who she cares a lot about and is trying to help, and it's very difficult. So, and that's particularly difficult in places with higher poverty rates and higher trauma rates. If we could just take some look at class size, that can help with the trauma issues, getting to know your students, and also learning to read at those early grades. I also wanted to, if you have any questions about this Medicaid reimbursement rate, it is something that our agency has been supporting, which is a reimbursement rate for consultation or collaboration. They do have it in Minnesota. It's fairly new. They've had it, I think just in the last year or two, they've been using it. They've been talking about it for a while. But it does allow for Medicaid billing for consultation earlier, where the parent would like the therapist to consult. But therapists are doing it anyway, but it's hard at that Medicaid reimbursement rate when the rate's already low for the session, and then they can't get paid for that additional time to collaborate. And then my last thing was already mentioned by our last speaker, which is funding competitive grants to get some sustainability to this expanded school-based mental health. So thank you for your time. I'm happy to answer any questions. I'm sorry for going so quickly, but I realized a lot
We're
of
sorry
what
it's
I
so
had,
late. We got a little late start.
What I had has been spoken about already.
Which is good, because everybody's on the same page.
Everybody's on the same page. And I'm happy to answer any questions now or at another time. People are welcome to contact me.
Got one question.
Sure.
The disability rights group deals with other disabilities besides mental health.
That's correct.
All physical disabilities and whatnot. What would you say the mental health, what percentage of your your activity is mental health as opposed to the other types of disabilities?
Well, it's hard for me to say because my focus is children and primarily children's mental health, but our two largest grants are for developmental disabilities and mental illness. So I'd say that probably 80% of our work is those two areas, developmental disabilities and mental illness, and then the other 20% probably physical and sensory issues. But our two largest grants are mental health and developmental disabilities. That's where we get the most calls.
And you get these grants from the federal government, pretty much? The grants?
Right, the grants I'm talking about are federal grants, and they're done, every state gets those, and it's done by, the governor appointed our agency, and it's done by population.
So really what you're doing is dispersing the federal grants, basically. You're using the federal grant, well, maybe you're not dispersing it.
No,
You're just
yeah.
using the federal grants to promote the...
To provide our advocacy, that's right.
Okay, thank you.
A good portion of our advocacy is funded through federal grants, if that's your question.
No, you answered. I was just curious.
Okay.
Thank you very much. I would like to thank the committee for being here, sticking around. This is an important issue, and we had the opportunity to see some shining stars, I think, in the state of Wisconsin, things that are good, that are happening, and they're still having issues and problems. And I'm sure, as Senator Bewley mentioned, there's a lot of schools that would love to be able to do the things that we heard from, Adams and Baraboo and La Crosse and Menasha, and aren't able to because of where their location is and things like this. And so I'm not sure exactly what we're going to do with all this information, but I think, and I'm glad Wisconsin Eye is here, because a lot of times public schools, get poked at because they're not doing what people think they should, and they're sort of an easy punching bag. But when you hear the issues that they're dealing with and the caring and concern that these people have for these children who aren't as easy to educate as other kids, and the challenge that they're facing, we can be really proud of the culture that we have in the state of Wisconsin, because without these staff members and these schools and these school boards and the compassion and caring, I don't know what would happen with these kids, because they don't have IEPs. There's no law that said, you have an IEP for some of them. It's just schools have decided, because of their moral imperative, that they need, as we heard today, we need to help them, because you can't teach them if they can't connect with the teacher and cause problems with other students. So we should be very proud of our state. We have a lot to do. Other states are doing work like this also, but one of the big things I think we need to continue to look at is how can we make sure that what's happening in these school districts is able to continue, and it happen across the state of Wisconsin, so it doesn't make any difference where you come from. You get services, and that's hard. It's hard. It's hard with broadband. It's hard with everything in the state, because location. In some places, if you're in the wrong location, you got problems. We've heard of parents moving to other communities because they couldn't get the services they needed in their community. And I hope that's not the norm, but I'm afraid it is. And if you're poor, you have no opportunity to move. You can't move to another community because you're place-bound, and that's just the way it is. And so I hope that the committee felt today was worthwhile. I hope the viewers on Wisconsin Eye who take the time to listen to this can understand what's going on in the state of Wisconsin, and that the challenge we have is not going away, and we continue to need to solve these issues, because I don't think that the issues are going to be minimized. I think they will be here for the long run, and I think it's our job to make sure that schools and communities have the ability to work together, because they have the desire. It's just, do they have the tools to get the job done? So Anyway, thank you. I think unless anybody wants to say anything, I think we'll adjourn.